Hello. Good morning. Welcome, everyone. Can we get seated? Can we let the people in the foyer know that we're starting? I think we're already running a few minutes behind, but hopefully we'll catch up. Can the people online, can we check if they can hear us? Because this is also being streamed online. Thank you. All good. So, yes, finally the day has come. Welcome, everyone. My name is, actually, one second. My screen, can this move? Can we load this one? No, the other one. Apologies. Oh, yes. So I hope we've scanned. Did we scan? Let's go back one. Yes. So that's the agenda. Please, can we scan that? Because there's no paper agenda today. And also we have the bios of all the lovely speakers today. So if you want to learn more about our speakers, you can also scan that. But if we scan the agenda, first of all. Okay. All good? So next slide. So my name is Dr. Olubukalaya Dele. I'm a consultant medical oncologist by day. Outside of my normal work, I am a fierce advocate for equity in cancer care. And I have been privileged to put this together today and be the event organizing committee lead. So I would like to thank everyone for being here today at Conway Hall, and thank you to those joining us online. I know how busy everybody's schedules are, and your presence means a lot. So this gathering really reflects everyone's shared commitment, because we know that improving outcomes for people and communities will continue to face barriers in cancer prevention and diagnosis is really important. I've always been involved with global oncology, having worked in 4 healthcare systems, Nigeria, Republic of Ireland, Canada, now in the UK. And I know that health inequalities might have different faces, but it affects everyone equally. So when I came to the UK in 2021, I couldn't but notice the stark inequalities I saw in my daily practice, and I knew I had to do something about it. So London Global Cancer Week is now in the 7th year running, and my first participation really was in 2023 when Susie Stanway was in the audience, asked me to chair one of the sessions that I was holding at the Royal Society of Medicine. And in that meeting, a friend of mine, Alfred Ginsburg, spoke about leveraging your superpower. And that spoke to me, and I knew that tackling inequalities is going to be where I have to leverage my superpower. And when Susie asked me to take over the Friday meeting organizing it, I thought it can only be about inequalities. So this was how Cancer Health Disparities was born. So in case everyone is wondering how this came about, this was it. Last year, our inaugural meeting took place at the House of Commons. And at that meeting, it was really about understanding inequalities and how we describe it as a wicked problem, And that meeting birthed a lot of networking and a lot of conversations. And we wanted to showcase that there are people who are actually doing things. And that's why today has been titled from awareness to action, because there are people doing things and we want to learn from them. And everyone who is speaking here today, either as a presentation or part of the panel, they are doing something about inequalities in cancer care. So we really want to learn about them. Really want to learn from them today. So one of the things we've also done this year is to open the doors to everyone. So today has been free for everyone to attend, because we know that addressing inequities in cancer care is everyone's business. And I wanted to make sure that all stakeholders were going to be available to attend. So I'm going to briefly walk you through the agenda and how it supports our mission for today. We're going to start our keynote with Dr. Kuver Singh, who is going to set the scene by examining the global burden of cancer disparities. And then we're going to have Dr. Habib Nakvi. So Habib was supposed to be here in person, but unfortunately he's developed a cold. So he's going to be presenting online, but he's still going to join us, thankfully. Habib has been instrumental in birthing vital changes in health inequalities in the UK, and it's no surprise that he and Nasser Turabi are on the HSG list of the 50 most influential Black, Asian, and minority ethnic people in health that was released last month. Nasser was supposed to be here as well. However, there is going to be an announcement from the National Screening Committee on Prostate Cancer today, and he has to be there in person. So we have John Shelton, who is the head of Cancer Intelligence CR UK, and he will be representing NASA. And he actually wrote the CR UK report that was released about socioeconomic factors. After the break, we're going to move to a part of the meeting that has become one of my joys, which is the Vanessa Moss Prize abstracts. This is an opportunity for early career researchers to show their work, because we know that this session would show us concrete examples of research, community projects, and clinical approaches that can be adapted. The abstracts presented are from the UK, India, Mexico, Saudi Arabia, Nigeria, and Canada. So it will introduce a lot of fresh ideas from around the world. In the afternoon, we're going to shift our focus to innovation. Dr. Dario Trimpani will speak on ensuring new treatments and technologies that should reach everyone. And then the first panel of the day would bring together leaders from the NHS Race and Health Observatory, CR UK, Novartis, AstraZeneca, and Prostate Cancer UK. And this is a rare opportunity to hear major organizations speak together about practical steps to move from awareness to real-world impact. And after the launch, we'll be talking about diversity in clinical trials. I know people have heard me speak about this a lot of times, so we're going to have the real experts talk about this. And then after that, we're going to have a look at primary care, because I think it's really important to highlight the role of primary care in managing and reducing healthcare inequalities. And then Professor Faye Ruddock is going to talk about community engagement and culturally competent care. And then we're going to move to our second rapid fire, who is going to talk about misinformation and mistrust. Before we move to one of what I feel is like the most important part of today, lived experiences. We've never had this before. We're going to have patients talk about their experience and what they've done from having experienced inequalities in the healthcare systems, and I'm sure you'll be inspired by all of them. And then we'll have our closing keynote on the future of cancer equity by Lacey Hubbard, who I find inspirational. Her work in the low middle income countries is phenomenal. And afterwards, we're going to have Susie come over and give us an overview of what has happened this week. I know the program is packed, but it is intentionally so because every session adds a piece to the wider picture. So I'm hoping that whether you're here to learn, collaborate, or share your work, you will spark new partnerships. And talking about partnerships, next year's theme is going to be about global partnerships, so watch this space. Thank you for joining us and being part of this movement. I hope today leads to new learning, new connections, and most importantly, new action. London Global Cancer Week, where hope meets action. So I'm going to hand over now to Kofi and Deidre, who are going to moderate our next sessions.
Good morning, everyone. Thank you for making time to be here. My name is Kofi, K-O-F-I, not the coffee you've been drinking. Kofi is a Friday born in Ghana. So, and I'm here with my colleague,
Didier Verhoeven from
Didier Verhoeven from Belgium. All right, so we have 3 speakers today, and we're going to make it a very interesting session for us. So let's first introduce ourselves properly. What do you do?
I'm a medical oncologist from Antwerp and especially interested in global quality care.
And now I'm a radiotherapist from Ghana, and I've been treating patients for the past 18 years and also teaching. And I've trained quite a number of people in Africa, trying as much as possible with the resource constraint in Africa, but still making sure that we are making the most of the opportunities that we have. So we are here. Can we get our first speaker?
Yes, perhaps let's start, but before, perhaps we can give applause to Buki for putting all this together. Thank you. It's a great job. Thank you. So then we will start with our keynote address. It's Understanding the Burden of Cancer Health Disparities, and it will be given by Kulveer Singh. He's Head Marketing Communication of City Cancer Challenge, and that's a very great initiative, and he's a global health communicator and strategic storyteller with experience across oncology, medical communication, and international health programs. He's currently the Head of Marketing and Communication of City Cancer Challenge, where he leads global efforts to strengthen the organization's voice. He's known for connecting people, simplifying complex ideas, and that is really great, I think, and gilding teams with empathy, clarity, and curiosity. And in addition, he has a PhD from the University of Oxford. The floor is yours.
I'd first like to just, again, offer a big, huge congratulations to the organising committee for putting together such a great week of events, truly engaging conversations that we've all had. And as Buki mentioned, health equity is quite close to the passions that drive me. Working at City Cancer Challenge, our focus is really on working in low to middle income countries and using the cities as a way to understand how health equity can really be targeted and how we can develop systems and robust strengthening and support so that when we do come to looking at diagnostics and the whole patient journey and the whole clinical pathway, we're able to really support the system and deliver on the outcomes that the patients deserve. So today, I'll take you through the reality and the current gaps of health equity that we see in low to middle income countries. It's about developing the system, so a lot of the talk that I'll go through is on health system strengthening. and where we can look to build better architecture, work with key players in the cities that we work in, and also, as touched on just now, a real importance on collaboration and bringing together the right partners at the right time. What I do want to say is disparities are not abstract. They're lived realities, and unless we move from awareness to action, and keeping in theme with the topic of the week, they will continue to be present and to be prevalent. And we're all here today to look at ways that we can address those disparities and improve health equity. But first, what I wanted to do was really show you the reality of it. So in this picture, you can see this is Josefina. She's from Arequipa in Peru. She's an architect. She has a loving family with a husband and 2 children, and she's a really keen part of society. She's a really active member of the community. But unfortunately, recently, she's had a high suspicion of breast cancer, which has meant she's had to take time off work. She's had to go to the physicians, and she's in urgent need of a biopsy. And also the next step in terms of confirming that the breast cancer may or may not be present. But what's happened is because of the institutions that she kind of works with, there's been a miscommunication, and she's actually lost a lot of the information from the physicians. And so it's been 4 months, and she's still waiting on the next steps. And she's in that kind of position of she's worrying, her family are kind of asking her questions. And it really comes home to you that it's not just a clinical issue, it's a familial issue, it's a societal issue. It affects her work and her family. And this is the reality. In low to middle income countries, this happens quite often, where the systems don't quite connect, the institutions don't quite communicate as effectively as they should. And we see that just from starting to diagnose what's happening with Josefina. She's been lost to the system, and the system has failed her. And again, I want to reiterate, people don't just lose their health, they lose their community, they lose their families, they lose their ability to work and have fun. But amongst the most important things are, they lose hope. Now, what I wanted to come today and for the whole week is that it's this mantra, this energy of who you are and where you're from shouldn't determine the level of quality cancer care you receive. But like the example with Josefina, it does. And that's where it really hits home. The realities are stark. And we want to, again, come together to really address that. But first, I want to illustrate the real issue. And these are metrics that you may have seen before, but, 70% of global cancer deaths occur in low to middle income countries. That means 7 million deaths, equal to the populations of the 3 countries that I mentioned on the slide. And by 2030, this will actually go up to 3/4 being in LMICs, with 1 out of 8 people in LMICs suffering from cancer every year. So it's a stark reality. It's something that it's increasing exponentially. It's not just a gradual increase. 10 years later, by 2040, there'll be predicted just over 30 million cancer cases, with just over 60 million cancer care deaths. The global burden is rising, and the burden is heavy, and it falls hardest on the communities, the cities that are the least equipped and have the least protection. But behind every statistic is the systems that either work or don't work. For the case of Josefina, the system didn't quite come together, and it failed her. And so what we see is it's not just a health challenge. It's not just about ensuring that a patient is seen, gets a treatment. It's a societal issue. It's an equity challenge. It's about access. It's about equity. It's about ensuring that everybody has the right to access the care that they deserve, and it's not just a privilege for the few. So what I want to ask is, how do we create change? Well, we begin to transform the state of cancer by firstly looking at the global architecture that is in place. and that shapes and maybe even sometimes exacerbates or reinforces the disparities and inequities that we see. When we look at the architecture towards implementing change, it's the functions, the mechanisms, and the actors, the local people in the cities that really make a difference and make a huge part in determining who gets care, how, and when. And when we look at the right-hand side of the slide, it's about the health system strengthening. So when we look at that, it's about the strategies that we want to put into place that then support the architecture to ensure that we do cover all bases as much as possible to get patients right through the cancer care pathway in terms of prevention, diagnosis, treatment, and then follow-up. The two go hand in hand. So what I want to do is maybe on the next slide is to just kind of spend a bit of time and go through the global architecture. When we talk about disparities, we often look at the disparities in the clinic. But there's something much bigger that actually occurs, and it's beyond the clinic. It's the architecture that supports the clinic, that supports the institutions. Every single part of the architecture really influences the outcomes for the patients. And I'll very briefly go through each pillar. Stewardship, governance, it determines whose needs are prioritised and who is protected and who is left behind. Equity should be the design principle that really brings together the governance, the advocacy that drives sustainable change. Financing, as I'm sure you've all been part of some really interesting financing discussions and health financing strategies. At the moment, it's fragmented a lot of the time, and this fragmentation causes inconsistencies and a heavy reliance on out-of-pocket expenses for patients, which it means that patients will leave the system. They just can't afford to really pay for the treatment and even the diagnostics or the testing or the screening. It's just beyond them, and so they fall through the cracks. The technical assistance, we see that capacity in the cities that we work in at City Cancer Challenge. We see that local capacity really does build resilience, and it helps to reduce disparities as it allows cancer care to be delivered to those who need it most. With emergency response, we see, with COVID and some of the natural disasters, what tends to happen is funds are diverted. And because cancer care in certain places isn't such a priority in terms of a political priority, a financing priority, sometimes it kind of gets left behind. And knowledge and research is important. Innovation doesn't reduce inequity unless it's accessible and relevant to those who really need it. And so what we want to do is we really want to understand what the gaps are and build local evidence to support where research can help deliver outcomes and deliver solutions that we can implement in the cities. And then finally, data surveillance. If the data systems that are in place, the health data infrastructure, digital infrastructure in place isn't strong, then the connectivity, like the example that I mentioned at the start, is just not there. Data doesn't pass between people, institutions, doctors, and so information gets lost. And so again, the patient is really the person who suffers. Ultimately, we can't measure. If we can't measure it, we can't prioritize it. And so some of these points are really to hit home that it's the architecture that we want to focus on. Now, the next slide is, as you may have seen, these are the 6 building blocks from the WHO in terms of the strategies that we can put in place. And what we at City Cancer Challenge do is we align to these 6 building blocks so that we can deliver on the architecture that I showed you on the previous slide. All of our works in the city are aligned to these building blocks of the health system strengthening. We engage multi-sectoral stakeholders in the cancer care and in the city. We collect data and analyse the challenges in cancer care in the city through needs assessment, through priority settings, through situational analysis reports. And the way we deliver it is we understand how capacity can be built. Like I mentioned earlier, it's not just about isolated support. It's not about delivering isolated solutions such as equipment. It's about understanding how we can develop the system to be ready for the intervention. And that means workforce training, that means capacity development, that means ensuring that the processes are in place, the data can flow freely, so that when we do get to delivering the interventions, they're supported and they're sustainable. Now, underneath all of that is the hidden architecture. And this really comes down to the social determinants of access. Cancer care disparities are deeply rooted in these socio-economic determinants. If you're poor, if you're female, if you're from rural communities, if you're from marginalised communities, then treatments can take longer, they may not be as reliable, and they may be more expensive. Now, I'll go through each of these very quickly. Geography matters. In many countries, specialised cancer services exist in major cities. Major cities is where the key services are. But for those in rural areas, those who can't commute, those who can't travel, those who have children, who have dependencies, these aren't just small inconveniences. They're often the reason why people stop treatment, abandon their treatment. So it's important to understand the geography of the patient population and where these solutions are delivered. Poverty matters. Poverty restricts every step of the pathway, from recognising systems to seeking care to staying in care. And sometimes if patients can't afford it, they just step away, despite the benefits that it is to stay in. And that's why health financing strategies really need to factor in the human element of whether a patient can afford it and reduce and maybe cap those out-of-pocket expenses. Insurance coverage matters. Many health insurance schemes offer shallow benefits packages. They look good on paper, but in practice, we still get the high out-of-pocket expenses for patients, for diagnostics, medicines, or even specialist consultations. It really does clock up. And health literacy is important, both for health itself and for financially. If you don't understand the systems, you present late. If you don't understand how the health system works, you get lost in it. And if you don't understand the costs ahead, you run out of resources before treatment is even complete. So it really does ladder up, and it really does affect the patients. And then finally, culture, stigma, and maybe even gender norms. Mistrust, stigma, and gender-related issues and decision-making can delay care or prevent care. If we don't acknowledge cultural realities and build systems that support those cultural realities, people cannot and will not use the system to get the treatments that they deserve. If we ignore these determinants that shape people's ability to enter the system, to navigate the system, and then complete their cancer care journey, we will continue to see unequal outcomes and the disparities that exist. Now at City Cancer Challenge, we have a set of core principles when we talk about reducing disparities. It's easy to jump straight to solutions, but we want to ground ourselves in these core principles. Firstly, we must make decisions rooted in local data, not assumptions, not donor priorities, not global templates. When we let evidence guide us, it really does help us to build interventions that match what the patients need and not what we think they need. Alignment is what transforms a pilot project that we deliver in a city into a system-wide improvement. And local ownership is then when cities, key stakeholders, institutions, key experts come together, collaborate, and are part of designing the very solution, and they champion the solution. So it becomes part of their advocacy, and that can then ladder up into national change. And finally, we need systems that endure. Like I mentioned, we never want to look at developing solutions for cancer care in isolation. We want to ensure sustainability. We want to ensure that there's a workforce capacity that continues. We want to ensure that there's clear policies and guidelines that exist. At CCAN, everything we do is about closing the gap between what people need and what the systems can deliver. We work with cities to strengthen diagnostics, workforce, quality and patient pathways, and the exact areas where disparities take hold. By building stronger local systems with city stakeholders, we make equitable cancer care possible. And these are some of the principles. These are some of the principles that we work on with CCAN. So what I'll do next is I'll take you into the network of cities that we work with in CCAN. At the moment, we work across 16 cities, 7 cities in Latin America, 5 in Africa, 1 in Europe, and 3 cities in Asia. Now, the reason we choose these cities is because one thing they all have in common is they want to work together to overcome these disparities that we see, the inequities, the challenges that we face. But a really key reason is that cities are where cancer disparities are most visible, because cities are the front line of cancer care delivery. It's the front line service, and that's where change can happen fastest. They're close enough to understand the real barriers and influential enough to drive systemic change. So like I mentioned, if we see something working in the city as a pilot project, it can then be scaled up into a national priority or a national intervention. And when cities lead, inequities start to shrink. Cities are where we really see the data, the patients that suffer the most. That's where we see the disparities. And it's important to work with local stakeholders, local actors, to build that local evidence. And then when cities strengthen their cancer system, they create models that countries can scale, like I mentioned. Local innovations become national policies, national standards, and national investment. City success is the gateway to nationwide equity, and that's what we find working across the 16 cities. Now, this is quite an important slide because this summarizes our city-led model. So, as you can see on the left, we say we first uncover the gaps. Now, uncovering the gaps is all about working with stakeholders, again, key players, ministries, governments, to really map what's going on in the cities. We conduct a needs assessment, which is where we understand the key unmet needs that exist across the city in cancer care, across many institutions, dealing with experts as well. And we help cities pinpoint where these inequities are and co-create solutions. And that's the biggest step, is that we first co-create the priorities. We sit down with the ministries, we sit down with the stakeholders, and we priority set based on the unmet needs. And then following on from that, we then bring in the key players to help us co-create the solutions, to create that co-championing of the interventions that we deliver. This is how we move from knowing what the gap is to then powering the system. Powering the system is then understanding how we can implement these designs into reality, how we implement the solutions, how we deliver these interventions and solutions in the cities. And then that leads to policy change, that leads to national influence, that leads to knowledge sharing across our city network and other places. And so what happens is when we deliver a solution in one city, we're able to share that information and look at where it can be applied to another city, which is a real strength in the City Cancer Challenge model. Now this is, again, another key slide. It's the importance of building equitable cancer care. No single actor can close cancer care disparities alone. Equity happens when governments, funders, industry, communities, and healthcare institutions work together with a shared purpose. I won't go through each and every icon, but as you can see, there are multiple players that are involved in building this equitable cancer care at the city level, and each of them can help support different elements that will help advocate for these programs, these solutions that we deliver. Equity happens when these guys come together, and collaboration isn't optional. It's a big part of how we work, how we communicate, how we deliver our solutions in the cities. It's the engine of the better outcomes that we hope for. And collaboration, again, like I mentioned at the start, is another of the design elements of building an equity strategy. And just to repeat, it's the right partners, the right funding bodies, and strong frontline leaders who come together to make this happen. So before I move on to the next part of the presentation, I've taken you through the realities, the gaps, and looking at the architecture to understand what happens when we do keep that in mind and when it's ignored, what can happen. Now, what we've seen in the cities is developing solutions, delivering programs, designing, co-creating. We've seen real change, but real change is often ignored because it can take many years. So at City Cancer Challenge, what we've developed really is a set of indicators. These indicators allow us to understand how exactly our solutions and our interventions are working, and it works across 5 key pillars. Now I'll go through these pillars again very quickly. The first pillar is patient-centered care. We measure how many patients reach key milestones in their cancer care journey. We measure how many may get lost. We measure whether care is centered around their needs, because these are the disparities that show up first. The second pillar is access to cancer care, and access is where inequity is most visible. We track how much patients pay out of pocket, how many are covered in financial schemes, and how many actually make it from suspicion of cancer to diagnosis to treatment, how many are successful in that journey. These numbers reveal the true care gap. Quality of cancer care determines survival. So we monitor guidelines, we monitor turnaround times, and the regularity of multidisciplinary interactions and collaboration and discussions. Stronger quality systems mean earlier diagnosis, faster treatment, and fewer disparities. And no health system should be without equity, without a strong workforce. Like I mentioned earlier, it's about creating a robust system. We track training, competency, staffing levels, because without people, even the best plans just sit on the shelves. We can deliver something in a city, and once the funding's gone, it sits there gathering dust. And so we want to ensure that we can build a system of resilience and longevity. Human capital is the backbone of quality cancer care. And data, finally, is our compass. Like I mentioned earlier, if we can't report it, we can't prioritize it. And so we measure local research, we look at registry participation, coordination across institutions, and we measure how things can improve, how things are improving. And disparities shrink when systems can really report back on the outcomes and see the impact of the work that we do. Now, the final few slides, I'm just going to go through some of the examples. So in terms of patient-centered care, we've seen projects delivered, the project types delivered, referral networks, patient navigation schemes. These are really important in terms of mapping the patient journey and training people and the workforce to understand how to take a patient through their journey with cancer. An example that we've seen is we've used open source digital platform deployed in collaboration with the Secretary of Health in Cali, Colombia. And the impact that we saw was that patients lost to follow-up rate was reduced by 15% for breast cancer patients waiting for biopsy. So, if we look back at that example that I shared at the start, that disparity that meant Josephina was lost to the system can really be approached and addressed with these types of interventions and solutions. With the quality of care, examples of projects are patient navigation, MDT guideline development, quality assurance programs. So in Kigali, we've seen patient navigation programs established across 5 cancer centers. And we've seen a reduction of time between diagnosis and treatment from 82 to 28 days. So significant improvements. And again, with access to care in Tbilisi, Georgia, we've seen a mobilization of financial resources, which has led to annual financial coverage of cancer medicines increasing per patient, endorsed by the government of Georgia. So again, we see cities as the microcosm of the national system. Cities are where we can really see the difference happen, and we can then connect in with the political will and the lobbying that can help that be delivered on a national scale and change national guidelines and policy. The final 2 examples, development of human capital. We've 2 years ago, we launched a cohort of 10 female oncologists and bringing together many female oncologists from the cities that we work in. And that has really given them a platform to promote gender-responsive health strategies and health equity, and given them increasing positions of leadership. And then finally, local knowledge generation. This is where it's super important, because the work that we do, we want to sustain it. We want it to be shared. We want to understand how this can be applied to other cities, to other localities, to other regions. And one of the examples we've done is strengthening cancer registries. where we've developed policy guidance to harmonise high-quality data collection and synchronisation amongst cancer centres across cities. And this has just improved coverage, completeness and reporting, and it's brought that data connectivity and knowledge sharing and generation in a central hub where we're able to really understand the key lessons from it. Another quite nice example is a recent paediatric intervention that we did in Kumasi, Ghana. Simple changes in training of the workforce in terms of understanding better the referral pathways and recognising issues around diagnoses transformed cancer outcomes from 1% of referrals being confirmed cases to 25%. So it's a vast increase. This is what happens when local insight really drives action. Inequities start to close. So as I come towards the end of the presentation, I just wanted to show a really clear slide on the impact that our city-led model has on LMICs and the cities that we work in. Across 16 cities, we've improved care for over 750,000 patients and developed over 200 cancer care solutions developed for the LMIC settings. And we've trained thousands of healthcare workers, and we've connected with thousands of key healthcare stakeholders. These numbers represent lives directed towards better outcomes and systems moving towards equity. But equity is built through deliberate choices in how we design services, engage communities, and shape the environments people depend on. Every decision brings us closer to fairer care, to address those disparities, to overcome those inequity challenges. And so closing the cancer gap is bigger than just any single organisation. It's about coming together, and we can't do this alone. It takes aligned partners across government, civil society, industry, and local systems, all working with a shared commitment to change the current situation of equity, because real change only happens when we move together. Thank you.
Thank you very much. Thank you. I saw you were becoming very emotional, and of course, you're a communicator, and that's what you do. Thank you very much. City Cancer Challenge, you are in Kumasi, Accra, and Ghana as well. They're doing very much well in LMICs, and I believe that this is something that is worth emulating. But we just have some few questions for you.
Sure.
And because of time, I would want to find out, what are the most effective approaches you've seen cities adapt to close equity gaps, with the work that you've done over the years?
It's a great question. I think it's more about the approach that we've enabled, and it's really to understand that we can't fix every solution immediately. It takes time. And what we see is the best approaches are to understand that there's a foundational element that we need to build. As I mentioned in the presentation, it's about building the readiness. It's about building the system's readiness to welcome interventions and solutions. And so that's not just getting ready for the equipment to be delivered into the new labs. It's understanding what we need to make sure that those labs really continue going for many years. And so that foundation comes from capacity development, from workforce training, from understanding the competency and the quality of cancer care that we can deliver. And that even goes down to understanding and better supporting data systems, diagnostic pathways, training for referral pathways that we can deliver to nurses, and then even, like I mentioned earlier, the patient navigation that we're able to put into place so that we can help those patients get through the prevention, diagnosis, treatment, and follow-up journey, so that every part of that journey is supported with a robust set of systems.
Fantastic. Thank you. I think we just have one question for the audience. He will be here for the whole day, so I'm sure that if you have more questions, we can. But just one question from the audience. Yes, if anybody has a question for... Anybody has a question? Yes, there's one hand. Yes.
Good morning, everyone. Thank you very much for your speech. It was quite a good one. But when we talk about inequality and we're talking about closing the gaps, more especially when it comes to diagnosis, I would talk from where I come from, Africa. We understand that most of the diagnoses that happen today in cancer comes from the data available. And if we look at cancer data available, they are Eurocentric. And you're using an Eurocentric built data to develop diagnosis for an African population. How do you think that helps to detect this? Because from my experience and my work in the clinic over the year, you find out that you're actually using a parameter that doesn't see someone to try to find the person. How do you work to try to reconcile this? Thank you.
That's a great question. I think that the power that we have to convene key stakeholders in the early stages where we bring together stakeholders and develop the needs assessments for the cities, these are the types of issues that we do here, we do see. And what we want to do is we want to use these issues, we want to build key priorities. The next step is to build those key priorities with yourself, people like yourself, people from the institutions in the clinics, to really understand how we can take that step further from moving away from, like you say, maybe Eurocentric models to understanding the real lived realities, the lived experiences of not just the patients, but the clinicians who develop the treatment pathways. So it's part of our process to connect with the stakeholders, to really understand, and it's about that local evidence. We try to build local evidence with institutions and physicians, and that's how we try and uncover those gaps particularly, and then use them to help power the system to really support localized, contextualized solutions that we can deliver.
Thank you. I think let's put our hands together for him. He's still around, and please take your seat. He's still around, so we would continue with the questions. We want to invite our second speaker before we go online for the... oh, he's online? Okay. So then we would switch to our second speaker online. Professor Habib is a chief executive of the NHS Race and Health Observatory, which works nationally and internationally to tackle ethnic inequalities in healthcare. He has been instrumental in forging partnership with major organizations and bodies, including the UK Faculty of Public Health. He's worked for so many years. From 2013, Habib directed the development and implementation of the National Health Equity programs for the National Health Services, and has given evidence to the UK House of Commons Health and Social Worker. Habib was awarded on MBE in 2019 Queen's Birthday Honors for services to equality and diversity in the NHS. He has received a fellowship through distinction at the Faculty of Public Health in 2023. We want to invite Professor Habib Navik to speak for us if he's online. Thank you, Prof.
Great, thank you. Thank you so much, and I hope you can hear me. And apologies for not being with you in person. I have developed a cold over the last day or so, and traveling from Bristol to London wasn't feasible, and I'm grateful to Bookie for agreeing to have me come online today. I will share my screen. I have some slides, and I'm hoping you are able to see the slides. But firstly, thank you for the introduction. As I said, I have been working in the NHS for 25 years, and throughout that time, I've been working on looking at tackling inequalities in health and healthcare, but perhaps there hasn't been a time more important than now to focus on looking at how do we tackle racial bias, discrimination and racism within our healthcare system, and of course our role as a healthcare institution to tackle that across wider society. I'm also grateful for the previous presentation. It was very insightful, and in particular the question as well, and I'll be touching on some of those and building on some of those points in my presentation. But before I go into the detail of ethnic inequalities in cancer, I think it's good to set into context the ethnic inequalities that we see generally across the UK. And the fact is that there are inequalities throughout the lifespan in relation to access, experience, and outcomes with regards to a range of conditions and diseases, whether that's maternal health, whether that's access to mental health care, whether it's prostate cancer, whether it's cardiovascular disease, diabetes, and of course, what we saw not so long ago now, the adverse, disproportionate impact of a pandemic, COVID-19, on our ethnic minority communities, patients, and healthcare staff as well. So there is a level of urgency for us to focus on this agenda. And in a way, our healthcare system, our country should be well equipped to deal with that level of urgency for a number of reasons. Firstly, we have a long history of migration in this country that goes back not just decades, but centuries. Secondly, we have very good investment in healthcare research in this country. Innovations developed within this country have been used and have been migrated out to other parts of the globe. And of course, COVID vaccine is probably one of a very long list of interventions that have been invented, produced in this country, and have been migrated out. And then thirdly, we have fairly robust legal frameworks in tackling inequalities. We have the Equality Act 2010. We have the Health Inequalities Duties as well. But at the same time, it can also be argued that our collective responses, historic responses to tackling these issues, have been somewhat fragmented, costly, and confused. And whereas specific interventions are focused on tackling these issues, they have, in my opinion, largely focused upon surface level issues and interventions, as opposed to tackling what I call the causes of the inequalities that we see, which include the inequalities that we see within cancer care as well. And some of those inequalities within cancer care specifically, as I mentioned, include the inequalities around access and experience and outcomes, include the delays in diagnoses, include the higher mortality for certain cancers despite lower similar incidence. They include focusing on the root causes, the social, economic, and the systemic racial bias that exists within the healthcare system, whether we see that play out in clinical trials, in medical research, or whether we see that play out in medical devices or in medications itself. And I'll come on to that point a little later on. And then, of course, policy progress and the limits that we have to that, including how can we turn data into insight, and how can we turn that insight into action in a meaningful way through policy progression. And these are some of the things that I'll be focusing on at a higher level in my presentation. But I'd like to begin also by highlighting the Race and Health Observatory. We are now operating, and nearly 5 years into our establishment. We were established just before the pandemic broke out. And one of the very first things we did an organisation established by the Department of Health and Social Care and NHS England as an independent organisation, we commissioned a rapid evidence review around ethnic inequalities in health more generally. This report was in part our response to the CRED report, or the Sewell report, that was commissioned by the previous government. But in fact, this report also led us to establish our work programme for the coming period. And this report did highlight some of the inequalities that we would, I guess, expect, knowing what we know in terms of health inequalities. So inequalities in terms of ethnicity and race on the basis of mental health, maternal health, genomics, on sickle cell, on cancer, and workforce race equality as well. And this report did make the front pages of the newspapers, not because it was another rapid evidence review. We've had many of those in the past, and I'm sure we'll have more of those in the future. But for the first time, perhaps, we were using the word racism with regards to our beloved NHS and healthcare system. And it's important for us to recognise that. And since then, in fact, we have seen the establishment of anti-racism approaches, methodologies and interventions, and have had very senior leaders talk about racism and the impact that racism has, not just within society as a whole, but within the healthcare system as well, not least because the NHS, the healthcare system, is a microcosm of wider society. What happens on our streets, in our communities, is bound to be reflected in the 1.5 million people that work within our healthcare system. And so it's important to understand the different cases for tackling racial inequalities, including in health. We have the legal case I mentioned, and we have the moral case of obviously getting this right for patients, but also the financial case. And this case very often speaks to people on boards of organizations. A piece of work we're doing within the observatory called The Cost of Racism to the NHS doesn't just look at the human cost, but also the financial cost as well, which is in its billions. Not tackling inequalities does have a significant detrimental impact to our economy, to productivity, and to efficiency across the NHS. And I do highlight this slide because very often it's numbers that people want to hear, it's the figures that people want to hear, and yes, they understand the moral case and the legal case, but actually there is a financial case to this as well. I mentioned the COVID-19 pandemic. We saw so clearly the concept of trust and confidence in our healthcare systems play out throughout the pandemic. In fact, it's a historical issue, and there is a very real hangover from the pandemic with regards to trust and confidence. And I define trust as truth told consistently over time, as the algorithm on this slide. And if there's a breakdown in any part of that algorithm, there's a breakdown in levels of trust. And trust is fast becoming a determinant of health. We heard in our previous presentation the social determinants of health. Trust is fast becoming a determinant of health. It's determining people's choices as to whether or not they take part in healthcare interventions, access healthcare, whether or not they take part in medical research, in clinical trials. And so it's important for us to focus on building and rebuilding levels of trust, including through some of the concepts that the previous presenter highlighted in terms of co-design, co-production of services as well. And trust does lead to, or breakdown of trust does lead to bias, and it does lead to a lack of representation in medical research. And if I give you one example of work that we are doing at the Race and Health Observatory, this is a piece of work that we are undertaking with the University of Liverpool, looking at an anti-cancer drug, DPYD, that doesn't get broken down as quickly in black bodies as it does in white bodies, has led to higher levels of toxicity and sadly death amongst black patients. And the fact is that when this drug was being developed, the genome sequencing that led to the development of this drug missed out the African variant. And this point goes, I believe, kind of speaks to the question that was asked from the audience just earlier. 93% of genomic data is from white populations, and yet white populations only make up 15% of the global population. So the lack of trust in partaking in research, in clinical trials, in genomic bank, gene bank, etc., does lead to the development of interventions such as this anti-cancer drug that does not fully meet the diverse needs of our diverse populations. This is one example of the work that we're doing within the observatory, looking at racial bias. There are other examples in terms of medical devices. There are other examples in terms of medical assessments that do have a level of racial bias that we need to debias and weed out from our policies, processes, and assessments. So what are we doing? We are looking at identifying gaps. I mentioned the work we're doing with the University of Liverpool. In terms of that, we're looking at promoting inclusive research. It's a piece of work that we are undertaking with Macmillan Cancer, with Roche, with Barts Health as a pilot site, introducing innovative ways of increasing representation in clinical research. And we're also leveraging data, looking at data quality, but also looking at how can we bring together data and insight and replicable good practice in these areas from across the country and from across the globe as well. Just in relation to the middle example around promoting inclusive research, I mentioned we're doing work with Macmillan, with Roche, and with Barts Health. This is a innovative research collaborative that is really looking at, what are the barriers to Black, Asian, and ethnic minority women taking part in breast cancer trials? And what is it that we can put in place, as we are putting in place, such as, for example, dedicated nurses to really focus on increasing representation, and other interventions as well that can help us to increase representation, that can help us to increase the validity of the interventions, products that are therefore produced as a result of the more representative research. So this is an ongoing piece of work, and our role within the observatory is to evaluate the success of this research, and looking at scale and spread, not just within breast cancer, not just within cancer, but more generally around clinical trials as well. And it is about building partnerships in that regard. It's about improving representation, it's about delivering measurable results, and it's about setting an example. And we talked about in the previous presentation around the importance of global partnerships, and that's absolutely critical for the Race and Health Observatory. We have been partnering with global organizations and countries around race equality in healthcare, not least because we know racial inequality is a global system-wide challenge that requires a global system-wide response. Our work includes looking at good practice from New Zealand around what they're doing with their indigenous population, Canada, in South Africa, Guatemala, in the US, and very recently within the government-to-government bilateral agreement between the UK government and the Brazilian government, the observatory will be working closely with the Brazilian Health Ministry to really focus on our comparative anti-racism approaches to healthcare and what we can learn from each other as well. But there is a lot more we can do within the UK, and we are doing that. We have a a unique collaboration with NICE, which I'm particularly proud of. And the reason for being proud is because this partnership is about debiasing current clinical guidelines around cardiovascular disease, around cancer, around sickle cell, around mental health in particular. And the other reason I'm proud of this partnership is because it's not just focusing on current clinical guidelines that exist at the moment, but we are also working with NICE to build in processes so that the development of any new clinical guidelines going forward will not have bias embedded within them from the outset. So there's a lot of work we can do to tackle, as I called, the causes of the inequalities that we see play out. I need to mention workforce because it's critically important. If we are in the business of tackling inequalities in cancer care, which we are, then we need to have a fully engaged and supported workforce within the healthcare system and representative workforce at all levels, including at senior levels as well. And that's not what we always see within our healthcare system. We know of the relationship between happy staff, representative staff, and happy patients. That is an evidence-based relationship. I came across that relationship very early on in my career in 2007-8 through the work of people such as Professor Michael West and Professor Jeremy Dawson. And that work is really critical for us to continue to keep on focus on, as we do within the observatory and as we are feeding in with regards to the implementation of the 10-year health plan and looking at the forthcoming 10-year workforce plan for the NHS as well. So what can we do? We know what works from evidence over the years, not just from this country, but from other countries, including from Harvard in the US. Demonstrable leadership is critically important. What leaders do, what they don't do, is really important, and how that filters down from board through the organization is critical. Evidence-driven accountability is important. That's not just external accountability from healthcare regulators, but also internal accountability of how we hold ourselves and each other to account regarding tackling inequalities. Sustained and meaningful engagement. There's a HSJ Health Service Journal article that we published yesterday, the headline of which is around how co-production and tackling racism will create an NHS for all. And it's important that as neighbourhood health care systems are established and rolled out across the country, that meaningful and sustained engagement over time happens. Robust data and data usage, not just data for the sake of collecting data, but good data, improving race equality data, ethnicity recording, and using that in a meaningful way through building trust is important. Identifying and eliminating bias, as I've highlighted, within policies and processes, and reflecting and continuously improving on that. My penultimate slide brings all of those 6 pieces together into the observatory's 7 principles on anti-racism, which we published last year. These are evidence-based approaches to tackling racial inequalities in healthcare. Behind each of these 7 principles, there is a more elaborate briefing that you can find by clicking on the QR code. Hopefully you're able to see the QR code on the slide. I won't go through all of the 7 principles. I've gone through some of those already, but I will highlight the first principle, which is demonstrable leadership in naming racism. Because in any sphere of life, everyday life, if we want to change something, we first have to acknowledge that there's something to change. Acknowledging that racism exists is the critical first step towards shifting the dial on ethnic and racial inequalities in health and in cancer health more generally. So it's really important that organizations focus on this, and they are. Many NHS trusts are now adopting these principles. And I'm pleased to say that the healthcare regulatory bodies are adopting these principles. CQC, Care Quality Commission, have adopted these principles as a employer of people, but also as a regulatory body, as have the GMC, NMC, HCPC, and others as well. And this really is about having those difficult conversations, what I call being comfortable with the uncomfortable, and enabling ourselves and each other to close down the gap between the promise of our ideals, what kind of society do we want to live in, and the reality of our time. And that reality does include the stark inequalities that we see in health, and in particular in relation to cancer health. But through some of the work that we are doing and we can do together, I believe we can make real inroads to tackling those inequalities head on. Now, I'll pause there and hand back to the chair. Thank you.
Thank you for the nice presentation. I think indeed a lot of more research is needed about the genomic diversity, and before bringing things to the market in the different continents, we also have to prove that the drugs work in African continent, of Asian continent, and all the continents. But are there questions from the floor?
Hi, thank you very much for the talk. It was brilliant. Just wondered, with your collaboration with NICE, how do you ensure making guidelines that there is no bias from outset when there is inherent bias within the research that's already been done?
It's a very good question. So it's not either or for us, it's both. So we are looking at not just building in that almost kind of equity impact assessment process within NICE, but we are also working with research bodies such as the NIHR to diversify not just what's focused on in terms of research topics, but who leads the research itself as well. We've been working with them in relation to building equity and racial equity as a criteria for funding of research specifically, and we will continue to do that so that we can really have both the upstream and downstream interventions around tackling inequalities.
Yeah, perhaps we must go to the next session in lack of time, perhaps. Or is there another burning question? No, then we will go to session 2. It's the role of socioeconomic factors in cancer outcomes. And our speaker is John Selton. He will speak about exploring the impact of income, education, and employment. John is working in the health analysis and intelligence for multiple organizations, including the National Cancer Intelligence Network, Public Health England, the Care Quality Commission, and Cancer Research UK. He leads a team analyzing data across cancer epidemiology, prevention, early diagnosis, and treatment to better understand how cancer affects different populations. Please.
morning, everyone. Thank you very much for having me here today. My name is John Shelton, late replacement for Nasser Tarabi, who sends you apologies for not being here today, but hopefully I can take you through this and get across to you the work that we've been doing looking at socioeconomic demographic factors on cancer. Before I get going, I would just like to echo what I said earlier and say a massive thank you to Bookie for everything she's done to get this organised today. A fantastic achievement, trying to do that alongside her day job, which is not really an easy one as well. Extremely impressive, many superpowers from Bookie, and it's great to see so many people here today and great to be here myself. What I'm going to do, I know we're running slightly over, so I'll try and get through this relatively quickly, but what I'm going to do is just take you through some of what we do at Cancer Research UK, looking from a data point of view, looking from an analytical point of view, trying to understand the evidence around the impact of different factors on cancer. Every year we produce a report called Our Cancer in the UK. This is a kind of a snapshot of what's going on right across the UK generally. It's aimed to be a kind of an easy to access, easy to read kind of journey through what we think are the kind of critical areas, the critical things that are going on with cancer care. We do specific focus areas which are less frequent, and earlier this year we published this report on socioeconomic deprivation and cancer. Really, it's trying to pull together the evidence that exists into one place to tell a kind of consistent story. We do add our own analysis to it and try to kind of understand really kind of what's going on. And that's really what I'm going to be taking you through today. And then I'm going to kind of finish up of what are we trying to do about it. So what are the inequality strategy that we have at Cancer Research UK, and probably echo some of what has been said by previous speakers, Dr. Singh and indeed Professor Naqvi, and so I won't be surprised if some of those things are quite similar, especially that theme of collaboration. So if we just move on to the next slide, as I said, I'm just going to take you through the overview, which will kind of give you a sight that wherever we look, predominantly in every metric, there are some exceptions, but predominantly in every metric, everything we look to do with socioeconomic deprivation and cancer, we see worst experiences or outcomes for those from more deprived groups. So there are a few exceptions, but it is quite a clear picture that we see in every place. So I'm just going to take you through the overview of what the analysis shows, taking you through prevention, screening, a bit around earlier diagnosis, services, and then kind of come to that summary of the inequality strategy and what we're doing at Cancer Research UK. So to start off with, most of the work that we'll take through uses the index of multiple deprivation. There are pros and cons to it. We know that health inequality is a result of differences in various socio-demographic factors that include age, ethnicity, gender identity, and geography, among others. It's uniquely connected to these many demographic factors, but it's an important overview of inequalities in cancer. It's got aspects of income, employment, education, health, crime, barriers to housing services, and living environment within it. It's probably important to note that the individuals will have different experiences. These are generalized on a broad population basis. It doesn't necessarily reflect the lived experience of individuals within them. And I just want to kind of stress that because this is about the general population. This is not about individuals. But the generalization gives us the basis of the evidence of where do we need to look and how do we work? How do we need to connect with those people who are in those populations and what more do we need to do with them? The nice thing about IMD is it's really easy to sign. I think both previous speakers have spoken about the importance of data and evidence. The nice thing about IMD is within the health services, we collect where people live. We collect their postcode. It can be signed at a population basis. We can split it into 5 equal groups. It gives us a nice set of comparative results. No, that's not the same for every factor of the population that we want to look into and understand about inequalities. For example, with minority ethnic groups, there's a lot of evidence that we don't have because of the small sample size that we have in certain cancer sites. So this is, I guess, from a socio-economic point of view, we have quite a bit of evidence that doesn't. I want to kind of stress that there's much more that we need to look at, and I'll come to that with our inequality strategy. There's many areas that we don't quite have the evidence for yet. So just to kind of move on, the overall picture that I'm going to take you through, it's nothing new. I think that when we first published a report looking at socioeconomic deprivation and cancer, probably roughly 5 years ago, we probably produced quite a similar report. The sad thing is that we haven't made much progress, and that's why it's so important to have what we've put together today of how to move this into action. We are making this progress. There's some areas, and I will touch on where we have made some good progress, but there's much more that we absolutely need to do. What I'm kind of going to take you through is essentially this journey. What you see is wherever are these metrics that we look at. So if we're comparing on each of the bits I'm going to take you through, comparing the least deprived areas and people living in the most deprived areas have high proportion of adults who smoke, for example, about 3.5 times the rate of smoking amongst most deprived people. We have a high proportion of adults who are obese, nearly twice as many in the most deprived compared to the least deprived. We've got low proportion of participation in screening programs, high proportion of emergencies and diagnosis in late stage disease. We've got higher incidence rates, and this is how it all manifests with the highest risk factors and the worst experiences through care. Is within cancer with higher incidence, lower survival and higher mortality rates. So I'll take you just through some of those briefly over the next few minutes. So starting with the kind of risk factors element, I'm going to start with smoking. And yes, there is positive news in smoking. We've been reducing smoking prevalence overall for quite a while. Smoking prevalence in females, for example, peaked in about the late 60s, early 70s. For males, it was quite a few decades before that and a much higher rate. And it's been coming down ever since, which is fantastic. The bit I kind of want to highlight here is whilst we are making progress, and we can see here results for each of the 4 countries across the UK, of England, Northern Ireland, Scotland and Wales. What we've got on the screen is the dark purple, the most deprived, the blue, the least deprived. And you can see, if you kind of look over the left for England, we've reduced the smoking rate in the most deprived from 33% down to 22% over those 10 years, which is fantastic. But we have also reduced the smoking rates in the least deprived from 10% to 6% over that time. So if we kind of look at that, we're actually kind of keeping that ratio. If you look at the comparing between the two, the relation between least deprived and most deprived, we're kind of keeping that consistent. And I kind of highlight this because whilst we are kind of reducing smoking, we're just not doing it quick enough in the most deprived groups. And if we take this kind of on, and this is split into deciles, so the bottom line on this graph is the least deprived, the top is the most deprived, and whilst I'll look at quintiles before, when we're looking at this deciles, if we project smoking into the future, we essentially can say, well, what is the inequality in smoking by socioeconomic deprivation? And we can kind of put a time frame to it. We have a smoke-free target of 5% by 2030. And probably the top quintile, we're going to make it. We'll probably hit that 5%, which is great. But if we look at the most deprived groups, we're way off meeting that. And if we're keeping that kind of relative ratio between them consistent, it's always going to be higher in the more deprived groups. We have to do so much more in order to reduce it. In fact, we don't think that we'll probably get down to 5% in the most deprived quintile for about another 20 years, about 2050. So that kind of shows what that inequality is within smoking amongst populations. It's about a 20-year, 2-decade gap that we've got. And we know that this is such a large contributing risk factor to cancer, and not just cancer, but also kind of tertiary prevention impact that it has when people are ill, treatment, etc. It has a long-lasting effect right through. So understanding this and looking at things like the socioeconomic deprivation on groups, really understand where we need to kind of improve, where we need to really kind of target areas, and much more we need to do. If we move on to obesity prevalence, again, we've kind of got this similar picture. If we look on the left being the most deprived quintile, to the right the least deprived, is the proportion of adults who have obesity, looking at biodeprivation. We've got that step change right across the quintiles as you kind of look at them. It gets, if you kind of go in order of deprivation, it gets progressively worse with each quintile. So we've got this kind of challenge. Overweight and obesity is very important. It's the second largest preventable risk factor. Probably in the next 20 years, it will probably overtake smoking and become the largest preventable risk factor for cancer as we continue to reduce those smoking rates. We're seeing increasing rates of overweight and obesity, but we've got this massive difference between the least and most deprived of roughly about 15 to 20 percentage points. So again, looking at these kind of risk factors, this is effect on cancer and cancer outcomes for decades to come. This isn't just about today, this is about the future. We have 3 national screening programs in bowel, breast, cervical. We've also had the rollout of targeted lung screening. A very positive note, just to kind of focus on targeted lung screening, that it started the rollout in areas of higher smoking, of more deprivation, which has been great. We need to make sure that we get that kind of complete rollout of the targeted lung screening as soon as possible, and not just in one of the UK countries, but across all 4 of them. But the screening programs that do exist now, we need to kind of understand a lot more about how we target groups and get the right information to groups to make informed choices about screening. If we look at bowel uptake, for example, bowel screening doesn't just detect early stage cancers and enable much more treatment options. It's about preventing cancer, detecting polyps, removing them before they become cancerous, so preventing kind of cases for kind of in the 10 years kind of future. So huge preventative elements as well as a cancer early detection element to it. We've got about a 20 percentage point in uptake between the most deprived and the least deprived. We're clearly not getting the right or same amount of information for people make informed choices about screening. Otherwise, we'd see that kind of much closer together. We're doing much better with cervical, so other things kind of learn from that. But with bowel screening, there's much more that we need to do there. That kind of gap that we're seeing between deprivation, we need to really get the right targeted interventions and drive up informed uptake of screening. Again, as we kind of go through different metrics, we see it in every place. These are just a kind of collection of cancer sites. Emergency presentations are predominantly linked with late-stage disease, with fewer curative treatment options. It's a big challenge on the health service too. There are links to people either not presenting earlier with symptoms or challenges of accessing their GP or referrals from primary care through to secondary care or delays in secondary care. So there are challenges which lead to why people do present as an emergency. But across nearly every cancer site that we look at, we do see this increased proportion of emergency presentations amongst the most deprived. And that clearly is an area right across the system that we need to look at and try to improve. It's linked very closely to stage of diagnosis and late stage disease. This is just a handful of cancer sites that we looked at, probably a bit old now, so the figure is probably much higher than this. But if we applied what we were seeing in the least deprived across all the deprivation groups, we would get much higher numbers of early stage disease, where we've got much better curative treatment options and improve outcomes as a result of it. And all these things kind of manifest really it's not just about the presentation of people, it's also about how we get people through the health system. One of the things that we looked at trying to understand was the chance of waiting long times or long waits for cancer. We've got the 62-day pathway in most countries across the UK. We've got targets to hit that. Looking at those who present at GPs with red flag symptoms that should be referred urgently. 62 days is the target. We've got a kind of measure of 104 days, which is over 3 months. So these are really long waiters. We've seen an increase in this. I think we're about 10% of those referred are actually long waiters. It is a big challenge at the moment, and one that really needs to be addressed. But when we look at it and break down by deprivation and understand that deprivation impact, again, we've got that step change with every quintile that we look at. We look at the most deprived, a third more likely to be these really long waiters. That's not just about the presentation, that's about how the experience through the health services, and have we got the health services there that are there for everyone? Have we got the right understanding of what's going on? We need to really make sure that we target and understand why we're seeing that massive variation, those huge proportions of inequalities in long waits. And all these things kind of come together and manifest in outcomes. We looked at applying mortality rates for the least deprived across every quintile, and trying to understand what would happen if we actually had the same level of mortality from the least deprived across all the other quintiles. How would that manifest? Over 22,000 cancer deaths every year that we could reduce it by. So just socioeconomic deprivation, this is the impact of it. If we talk about outcomes, this is what's happening. It's a huge proportion of the cancer deaths that we have each year that could easily be avoided. And when I kind of talk about the outcomes element of it, it's not just about mortality. We have higher incidence rates, which are kind of 20% higher. I've got an example just of lung cancer survival here. Again, big differences in 5-year survival. And indeed, if we kind of come to mortality rates, that's where we really see this a result of all the things that we've kind of seen previously. Nearly 80% higher mortality rates in more deprived groups. So the inequalities that we're seeing from socioeconomic deprivation are evident everywhere, and we're not making progress. There are things that are kind of coming on that we need to kind of appreciate. We've got the tobacco and vapes bill, which I think went through the committee stage of the House of Lords yesterday, which was great to see. And that's going to be a fantastic impact on us not starting smoking in this country. But as stressed earlier, actually we've got big differences in that kind of 2-decade difference in smoking that we need to really address. And so there's lots more that we really need to do. And some of the things that we are kind of focusing on in our inequality strategy is about the things I'm just going to take you through of improving access to health information for everyone. We need to increase that reach of information, but we need to make that and do that in ways that are relevant to the different people in the population, that are accessible to the different people in the population. Different people have different needs and different ways of accessing information. We need to make sure that we get that right. We need to focus on tobacco and overweight and obesity. They are by far the largest risk factors. We see these big differences by socioeconomic deprivation, and we need to make sure that we have the right interventions in the right areas for the right people. Cancer screening and those targeted interventions to drive up informed uptake of bowel screening in particular, which has massively fallen behind by socioeconomic deprivation, it is really important. As I say, it's not just about the cancer impact, it's about that preventative impact too. We need to ensure that help seeking and timely presentation of symptoms targets those most in need, and with that we need to support health system to implement the most effective approaches for recognising and referring people. We need to support the health systems and policymakers to ensure we've got the robust data on unwarranted variation. And we need to implement recommendations from existing audits. We've got some fantastic clinical audits in this country that make recommendations. We need to make sure that they can be implemented and that health systems are supported to do that. We need to advocate for health systems that work for everyone affected by cancer. We see variation in workforce by deprivation, for example. We've got fewer GPs in poorer areas, which, as you can see from the evidence, is the contrary. They're the ones that need more GPs. They have higher demand for healthcare. This is where we're seeing the higher kind of rates of cancer. So we need to really kind of focus on that workforce and make sure the workforce is there where we need it. Both Dr. Singh and Professor Nakmi have mentioned before about data. For me, it's not just about kind of improving the data required to tackle inequalities. There are data that are captured as part of the health systems that people just can't access, who want to access it. And yes, we need to make sure that's accessed safely and securely, but we need to make sure that there are researchers, that there are organisations who are wanting to understand inequalities and really get to the root causes of them and understand how we can make improvements that can't access the data that already are recorded. So how do we make that better? How do we make sure that we can make the best of that, access it where it's required and collect it in areas where we don't have the evidence yet? We need to make evidence-driven decisions about interventions. We need to make sure that they are there. We need to foster innovation, and we need to evaluate and encourage adoption and the spread of interventions that address inequalities, but we need to make sure they're not just implemented amongst certain groups or those that would have less impact. We need to make sure that innovation really gets into the places, gets into the populations that need it most. And again, echoing what Dr. Singh said earlier, we can't do this alone. Collaborative work is essential in all of this. Wherever we're trying to tackle inequalities, whichever groups in the population we're looking at, the only way that we're going to make progress is through collaboration across different organisations. It's vital, and I was really pleased to see Dr. Singh mention that earlier, and I really just wanted to echo it and repeat it again. We need to work together across organisations. We have to do this hand in hand. We need to get the right experience from the right people, whether that's about understanding different groups in the population, how we communicate to them, understanding the evidence and translating that, getting the clinical involvement into it. We are all here wanting to try to reduce inequalities and the effect that we have on cancer, and we must work together in order to do that. So thank you very much to Bookie for organising today and getting us together so we can talk about this more, and I look forward to the discussions and presentations that we have today.
Thank you. So, John is still here, and want to open up for any question. He makes everything simple, but I think that we can ask him a lot of questions. Yes, there's a hand.
Hi, John. It's Mo. I'm one of the respiratory physicians. Amazing talk, really insightful. It just comes to my attention, the slide about removing deprivation and how that impacts late stage, because we know data from the lung cancer screening audit that despite the rolling of the targeted lung health check, there is still 30% emergency presentations coming with late stages. Do you think lung cancer comes at the bottom of the list because we are not good diagnosing it and looking into researching it rather than removing the deprivation, especially with smoking prevalences still being so high? Is that the reason why it's on the bottom of the list rather than that removing the deprivation would be least impactful on it?
Can you use the microphone for this?
So I just step forward to try to hear you a bit better. So sorry, what was your question? Sorry, just to, if you could give the microphone back to the gentleman, please. Sorry, my hearing's not fantastic. Was it that why is lung cancer at the bottom of the list in terms of late stage presentation?
Yes, that removing deprivation would not, it's the least impactful in terms of all other cancers. Okay. Despite that, emergency presentations remain the same with late stage.
Yeah, I mean, emergency presentations are reflective of different elements and are reflective of the symptoms that kind of come with them. In terms of a stage, we are seeing late stage across most deprivation quintiles. We have a big challenge of, especially in lung cancer, of that late stage disease, which is why targeted lung health checks screening is going to be helpful. But we need to do much more generally on lung cancer in order to detect those cancers at a much earlier stage. And that needs to understand different impacts for different people in the population. We need to understand the disease by different groups of the population to do that. It's not going to be just a one-stop kind of solution to that. We need to really understand how can we get better early diagnosis. I say that the lung screening is going to help, and the quicker we get that rolled out, the better. But the reason why we didn't see as many numbers in lung cancer with the by-stage disease is that because generally across everyone we are seeing late-stage disease, and that's the big challenge that we need to kind of get through, but we need to understand that for different groups so that we can get that right.
Thank you, John. Is there any other question for John? Okay. So we'll have a 15-minute break, and John is still with us. During break, I'm sure we can ask more questions. Thank you very much for your time. Let's have some break. Thank you, John.
Hello, can we come in and have our seats? The next session is starting. Can we grab our seats? Ladies and gentlemen, can we grab our seats? I'm going to ask for a favor. If we can fill the seats in front of you, the session is being recorded and there are a lot of empty seats in front. So if it's possible, those at the back, please can we move forward and just fill the seats in front. Yeah. Also, please take a lot of pictures, use hashtags. The hashtags are CHD 2025, LGCW 2025, and please share what you've been learning so far and what you learned during the day on social media. I'm sure a lot of people want to be here, but there's loads to learn, so please share what you've been what you've had the opportunity to learn today. So the next session is one that I always look forward to because it's about research, and it's spotlighting the early career researchers, especially in an area which we know that there's paucity of data and we don't get a lot of publication about this. So without much ado, I'm going to hand over to Aruni and Neil, who are going to handle the Vanessa Moss session.
Hi, sorry, I'm Aruni and I'm the bad cop today, and you're...
I'm Neil. I don't think anyone's ever called me a good cop, so...
Cool stuff. We come to the business end of a very rapid fire and an oral presentation on the Vanessa Moss Prize. We had around 30 high quality abstracts and really hard to select 10 of them. In the interest of time, to tell you more about what the Vanessa Moss Prize is all about and a brief history of it, I'll call upon Dr. Susie Stanley, my mentor figure, to go through it.
Thank you very much, Aruni and Neil and Buki for today. So Vanessa Moss was a beautiful, vivacious, gorgeous, curious child born to family friends of ours. And she received the devastating diagnosis of neuroblastoma when she was 4 and underwent 5 grueling years of multimodality treatment before she very sadly passed away. I can think of no better way than contributing to her legacy and to her spirit than this award. And thank you to everybody who submitted abstracts, and really looking forward to hearing and seeing this work being showcased from around the world. Thank you very much.
Right, okay, here comes the bad part. So, and I'm pretty tense about this. So 10 abstracts, 10 posters to go, so 6 in-person e-posters. Everyone has a time limit of, I said 5 minutes initially, so let's put it down to 4 minutes. Sorry, I'll be hated for this. Cool, 3 minutes for telling stuff about it and 1 minute extra for Q&A, but we can go to 4. Apologies, I'll be really hated for this. So first of all, we've got Jojo, or Jocelyn Kirini Tan from the University of Manchester talking about AI-assisted MRI. Jocelyn, would you want to come up? Amazing. Don't be afraid, all the best.
Good morning, everyone. My name is Jocelyn, and today I'm presenting our work on evaluating whether AI-assisted bioparametric MRI, known as BPMRI, can serve as a practical, lower-cost alternative to multiparametric MRI, known as MP-MRI, especially in low and middle-income countries where MRI access is extremely limited. The PROMISE trial in 2017 established that MP-MRI as the pre-biopsy reference standard for clinically significant prostate cancer. However, MP-MRI is expensive, contrast-dependent, and slow. These issues are amplified in resource-constrained settings. The recent PRIME trial challenges this standard by showing that BP-MRI, which removes the contrast-enhanced sequence, is cheaper, faster, and diagnostically comparable. This raised 3 questions for us. First, can AI further improve BP-MRI or MP-MRI performance? Second, if BP-MRI is faster and cheaper, how much money could health systems save? And third, could this help expand MRI access in LMICs? We conducted a systematic review of AI models for detecting clinically significant prostate cancer using BP-MRI or MP-MRI assessed using the tripod checklist. We also conducted a budget impact and capacity model estimating how switching from MP-MRI to BP-MRI could affect costs and scanner availability in LMICs. We searched Medline, Embase, Scopus, Cochrane, and PMC from 2010 onwards. Out of 6,389 records, 202 full texts were reviewed, and 6 studies met our criteria. All of them were multi-center, multi-vendor studies comparing AI with radiologists on pre-biopsy MRI. For modeling, we ran 2 scenarios. A conservative scenario assuming 10% MRI referral rates and $100 per scan savings with BP-MRI, and a realistic scenario assuming 25% referral rates and $200 per scan savings. In both, 1 scan per patient was assumed. In our results regarding diagnostic performance, across all 6 studies, MP-MRI AI pulse sensitivity was 0.884 with a specificity of 0.68. BP-MRI AI sensitivity was 0.65 with specificity of 0.93. And then the PROMISE standalone MP-MRI sensitivity was 0.93. And AI-assisted BP-MRI achieved 0.97 sensitivity, which is the highest observed. Areas under curve were similar, with 0.84 for MP-MRI AI and 0.88 for BP-MRI AI, with BP-MRI AI reaching 0.92 in 1 study. Taken together, AI-assisted BP-MRI performs comparably to MP-MRI, with potential advantages in standardization. Regarding budget impact and system capacity, in our conservative model, switching to BP-MRI yielded 19,744 MRIs performed, meaning almost $2 million were saved annually, and 1,600 extra scans per machine. This increases capacity from 3,200 to 4,800 scans annually. In our realistic model, 49,361 MRIs were performed, meaning almost $10 million were saved annually, and the same 1,600 scan capacity increase per machine. Scaling up to all LMIC MRI systems, this implies a global capacity gain of 7.35 million scans per year, equating to roughly $2.2 billion saved. To conclude, BP-MRI with or without AI offers diagnostic performance that's comparable to MP-MRI. It is faster, cheaper, and more operatively feasible for LMICs. And switching to an AI-assisted BP-MRI workflow could deliver substantial cost savings and, importantly, free large amounts of scanner capacity. These gains could directly support reduced waiting times, improved early detection, and more equitable access to prostate cancer imaging globally. Thank you very much for your attention.
Jocelyn, one second. Any questions for her? I know she wants to run away, but any questions for her? No questions for her? No hands up? Fine. So we'll move on to the next one, and I can say for certain you can see my name on the last author of that paper. I did not use any underhand means of being judged. So yeah, just a declaration. Next up is Archana Sood from Kingston Hospital, talking about amplifying underrepresented voices to shape cancer care. Cool.
Salam, namaste, annyeong aseo, ni hao, bunaziwa, and vanakkam. This is how I begin every presentation in Kingston. Because connection starts with recognition of language, identity, and belonging. In 2022, at Kingston and Richmond NHS Foundation Trust, our review of the National Cancer Patient Survey uncovered something unsettling. There was a silence. And despite having a huge ethnic group of Koreans that make up the population in New Malden, their voices were absent and they weren't alone. The perspectives of Hong Kongers, South Asians, and our growing refugee communities were missing too. Their stories just weren't being heard, and their experiences weren't being captured. And that silence revealed something important. Our systems weren't designed to meet everyone where they were. So we decided to change that, and in 2022-2023, I led a project called Building Bridges. It was an initiative to take cancer awareness, education, and listening directly into the heart of underrepresented communities. We left clinics behind and we stepped into community halls, churches, temples, and refugee group gatherings, places where people already felt safe and seen. We worked alongside community leaders and interpreters fluent in Cantonese, Korean, Urdu, Arabic, and Romanian, and we were supported by our cancer teams. We built an approach rooted in trust, not transactions. And each session began with a warm greeting and a smile. We made cancer care tangible. We used plain English, clear visuals, culturally relevant images, and we replaced medical jargon with understanding and fear with familiarity. We brought real items like a bowel testing kit, the various sizes of speculums that you can get, mammogram images, to demystify procedures and make the information more tangible. We used food examples that made sense culturally. We used humor, and we used interpreters who translated emotions and not just words. We then asked the questions, what matters most to you about your health? What stops you from seeing a doctor? How can we make this better for you? But most importantly, we listened. The answers were honest and humbling. There was fear of stigma, lack of trust, confusion about the NHS, language barriers, uncertainty about what happens after their diagnosis. But the communities also told us what would help, and that was interpreters, continuity, and reassurance that the NHS is for them too. Over time, our consistent presence built confidence, and the communities began inviting us back for more and more talks. So to just share a few stories, Mary was a refugee who came to one of the talks I gave on cervical screening. She recognized her own symptoms, she sought medical help, and was later diagnosed and treated for cervical cancer. Today, she now joins me on our cervical cancer talks and tells her story to the other refugees, helping women understand the importance of screening. Rani was aged 78, had avoided breast screening for years due to stigma and fear. After attending our session for Asian elders, she agreed to be seen by a female radiographer and was later treated successfully. She now supports other ladies in her community. And then there's Derek, a man from a local autism group who finally felt confident to use his bowel screening kit after we used accessible tools and easy-to-read guides. His test led to early diagnosis. These stories show how awareness, trust, and understanding can literally change and save lives. The ripple effect has been really powerful. Refugee groups now know how to use screening kits. The North Korean communities have asked for regular health talks. Our Asian elders proudly display the South Asian Eat Well plate in the Eat Well poster in their centre, and more patients are accessing our services in the Macmillan Centre at Kingston Hospital. By the end of 2024, we had delivered more than 20 sessions, reaching over 300 individuals. Our work didn't end in the community. We redesigned our patient leaflets, we translated summaries, and culturally inclusive images were included. We created a health inequalities group at the hospital to embed these lessons into all our cancer services. And we did it cost effectively using existing partnerships and the core 20+5 framework. In conclusion, what we learned is simple. Health equity isn't a poster with a diverse face on it or a translated leaflet. It's sitting beside people in their spaces, sharing food, listening without judgment, and asking, what do you need to take control of your health? When we amplify underrepresented voices, we don't just improve services. We restore trust, we restore dignity, we embed equity into care. My role was to help build bridges, but it is the voice that crosses them that will shape the future of cancer care. Because when every voice is heard, every community belongs. Thank you.
Any questions? All right, we'll go on to the next speaker. One of my great friends, Lin Chen from the University of Glasgow, is trying to explore supportive cancer care disparities among ethnic Chinese immigrants in Scotland. Lin, would you come up? Thanks.
Hi, everyone. Hello, everyone. Thank you so much. So my name is Lin Cheng. I'm the final year PhD student in University of Glasgow, Scotland, UK. And today, I'm honored standing here to give you the presentation of my first two phases of my larger PhD project. So the exploring the supportive cancer care disparities among the ethnic Chinese immigrants in Scotland, insights from a mixed method study. So as we all know that the ethnic Chinese immigrants are one of the fast growing minority groups who face the barriers to cancer care, including the language, culture, and the difficulty in navigating the healthcare system. And in 2023, the Scottish government launched a new 10-year cancer strategy with the aim to improve the cancer care to all groups. However, the ethnic Chinese immigrants are still underrepresented in the research. So the overall aim of this first two phases mixed method study was aimed to investigate their health-related quality of life, their unmet needs, and the care experiences of ethnic Chinese immigrants affected by cancer in Scotland, and with the aim to informing the culturally sensitive supportive cancer care strategy in the future. So as I said at the beginning time, this is the first two phases of my larger PhD project. So the overall PhD project was a theory driven, underlining by the patient-centered care theory. This mixed method study using three methods for the sampling. So the convenience, purpose, and the snowball sampling method. We did the public engagement sessions to do the data collection. We advertisement the recruitment poster put on the social media. And the data collection time was from November 2023 to June 2024. And of course, the overall project has got the ethic approval from the University of Glasgow. So as an explanatory sequential mixed method study design, the first two phases started with a quantitative cross-sectional survey. We're using the FACT-G for patients and FACT-G caregivers, FACT-G caregivers for caregivers group. And for the patients group, we supplement with the supportive care, cancer care, short form 34 for patients also. And all these data collection instruments, we provided the 3 languages version with the English, simplified Chinese, and traditional Chinese, depending on how about my participants' preference. And the data analysis was by the descriptive analysis. And in terms of the following up phase 2 interview, and we did the semi-structured interview either by phone or by Teams, also by the preference by our participants. The overall data analysis was by the inductive and the relativist thematic analysis. Okay, so you can see that. So after 7 months, the data collection evolves. Finally, for the phase 1, we got 24 patients and 13 for caregivers group. And the overall is that the caregivers group reported they have the lower overall well-being comparing with the patients group, and particularly in their social domain, emotional and functional well-being. And both patients and caregivers group, they suffered with more with their emotional well-being, with the prevalent reported problem is the fear of cancer progression. And you can see that so over 62.5% of patients, they identified they need information, and followed by their psychological concerns. And in terms of the interview, after doing the thematic analysis, we find that both patients and caregivers, they shared this reputation is that the presence of the cancer, of the culture taboo that encouraged the security and the silence around the topic of the cancer, displaying the heavy burden of the cancer-related stigma between the patients and caregivers group. And also, they, as the immigrant in here, they, without extended family support, this makes this face the much challenges. And both of patients and caregivers, they emphasize the importance of the tailored information prevention. And so they emphasize that they prefer the bilingual written resources, and they want it was provided by the hospital. And both patients and caregivers, they value the development of peer support groups with a shared cultural background to address the information and the emotional needs. So today, I'm giving some take-home message from my first 2 phases of my PhD project. So addressing the unmet information needs and supporting the caregiver group are crucial to improving the cancer care for this population. And the future research should consider to engage stakeholders and co-design the interventions to ensure the supportive cancer care are both culturally appropriate and accessible. And finally, there is a dual challenges for the posed by cancer and also the migrations together, which makes the health and cancer care disparities among this population group. And thank you so much.
Don't run away. I can see Kofi's hand raised up, and I'll pass on the...
I want to find out more particularly with the qualitative data. The 6 patients that you got and then the 5 caregivers, were they from the 24 patients and the 13 that you had already used for the phase 1?
Yes, so thanks for asking me this question. So in terms of the phase 2 study, so the patients and caregivers, they came from the phase 1. I will leave a question at the end of the questionnaire. It says, if you are interested to taking part in the following phase 2 interview, you can leave your email and then we can follow up to you. So all the patients and caregivers, they came in from the phase 1 survey, and also it can be linked as a whole mixed method study.
All right, thank you. Yeah.
Any other questions? No, so we will move on. So, Naman Julka Anderson, have you ever emailed him? When you emailed him, the email signature's 50 lines long with 40 awards. Every time, that's the email I get from him. So he needs no introduction. He started the Rad Chat podcast, one of my favorite podcasts. Sorry, I'm taking a bit of time. Naman, would you come up and he's going to do the next rapid fire presentation.
Thank you. I will say, Bookie said a month ago I had 10 minutes and now it's down to 3 minutes. So I'm going to do my best to try and combine everything. So thank you for this opportunity. My name is Naman. I'm a therapeutic radiographer, allied health professional clinical advisor for Macmillan, and co-founded Rad Chat, which is a podcast education platform with Joe McNamara, who's watching online. So this journey kind of started 4 years ago for me, when I experienced watching Black and South Asian patients be dismissed for their pain, their skin changes, etc. So watching that structural racism in real life, I think from a professional angle, when I've already experienced it as a person, I guess, with my lived experience, was quite scary. But then to notice that lots of professionals didn't know anything about different skin changes on black skin and brown skin especially. So looking for redness, that's kind of where it really started to light the fire, and actually hearing the quote every time from professionals that, well, textbooks only show white skin, but we need to do something about it. So since then, speaking many different times, and yeah, having a long email signature, which is quite nice, but then changing consent forms, triage tools, etc. But actually realizing that changing terminology isn't enough, is actually you need to see what's going on. So Rad Chat started off as an oncology podcast in the UK 4 years ago. We're now in 141 countries. We're a trusted resource, CPD accredited. I think that trust is what was really important to take this image library forward. So last year we wanted a website. Joe and I do all of this in our own time with our own funding. But we did our research and found that actually medical image libraries are mainly dermatology based, with medical photography, but apart from Mind the Gap, which was quite a few years ago now, actually people of colour are often made an afterthought. So a huge unmet need for our patients, and obviously a crucial point, no funding and no time for Joe and I to write the lengthy grants. But I'm sure Joe will agree. We agreed that, well, what have we got to lose? Let's put our own money in. We'll start an image library on the website, use our personal time and resource and see what happens. So we worked with some amazing charities like Black Women Rising, some South Asian charities, outpatients, just to see what people with lived experience wanted to see for images online. So do they want to see complete images like this, where it shows quite a severe skin reaction, or just some generic stuff, and actually even some of the professionals that we spoke to as well. But nearly all the people with lived experience said that they preferred crowdsourced images, as they can't create those perfect conditions at home. One black woman, who's a friend of mine now, said that actually she doesn't want a white professional with a fancy camera taking pictures of her chest, which has already been butchered by an arrogant white beep/surgeon who didn't know anything about black people. She wants to see someone's radiator in the background, someone's wig or bra hanging up on the door behind the photo, because that's real and that's what she can trust. I think that shocked me, thinking medical photography is the best, that's what we want, but actually it's not what all patients want. So we started off, I think, about 60 images on our website at the moment. We've got 2,000 more coming, thanks to some amazing people in Bermuda who are helping. So we're a free CPD resource with oncology-based images, so some of the ones are on the screen, so skin changes, but not just oncology. We realize actually even allergic reactions aren't really represented. So my anaphylaxis training only showed white skin, and actually I've got a friend with black skin who nearly died because the professionals didn't realize that her neck looking grey and solid where she couldn't breathe, that was her having an allergic reaction. So she's shared the images and they're on our website, and these images are being used in exams, guidance all across the world now, which is amazing. So crowdsourcing the images, but we have a medical legal consent process, so we're not just taking images and doing things with them. But actually we're self-sustainable, so a bit of a call or shout out to all of you if you have any people, friends, family, patients, or if you've got an interesting scar that looks different on your skin type, we're trying to crowdsource it and obviously anonymize things. I think very proud to be able to stand here with quite a few of the legends and health inequalities who've spoken today and in the crowd, but I think we're just going to keep trying to use the coalition going and trying to crowdsource more images. Lastly, I think I'm running out of time, but there is, so Sarah Adomo is in the crowd, and I think Natalie Evans isn't here today, but there's a letter being spearheaded by these people and Gilead going to, so Gilead's at the back, the pharmaceutical company, around better access for wigs, for afro hair, for prosthesis, for black women. So at the moment, there isn't really enough access to prosthetics, appropriate for skin types, but just as a call out, if you want to be part of this sort of work, so some of this work is feeding into this amazing letter going to the government. It'd be really nice to hear from all of you so that we can keep this momentum going. So thank you.
Any questions for Naman? No? Any hands? Okay, no questions for Naman. One question from me. When am I getting on to Red Chat podcast?
Whenever you like. Yeah, have anyone on. So I think we've already asked you. You didn't respond to my email.
Oh, sorry. Oh, that was a low blow. All right, it's time to bring up the next speaker. That was a low blow. Elise Bautista Gonzalez works at the IARC in France. She's going to talk about the Mexican situation of cancer resource distribution and the disparities. Off you go, Elisa.
Hello. Right, so this is Mexico, many maps of Mexico, as you can see. So we have a rising cancer burden in Mexico. Sorry, I forgot to introduce myself. I am Elise. They already introduced themselves, but I'm actually working currently in IARC. But this is work that I conducted with FunSalud in Mexico. As I said, we have a rising cancer burden in Mexico, and we knew from patients and from health stakeholders that there was uneven access in infrastructure for cancer patients. But we didn't really know exactly where these service gaps were. So there was a need for clear national assessment. Therefore, our objective for this study was to map the services from the Ministry of Health, the facilities for 5 types of cancer, for breast, lung, prostate, colon, and cervical cancer. So we were aiming to identify availability gaps, misalignment. We conducted a realist evaluation of a publicly available national database that was actually then closed after we published this. And we gathered some experts to define what were the most important resources needed for diagnosis and treatment for each one of these cancers. We continued on to classify these facilities into diagnosis and therapeutic. And also classify the facilities into core, so core cancer care services versus enhanced services that were not only providing cancer care, but also nutrition, therapy, rehabilitation, psychological services, etc. And on top of that, we overlaid the municipal population density to just check where exactly these services were, and if there was some regions in Mexico that were just left behind. So we found about 14,000 facilities in the Ministry of Health, and from those, only 5% provided any type of cancer care. Most of these were diagnostic heavy, which meant that it would only help patients get to diagnosis, and limited amount of them were providing both diagnosis and treatment. And in terms of the enhanced infrastructure, only 60% of these facilities were enhanced, which meant providing, in addition to cancer oncological care, nutrition, therapy, psychological services, rehabilitation, and other, expanding quality of life services. In addition to that, as you can see, there's a QR code if you want to see the big maps, because they are little dots marked in red and yellow. But basically what we found is that each cancer type resources were not really aligned with the epidemiological burden. And not only that there were differences between the cancers. So there was more infrastructure for some types of cancers that compared to others. There was strong centralization around Mexico City, which is 25 million people. It makes sense. But there's other cities that are also in the millions where there seems to be some gaps. As I said, there's some map cues. Basically, blue is the population density, and the dots marked in red are the facilities. And in yellow, there's the facilities that provide treatment. As you can see, there's almost no yellow. So we basically conclude that there is definitely some structural limitations that render incomplete pathways. And this basically is kind of explains all of these stories of patients saying, I take a plane to go to Mexico City to get treatment. I drive for 6 hours. And I think we have to start building health systems that are geared for patients dealing with cancer and not making them fly 6 hours and spending all that money. So our recommendations is to obviously expand to full enhanced service facilities, to relocate resources towards high density areas, to decentralize not only nationally but also regionally, and to ensure that there is equitable allocation of resources per cancer type. So this is one of 7 studies that I led in FunSalud, and if you have any questions.
That was extremely forthright of you. Do you have any questions? Do we have any questions? Oh, I see one at the back. Sorry about that. You shouldn't have.
Yeah, thank you. Good morning, everybody. It's so interesting that you said a lot about major cancers that there is in Mexico. But is there no resources, or is there nobody that has gone through pancreatic cancer at all? Because it's like, I know that pancreatic cancer is is increasing now. And I've not heard anything about pancreatic cancer. And I'm a little bit worried.
Yeah.
Yeah, thank you.
Yeah, we definitely focused on these 5, and there was obviously limited budget constraints. We wanted to do so many more, including like childhood cancers, but we were just limited in time and budget. So we decided to go for what was, epidemiologically the most burden. But definitely, I think that's very important to look into other, even like hematological cancers and other types of cancers in general, to just map where exactly we are in Mexico. Yep.
No more questions? Fine, okay. Thanks, Elisa. Last of the in-person presentations, Odunola Atitebi from Cancer Survive UK is going to talk about community-led interventions for Afro-Caribbean people living with cancer in Manchester. Stage is yours.
Good morning, everyone. My name is Odunola Atitebi. And today I'm talking about Living Beyond Cancer, a community-led intervention for African Caribbean cancer survivors in Manchester. Despite the rising cancer survival rates, outcome disparities still persist, especially in underserved communities. It is an established fact that clinical survivorship does not guarantee emotional, social, and nutritional recovery post-cancer treatment. To address some of the unmet needs that are reflective of individual needs post-cancer treatment, a project titled Cook and Thrive was co-designed with African Caribbean cancer survivors to address some of their unmet nutritional needs. The aim of the project was to encourage participants to feel more connected, feel less isolated, and to build healthier habits following their cancer treatment. Over the period of 6 months, that is from November 2024 to May 2025, 12 cooking sessions were delivered to 17 participants. And to monitor the impact of the project, pre- and post-project surveys were used to gather feedbacks from participants. Quantitative data was analyzed using the Wilcoxon sign rank test in a software known as Jamovi, and qualitative feedbacks were also thematically analyzed to get key terms from participants' feedbacks. The project had 5 outcomes, which are nutritional knowledge, cooking skills and confidence, social connection, frequency of access to nutritious meal, and overall well-being. In 4 out of these 5 outcomes, significant improvements were observed, which are nutritional knowledge, cooking skills and confidence, social connection, and overall well-being. From the quantitative data, the numbers are there, and you will find out that for nutritional knowledge, that was where we observed the highest impact. Just to give a clearer understanding of the quantitative evaluation, the graph above shows the extent to which the changes were observed before and after the project. For the qualitative feedbacks, we had 3 key themes, which are motivation and empowerment, cultural connection, and healthier habits. For the team motivation and empowerment, participants were always looking forward to come to the cooking sessions because it made them feel connected. For some of them, it reminded them of their childhood because they could prepare meals that they used to cook back at home. For example, the famous ackee and saltfish for the Caribbeans. For some of them, it was their first time trying new things, such as using a smoothie bag to make smoothies. In conclusion, the Cook and Thrive model demonstrates how holistic participatory support from a culturally aligned charities such as Cancer Health UK can complement medical survivorship care. Findings from this project highlight the importance of integrating culturally competent community approach within broader cancer support frameworks to reduce disparity and promote recovery. Beyond this project, to ensure that participants are continually encouraged to pick up healthier habits, and for also the wider community members, all the recipes from this project were collated into a cookbook titled Cook and Thrive. For anyone that would like to have copies of this, please feel free to approach me. Thank you.
Kofi, up to you.
Yeah, thank you. Brilliant study. I was just trying to find out whether you just decided to use the 17 participants, because this is a very brilliant thing that maybe you could have expanded the scope wider. I don't know whether you have anything.
Thank you for the question. So we had 33 people register for this project, and that's a combination of cancer survivors, their families, and carers. But because it's cancer and some people are still going through treatment, some of them could not attend more than once. So we had like a high dropout rate, and for obvious reasons, it's cancer. Some people felt tired, they couldn't come out of their homes. So that's the reason why we couldn't go beyond that number. And we are hoping that in the future, we'll be able to scale up this project. Thank you.
Wonderful, thank you.
Any other questions? All right. I'll pass it over to the good cop over here, Neil, with the hybrid session.
Hi, thanks, Aruni. Before we go any further, I just want to say the way these sessions run, when they run efficiently, it's because there's a lot of organisation. So I'm going to thank Aruni for organising this and doing so much work. My role in organising this has basically been disagreeing with Aruni and asking Aruni questions. Right, so now we're going on to the session that probably isn't going to work because a lot of it is virtual, but we're going to try our best. I think, is it saying Fumaloli can't present, so we're going straight to the second one. Yeah, so we've got two people who are joining by Zoom. So first of all, we've got Delphine Lablina Francis. So she's from Savitha Institute of Medical and Technical Sciences, Chennai, India, and going to be talking about the effectiveness of brief anti-tobacco counselling and cancer awareness in behavioural change among Malayali tribes of South India.
Yeah, am I audible?
Go ahead, please.
Yeah, hi. Yeah. A very good morning, one and all. I'm Dr. Delphine Francis from India. I'm here to present my topic on the effectiveness of brief anti-tobacco counseling and behavioral change among Malayali tribes of South India. It's an 8-year follow-up study. The Malayali tribes of India, I want to talk a little about that. Malayali tribes of India are very unique and unexplored group of tribal community in India. So, oral health is critical to overall well-being and quality of life. The tribal communities in India often have limited access to preventive and curative healthcare. The Malayali tribes of Eligiri Hills are present unique oral health challenges due to cultural and socio-economic factors. The Imperial Gazetteer of India, 1911, defines a tribe as a collection of families bearing a common name, speaking a common dialect, occupying or professing to occupy a common territory, and is not usually endogamous, though originally it might have been so. The tribal healthcare delivery system remains underserved despite the medical advances whatever we have here in India. The cultural beliefs and practices contribute to high tobacco use and poor oral health. So there is an urgent need for targeted behavioral interventions. The aim of the study was to assess the effectiveness of brief anti-tobacco counseling in achieving behavioral change among the Malayali tribes in Eligiri Hills, Tamil Nadu, India. And the objectives were to assess the prevalence of tobacco use and to evaluate the effectiveness of brief anti-tobacco counseling on the behavioral change. So here, what we found was the study actually started in 2010 as a small oral health camp where it was found that the Malayali tribes do face a lot of challenges and there was very poor oral health awareness. It was initiated as a small oral health dental camp, the dental-based camp. And further, it was developed as a cross-sectional descriptive study to assess the oral health status of that population. The baseline study was conducted in 2010, where 660 participants took part in the study. And further, it was followed up for 8 years. Every 3 months, the oral health advisors and the anti-tobacco counseling was given to the tobacco users on the spot and also during the community meetings and through the traditional healers and the community leaders. And then the same pre-tested questionnaire was tested among 2,185 participants in 2018. So the tools being pre-tested questionnaire, which had the questions about the tobacco use, oral health practices. And in 2010, the baseline oral health examination was done using WHO Oral Health Survey Methods 1997. So for both the surveys, the inclusion criteria was the Malayali tribes who were settled in the Elagiri Hills for more than 15 years and willing to participate in the study. And exclusion was those who were not willing to participate, and migrants were eliminated. So now I'm presenting the results which we found in 2010. From the findings, all those blue charts are the 2010 findings. It was observed that the Malayali tribal population exhibited very limited awareness regarding the oral health, deep-rooted dental beliefs, and high prevalence of oral diseases, reflecting inadequate access to prior dental care and considerable dental treatments. Tobacco use was widespread within the community. For example, even a 7-year-old chews tobacco. That was the condition in 2010 when the baseline data was collected. The primary reason which was cited by the participants was they were coping up with the cold weather. It's a hill station, small hill station. So it was stated that they were coping up with the cold weather, elevating the work-related stress and body pain. And it was all about the lack of awareness about the health risk associated with tobacco. So here the highlighting factor is there was very poor formal education. During the baseline data collection, it was seen like only 7% of the males and 3% of the females had secondary education, and primary education was for 44% male and 18% females. There was no formal education for the females. 79% didn't have a formal education. And the materials used for cleaning the teeth, charcoal was the highest. 69% male and 79% female used charcoal to clean the teeth. And tobacco use, there was very high level of tobacco use, like there were different types of tobacco. Both the smoking and the smokeless tobacco use was predominant, with BD and cigarette, the smoking type of tobacco, 41% of the male practiced, and raw tobacco chewing among 13% females and 12% males, and hunts, a type of smokeless tobacco which is being marketed, 52% among the male and 83% among the females. And the oral mucosal condition reflected of the tobacco use. About 40% male and 57% female presented with leukoplakia and ulceration, 28% male and 21% females with single leukoplakic lesions, and malignant tumor and signs of malignant tumor were found in 12% males and 10% females. So with all these, for 8 years, it was followed. Every 3 months, small campaigns has been conducted, along with more of traditional leaders and community leaders spreading about the hazards of tobacco, nothing else. So what we found after 8 years in 2018, a mass awareness camp along with doorstep activities were taken. So in that, what we found comparing both the data was, in 2010, the tobacco use was recorded among 42% males and 38% females, whereas in 2018, we could see that 36% males and 28% females were using tobacco. And also, after the implementation of this brief anti-tobacco counseling sessions by the primary healthcare workers during routine health visits, complemented by quarterly health education programs on tobacco hazards delivered by the village leaders and traditional healers, over this 8-year period led to a notable reduction in the tobacco use and an improvement in the community awareness about the tobacco-related diseases. So here I'm to conclude that health is a right of every individual. There is an urgent and indisputable need to develop targeted cancer awareness and comprehensive oral health care initiatives for the Malayali tribes of South India in order to promote health equity and address the ongoing disparities in access to preventive and curative services. Thank you.
Thank you, Delphine. It's really great work. Right, okay, we're now going to move on to the next virtual presentation. So that's Ahmed Nuira from the Prince Sultan Military Hospital in Saudi Arabia, Wellness Watch, Advancing Quality of Life Through Colorectal Cancer Screening. So can you hear us? Oh, you're there. Hi, Ahmed.
Yeah.
Go ahead, please.
Thank you. First, thank you all for letting us, giving us the opportunity to share our experience today. And I'd like to thank to everyone who spoke and who will speak today for sharing the knowledge and experience. Good afternoon to everyone. I'm Ahmed Nuir. I'm a public health physician in Saudi Arabia. I will share with you our project, Wellness Watch project from Prince Sultan Military Hospital, which transformed colorectal cancer screening and saved lives through a smart patient-centered innovation. Colorectal cancer in Saudi Arabia is the most common cancer in men and the second most common cancer in women, with rate rising recently. And when we are starting our initiative in our hospital, aiming to improve the screening to reach 6% of the target population. When we started, our baseline was 9% only. We found that this is due to poor education and some kit shortage and physician time limits. And there is a long delay in for the positive cases to reach the colonoscopy, which reaches 3 to 6 months. So we started to make focused PDCA, and we have a multidisciplinary team, and we launched a patient center personalized WhatsApp alert. We did send almost 50,000 messages with education, and we found that WhatsApp messages have a response better than SMS messages, and we found that many of even companies are using WhatsApp messages now. And also we make an appointment rapid access clinic, which receiving patient without any appointment, and we used AI chatbot for queries, and we have some cross-sectional agreement with our mother hospital to have only 2 weeks pathway for positive cases. In 5 months, the screening hit 67% with improve, which is beating our target was 60%, and all positive cases were referred 100% of them to have a colonoscopy. And we have some positive cases, and we have some precancerous lesions, which we started management early. We also get feedback from the patient. 99% from them were happy of our service, and we want to enhance it to other services in the hospital. We adapted for equity SMS and walk-in and hotline for non-digital users. And this aligns with our vision of 2030 of Saudi Arabia. We reduce the burnout and via nurse-led education and scale this in our region, and proving that technology plus collaboration delivers prevention at scale. Thank you.
Great, thank you very much. Thank you. Right, fortunately, we've got Fumilola on the call. So we now have Fumilola Warala from the Obafemi Awolowo University Teaching Hospital in Nigeria and Action Study Group, Toronto, Canada. The Action Study, a multi-center study to address global inequities in breast cancer, generic testing, counseling, and management in Nigeria. So over to you, Fumilola. Can you hear us? Fumilola? Yes, okay. Okay, so now it's with great pleasure I'd like to ask Suman Daz to come to the stage. We're going to have a 10-minute session from Suman Daz at the Institute of Breast Disease, NCRI Hospital, Kolkata, India, community integrated early breast cancer detection in LIMICS using BC-RAADS, the breast clinical reporting and data system.
Well, at the outset, I'd like to thank the organizers and the jury for selecting me for the prestigious award and for allowing me to present in front of you. So the topic we are going to discuss today is the problem of late detection in LMICs. If we look at the breast cancer scenario, it has overtaken all the cancers in female and has become the #1 with 2.3 million annual cases worldwide. If you look at the disparity, in UK, 1 in 7 women has a chance of developing breast cancer lifetime. In India, it is lesser than that, 1 in 22. But when it comes to the 5-year survival, you can see the distinct change. In UK and USA, it is 95%. In India, average is 65%, and in some rural areas, it is poorer than that. So there are issues with increasing incidence, late diagnosis, and high mortality. And when it comes to the low resource setting, it is not always the problem of low and middle income countries. We can have a pocket of low resource setting in high income countries also. So indeed, it's a global problem. When it comes to disparities, there are several areas where we find disparities in terms of awareness, late diagnosis, late initiation of treatment, infrastructure, and treatment accessibility and availability. We conducted a trial in 2018, published in 2022, to see what is the status in our practice. We could see 60% of our breast cancer patients, they present in stage 3 or stage 4. Median tumor size was 3.5 centimeter. And many of our patients, they gone for non-modern practitioners treatment that is called alternative medicine. So if you look at the natural history, that when the patient becomes exposed to some risk factors, the disease starts, it slowly grows, and then it metastasizes. If we compare the tumor size between Western countries and India, you will get a lot of early tumors in Western countries. In India, the average tumor size is 3.5 centimeter. So doing mammography, you can pick up these early lesions, but when I have a tumor of 4 or 5 centimeter, doing mammography is of no help to detect the cancer. Right now, our focus should be to bring down that 4 centimeter tumor to 2 centimeter tumor, then focus on mammographic installation pan-India. So we need to develop something with the clinical method or the clinical breast examination. We need to standardize that. So with that aim, we conducted this study. We all are aware of BIRADS, Breast Imaging Reporting and Data System. We just use the same principle to convert it to Breast Clinical Reporting and Data System, right? And this includes history and clinical examination. Based on our retrospective data, we included age, family history, genetic risk, radiation exposure, and in the clinical examination part, specifically we have included asymmetry, skin and nipple changes, lump features, and lymph nodes. All these points were given a specific score, and based on the cumulative score, we predicted, we came up with the BC-RAD scoring system, where the 1 stands for normal and 4 and 5 stands for highly suspicious of malignancy. Now we needed to test this in our population, validate this in our population. So we conducted one prospective trial of over 240 women. We wanted also to see whether this can be reproduced by the nursing practitioners and the peripheral health workers or not. So we included 3 groups: the doctors, the breast care nurses, as well as the rural healthcare workers. We taught them how to do a clinical examination and what are the points we want. After that, all these patients, they were evaluated by these 3 sets of healthcare workers, and all of them, they underwent as per evaluation as per the institutional protocol. We had a key threshold of BC-RAD score more than equal to 7 as malignancy prediction. These are our results. We could see that we had a sensitivity of 93.2%, specificity of 88.7%, with a good AUC to score it as a good diagnostic tool. We also wanted to see any difference. We could not find any statistically significant difference between the doctors, the healthcare practitioners, and the nurses. No early diagnosis is successful without an early treatment. So what we planned, based on the BCDAT score, our recommendation was if we have a BCDAT 1, then we go for a revisit after 1 year. BCDAT 2, you revisit after 3 months because some of the benign can grow into a malignant one also. BCDAT 3, a standard referral to a breast clinic. BCDAT 4 and 5, and expedited or fast-track referral to the breast clinic, because WHO GBCI has now set up a criteria of diagnosis to treatment start 60 days interval. So by referring these patients in a fast-track model, we could achieve that goal also. We have concluded with this trial that this can be a very good triage system which is evidence-based and which has included the history and clinical examination. This standardizes the frontline decision-making across all healthcare worker level. It maps each category to clear action pathway, ensuring timely referral and revisit. We believe that this can be an useful tool because it is simple, it is low cost, and it is scalable. This can enhance the early detection and reduces the diagnostic delay. To integrate this, because our results showed that this can be replicated by the nursing practitioners and healthcare workers also, so we can use these not only for the doctors, but also for the ASHA workers, the rural health workers, and traditional practitioners. Traditional practitioners are the truth in many countries like India. So we cannot throw them out of the system. We have to include them. We have to teach them how to detect breast cancer at an early stage. To next step, we are working on integrating AI and a digital version of BCRADS and then a national rollout. We have developed a low-cost model for breast cancer clinical breast examination, and we have conducted several teaching camps, RMP teaching. So far, 3,000 rural medical practitioners are being educated with this. With that vision in 2020, we established our Institute of Breast Diseases, Kolkata. We have now partnered with NBIA UK, several other international agencies. We have identified the key areas where we lack evidence. There we are working on those areas. Slowly we are moving towards improving cancer care in India and other LMICs. These are our projects. Now, if we want to throw away, if you want to take the disparities out of the system, then collaboration is the answer. So I am here to collaborate. Thank you very much.
Thank you. Great presentation. Is there any questions for Suman?
Thank you for the great presentation. I have a question and perhaps also a remark, because you say the 5-year survival in India is 60–65%. I think it's based on the Concord analysis. But is there also not a disparity in India? And is the registration now a big problem? Because perhaps that is a little bit too low.
Yeah, so true. In India, there are two Indias. One India will get all the modern facilities, and the other part of India which doesn't have the proper chemotherapy or proper basic breast conservation surgery facilities. So yes, of course, the lack of data is obviously there. So this is so far which is there in publication, right?
Neil, we've got one more question.
Hello, many congratulations, Doctor. I am Ranalini Sarkar, I'm from India as well. While going through your presentation, one thought stuck with me throughout, and I really wanted to ask whether, while working on the ground, did you come across any social stigma associated with the diagnosis part, or women not being able to maybe go for diagnosis in the first place?
Yeah, true. So there are some issues. We do a lot of groundwork. We do a lot of awareness activities there. And believe me, it is not the problem with the rural areas only. This problem also exists in the urban areas. So there are a lot of misconceptions. People, I always tell them that 1 out of 10 lumps will be a cancerous one. There is a common myth that biopsy causes cancer spread. So all these issues are there. We need to dig into the education part a lot to overcome this situation.
Any other questions?
No, right thing.
Just a quick question about the fast track. I saw that 3 groups were going to be put into the fast tracking. I was just wondering if you have had some thoughts about whether that will plug the fast tracking system, and you have like the numbers that will look like,
Well,
the numbers of patients, because you'll have more fast tracking, more women in the fast track. So I was just wondering if you've considered
I agree.
the capacity.
We need to make, before we roll out this pan-India, we need to make our system ready for that overburden, right? So those parts are being discussed with the health authorities, and we are now on the verge of establishing 1 breast clinic in each district to take care of this huge burden.
Farah Ginsberg has a question.
Thanks for naming me. That was an excellent presentation, very interesting work. I've had the good fortune to work in India with some colleagues at Japaigo's program in Uttar Pradesh and Jharkhand. There are so many issues regarding access to high-quality pathology and turnaround times, which is such a bottleneck in so many places in the diagnostic pathway. Coupled with, and they showed this in a major report with like 100,000 women going through a system, with all the measures taken to try to mitigate those losses to follow-up. Do you have a plan, and I saw there were many other studies, to include this approach as well as reducing the time to, and the follow-up issues? Yeah,
yes, true. Thank you very much for the question. So the model I showed, the clinical breast examination, there we have included another version of that where we teach how to do a core needle biopsy by the surgeons in the district, right? So a basic core needle biopsy is not available pan-India. So that actually a good quality pathology is another issue, but there we are trying to integrate digital pathology system, because the surgeon at the district, he performs the core biopsy, and the pathologist over there prepares the slides and etc. and uploads in the system so that an uniform pathological assessment can be given.
We've got one last question.
Yep.
Hello, my name is Rohana Sadat, CEO at Jamila's Legacy. Thank you so much for sharing your study and the presentation. I have lots of questions I know we don't have time for, so perhaps in the break we get an opportunity. But what I was very interested in is your approach of working with alternative holistic therapists, people who perhaps herbalists, Ayurvedic medicine, etc., because a lot of our communities will turn to those treatments, and not that there's any judgment around that, but how can we get these people on board? I wanted to know how you were able to be so successful to engage with those that they didn't feel you were a threat to their trade, shall I say, and what we could perhaps do to implement something similar here, because we still face similar challenges. Thank you.
Yeah. So these Ayurvedic physicians, out of those 3,000 peripheral health workers we educated, around 1,000 were from this alternative medicine background. So we approached their association. They do have some associations called Indian Association of Ayurvedic Medicine, Indian Association of Rural Healthcare Workers. We approached them, and if we can give them due respect, then they are going to accept it. It's not that they are not doing anything. They are the primary face or the primary point of contact in many villages. Thank you.
Thank you, and thank you for the questions, and thank you for answering the questions. Right, so we're now got on to one of the highlights of the day. So if I could ask Dr. Didier Verhaven, David and Buki to come to the stage, please. Didier is a medical oncologist from Belgium. David Collingridge is the editor-in-chief of the Lancet Oncology.
And Buki's our event chair. Right, okay. Cameras ready. First up, we've got Uzair Khan. Uzair, I'm sure you've had breakfast to walk faster. Cool. Archana Sood. Lin Cheng. Namanjulka Anderson. Elise Bautista Gonzalez. Odunula Atitebi.
It's our pleasure to announce the winner who has just given the oral presentation, Dr. Suman Das, who has come all the way from India today.
Suman, don't leave. Don't leave. Can we have all the abstract winners? Can we have the entire steering committee for London Global Cancer Week 2025 Cancer Health Disparities Programme on stage, please? And can we get the cameras buzzing? Lots of the cameras, all the cameras. Mobile phones out, please. Susie, come on, faster. No time for gossip now.
Should I be in this? Okay.
Shorter people can go in the first corner. I'm bridging disparities over here. Our job's done and we can now rest in peace. Come on, Neil.
So we're going to have a 5-minute break because we've had a lot. So 5-minute break. The tea is now at the back, so not outside the hall. So there's no need to leave the hall unless you need to go to the bathroom. So 5-minute break. Hello, hello. Please, let's take our seats. We're already running behind. Is there like a... I wish there was like a thing I could have. Ladies and gentlemen, can we take our seats? Thank you. We're already running behind schedule. Ladies and gentlemen, let's take our seats. There's going to be some time for networking afterwards, so please let's take our seats. So there's a slight change in the agenda. We were supposed to have Dr. Dario Trapani's talk next. However, we're going to move to the panel session that's going to be moderated by my friend, Ms. Georgia Doni.
Hello. Good afternoon, everybody. I hope everyone's enjoying the conference today. So we're going to do the panel session now, and we've got 5 panelists. So I think Prof. Habib is online, or is he in the audience? He's online, I think. So Prof. Habib Naqvi, are you online? Possibly, he might join us. We've also got Nasser Turabi from Cancer Research. No, we don't. Sorry, I'm going to read it off here. It's easier than reading off the thing that Bookie's given me. John Shelton, Ketty, Rosie and Keith, would you come up? Take your seats, please. I'm going to ask you each to introduce yourselves. We've got a very shy panel. Where are the panel? Let's encourage them up onto the stage. This is Ketty. Come on. John, hello. Hello, Rosie. Hello. We are missing Keith. Is Keith Morgan here? Keith Morgan? Not here. Okay, well, we'll start. Okay, so I'm gonna ask the panelists just to introduce themselves, and then hopefully we'll get Prof online and Keith will join us shortly.
Absolutely. Hello, everyone. My name is Katie. I'm representing Novartis UK today. I'm communications and patient advocacy lead for cancer with a specific focus on breast cancer at the moment. Lovely to meet you all.
Hello again, everyone. John Shelton, Cancer Research UK. Generally epidemiologist. We look across risk factors, cancer epidemiology, prevention, early diagnosis, treatment, coming from how do we generate evidence from data that's available.
Good afternoon, everyone. My name's Rosie Mogul. I am the oncology policy lead for AstraZeneca in the UK, and I also oversee our health equity strategy in the UK as well.
Thank you all for joining us today. Are we going to be able to get Prof. Habib online? He may not be feeling very well. And Keith Morgan, his bookie gone out. Okay. All right, well, what I'll do, a very compact bijou panel today. So I'm just going to start then. So I'll start with you, Ketty. Well, actually, a general question to everybody, actually. So, I mean, the whole purpose of this conference is we're talking about awareness. We know that it's rising, okay? But what we find is that action can often lag behind. What do you think would be the single barrier, the biggest barrier, do you think, to translating the knowledge that we all share with each other into a meaningful change? So, big question to start with.
I can start. For me, I think we started doing some work in health inequalities, which is connected with engaging with grassroots communities and working on improving outcomes for breast cancer. I think one of the learnings for me personally was how do we make sure we give power to the community and support them to drive the difference instead of engaging as pharma. I think we might have a tendency, both pharma and NHS, coming in and kind of trying to tell the community how to deliver things. So I think what we're trying to really focus on is how we give this power instead of extracting from the community and make sure there is accountability, but also enough support for the right people to deliver it, because there's definitely a lot of power in the community leaders. So I think this is one of the challenges that comes to mind instantly, but I'm sure there's more.
I'll try and bring in a different one then. I think probably a couple wrapped up in one. I'll put it under the element of resource. I think even when we've got interventions that we know work, the implementation of them can often be held up by lack of resource, predominantly in the health service. Is it big enough to cope with what those interventions generate, the people that we need to get through the system? So resource also kind of ties in with funding as well. Have we got enough funding to actually roll these out in the areas that we need them to be rolled out where they're going to have the most impact? So I kind of tie those two together.
I think for me, and this sort of journey we're going on at AstraZeneca is how do we embed equity into our organisation rather than it being an add-on. I think there's a bit of an inherent tension there because I think you need to make sure you do have equity-focused projects, but at the same time we need to be embedding an equity lens into the way we operate as a business right from the top all the way through to some of the local engagement we have. So, for example, we have recently launched a new patient-centred development framework for our R&D side of the business. So everything from the way that we start to plan research programs themselves all the way through to when we bring a new treatment to a patient from now on should be having a patient-centered approach from day one on how those programs are designed, how are the trials designed, and therefore how do we make sure that when we bring them into the UK they are not exacerbating health inequalities but they are helping to close them. So it's a longer term journey, I think, and you need to sort of do the short term equity-driven work to start with as well, but I think we need to make sure that at every stage of our business operations, health equity isn't just a priority, it's a business need.
So a couple of you mentioned things about resource. I'll start with you, John, because you brought up the point about resource and how sometimes it can be an expensive thing to try to get into underserved communities. Can you elaborate on that? Why would it be any more expensive necessarily than
The
anywhere
way
else?
that I was coming up from the resources is the funding there to implement the things that we know work.
So have you got some examples?
We saw on a national level.
Yeah.
I mean, let's take I guess the rollout of lung screening. We know that targeted lung health checks work. We know that targeting at those who are in more deprived areas, high rates of smoking is the right thing to do. But we won't have it fully rolled out probably for another 5 years. I don't think we've got that commitment across all of the countries in the UK yet. If we had that resource in the health service that could cope with it, we could do a lot more. It's the same with things like bowel screening. We've got different levels of fit thresholds across the UK. So we've got interventions that we know that work, and we've got inequity in the way that they're being brought in because we don't have enough resource in the health service to kind of cope with it. So there's kind of different levels to the resource question, but the funding behind all these things needs to be there in order to allow them to be implemented in the first place. So it's that combination for me.
Yeah. And so just following on from that point, obviously, because we've got two people on the panel from industry, does it make it more expensive to be inclusive?
I think it's definitely a proactive effort that needs to be there. And actually, I wanted to follow up on what Rosie said. I completely agree. I think often in industry, we perceive health inequalities or engagement with the community as a separate topic. It's not. It's a red thread that should be happening across all of the function, across all of the projects that we're doing, and this is how we're trying to address it at the moment as well through Health Inequalities Pledge that we have in the company. So I would say it is definitely an effort that every single person in the organization need to make, which doesn't make it not worth it. So yeah, to answer your question, yes, it is something that needs to happen, but it needs to happen.
Rosie.
And I think in terms of is it more resource intensive, it depends if you prioritize it, right? So I think at the moment we probably are quite broad brush with the way we engage. We often prioritize areas where we've got strong relationships and where we know we can embed local partnerships because there's system capacity for us to work with them. But actually I think if we just change the way we work a little bit, yes, it may be a bit more resource intensive up front for us to go into new forums like this sort of space. We're about to join the Royal Society of Medicine's Health Equity Scheme as well. That will hopefully open up new partnerships with parts of the system that we wouldn't normally engage in, communities who don't typically proactively engage with us either. So I think maybe up front there's a resource shift, but it's, you know, you do it with purpose and over the long term, which I think is the critical piece here. I think making the case for short-term funding, particularly within pharma, is doable, but actually I think we can often be too guilty of going into projects, funding them for a year and then saying, oh, we did it, well done, and leaving. We need to be more purposeful with the partnerships we do put in place, perhaps not spreading ourselves too thin, but finding ways where we can undertake partnerships that are really designed with intent to close the gap in certain communities, and by that you bring up, was it the expression around all rising tides raise all ships. Having that new mindset, I think, shouldn't over the long term be more resource intensive, I don't think.
Thank you. I'm going to welcome Keith to the stage. I know we had a bit of a time change, didn't we? Bookie's fault. Do you want to introduce yourself for the audience?
Yeah, hi everyone. My name is Keith. I'm the Associate Director of Black Health Equity at Prostate Cancer UK, and apologies for being late.
You were early, actually.
Yeah. For those that are connected to or know about prostate cancer, today is a very important day for us because the National Screening Committee are making a decision or making a recommendation on the evidence for a national screening or a targeted screening program for prostate cancer. So that is what I was preparing for. So apologies again.
That's okay, we'll accept that. We'll accept that. But on that, I'm going to ask you, because we've just been hearing about how it's really good that we have these initiatives, it's really good that we resource these initiatives, but if we're trying to get into communities that don't really trust what we're doing, don't really want to get involved in what we're doing, how do we sort of bridge that gap?
Yeah, so trust is, as we all know, is a determinant of health, and for us, the work that we do is all about trying to raise awareness of the increased risk of prostate cancer for black men. We can't do that without rebuilding trust, and I use the word rebuilding because unfortunately trust has been dismantled within the black community for public services, so not just the health system, for all public services. And so it's our duty and responsibility to try and rebuild that trust. But what I always use is an analogy to explain how long it would take and how much resources is required to rebuild trust. It's like a broken vase. So yes, you can use glue to fix the vase, but it will never get back to its original state. You will still see cracks there, and it's more fragile than it was when it was in original state. So anything that you do that again compromises that trust is likely to break it down completely, and then you have to start all over again. It's also another analogy I like to use is a Dutch saying, which is that trust comes on foot and leaves on horseback, which again means it takes a long time to build trust, but it can go so quickly if it's not nurtured and looked after. So it's a major part of the work that we do. We raise awareness, we try and rebuild trust, and we also demonstrate our legitimacy within the Black health equity space. And we do that through community engagement work across the country. We do that through building really strong and appropriate relationships with organizations that are embedded within the Black community, organizations that have already established that trust over years. And we also do that through learning and understanding through the challenges that we know that Black men face, particularly in prostate cancer, in all parts of the navigation of their journey through prostate cancer. So that's the diagnostic pathway, the treatment pathway, and the support pathway. We know that there are fundamental challenges for Black men when it comes to navigating each of those three parts of the pathway for prostate cancer. And so our work is primarily focused on raising awareness, both within the Black community, but also in the healthcare system.
That's really good, thank you. I'm not sure if anyone can answer this actually, but I'm going to ask it anyway. What policy levers would you prioritise to try and accelerate equity improvements in cancer care? I think this was a really good one for Professor Naqvi, but I don't think we're going to get him. He's not going to come on. Okay, so I'm going to ask you guys, and then maybe there might be somebody in the audience who might be able to comment at this point on that.
I might jump in just to start off,
Yeah.
because I think keeping an eye on the policy environment is front and foremost what I do. And I think at a macro level, I'm quite encouraged by the move to things like multi-year planning, multi-year budgets, because going back to the point around resources, sustainability, if you're just working on annual cycles, then you can have the rug pulled under your feet any day really when it comes to implementing new models, new services, etc. You can do more longer term planning and have the assurance that in 3 years' time you will still be getting that funding route and it will still be a national priority. That being said, I think all the changes that are happening at NHS England being rolled into DH, and particularly I think the risk of losing progress that has been made by the Core 20+5 framework, which has helped to shift or broaden out, I think, the health equity conversation from one around really important around prevention and lifestyle changes and the wider determinants of social health, which is really critical, but actually enabling the healthcare system itself with some really specific focus areas that they can work on to actually support patients in the pathway once they're hitting the service, so after the prevention opportunities are missed. And I think health inequalities often feels, the way I talk about internally is we can't boil the ocean. It can feel very overwhelming where to start. And I think the framework that was pulled together by Bolo Owolabi really helped support people to start somewhere, and it's better than nothing. So I think that's an opportunity, and I'd also flag a bit of a risk in the policy environment at the moment.
Anyone else? John,
I'd
poised to say
I'll
something.
support that, because I think Professor Lawabi's done some brilliant stuff, but I think your comment about rearranging structures just doesn't help at all from a policy influencing point of view. If you just think about things like Public Health England then becoming defunct, I've got NHS England changes that are in the kind of structure doesn't help. But hopefully we'll be seeing a national cancer plan being published soon. We were hoping it was by the end of this year, but we think it's going to be in the first few months of next year, and hopefully that will be an opportunity that they will have listened to the representation that all of us can give, and that there will be things in the National Cancer Plan that give us hope that there will be focus on inequalities, and that we'll be able to use that as a basis for kind of changing policy, and using that to really push on and try to get the right support in the right areas that we need it.
We're going to open up some questions from the floor, but while we're just waiting for some questions, I'm going to ask, how easy is it to be innovative? Because obviously we're moving into this whole, we are in this whole artificial intelligence kind of era. How easy is it to use all these new technologies to be able to bridge that gap? And then if there's anyone that wants to ask any questions. I mean, Keith, for instance, have you used any of those things in terms of like getting the trust back with the community? Have any of those things been of any use?
I think there's real hope with the introduction of AI to tackle inequalities or inequities. I was at, got colleagues here in the audience, I was at a Clinicals Champion, so it's a fantastic event where we get clinicians in the same room and they're on a program and they talk about the ways in which they can advance, make advancements in their professions. And we sat at the dinner table and we were talking about the introduction of AIs in helping men that have prostate cancer with their decision-making process. We know that there are challenges around shared decision-making when it comes to treatment for prostate cancer. And specifically in my area, we know that there are huge disparities for black men in the treatment pathway. So we know, for example, that black men that have high-risk, locally advanced prostate cancer in their 60s are 14% less likely to receive radical treatment. So that could be the treatment that could save their lives. And so the introduction of more tools which helps with shared decision-making can only be a positive thing. And it was really hopeful to sit with clinicians and talk to them about the work that they're doing to try and address those disparities, to try and address the inequities that we know is inherent in the system.
Anyone got any questions? Yeah, we've got another one here as well.
Hi everyone, thank you to the panel. My name is Esne. I'm a consultant pharmacist at University Hospitals of Leicester. So I'm coming at this from a pharmacy perspective, and probably a question for the industry colleagues on the panel. So I'm going to have to try and say this right, because whenever I see LMIC, I first think low molecular weight, you know, because I'm a pharmacist. So low to middle income countries. And with regards to looking at having data about ethnic minorities in research, and I'm thinking about looking at bringing medicines to the public, bringing medicines through the regulatory process, and that research trials aspect, so I reviewed I reviewed data, clinical trials data, looking at NICE guidelines and how that feeds in, and we're trying to look at representation in NICE guidelines and taking in ethnic minorities. But I don't see these trials being conducted in low to middle income countries. So that presents a gap in the data, and also something that I'm quite passionate about in terms of access to medicines. So we have a lot of early access schemes and things like that, and obviously research presents great access to medicines for patients. And I find that that's missing in these countries where we've had an influx of people who are now here, but that data is still missing, and we're going to need to treat them here in the UK, but also treat them in their own countries as well. Can you cite some examples, or what are the challenges? And I understand you may not have all the answers, and I'm happy to come and chat to you later. But any insights into what's happening in that space for access to medicines and getting the data about people from ethnic minorities?
So that's a huge question.
Sorry.
So just to summarise, why there are not more trials in low middle income countries? And also, how do you, I mean, that's a huge topic. And also, how are we broadening access to those drugs? But then I guess, which comes first, the chicken or the egg, actually? Because if the trial, you know, so anyway, but I think, yeah, in one line, can you answer that question?
Well, I can try. I will not do it justice, and it's certainly a little bit beyond my area of expertise. But I guess a couple of reflections I have on that. The first one is around, I think, the opportunity of countries that are diverse, like the UK, where if we can start to properly, and this is coming from my colleagues in R&D, our priority is start measuring what does representation currently look like in the areas where we do have trials, so that we can identify actually we do need to improve recruitment of certain demographics. I think there's a really huge point, and this goes back to what Keith was saying around trust as well. I don't think we can just assume that we pull a lever and people will want to participate in our trials. There's a lot of work to be done around building trust, not just, you know, with a single company's name or a single brand drug or whatever. It's about building trust with industry as a whole and healthcare systems. So we have to work with not just communities, but with the healthcare system as well. When it comes to, I'm a little bit out of my depth when it comes to why we're not more trials in low and middle income countries, but I think there's a piece around standards of care and infrastructure. It simply isn't there in the same way that it is in other parts of the world. That's not to say that that should stop us. So there are, I think, different areas that we're focusing on. So, for example, we do have a program globally run called Healthy Heart Africa, which is about trying to bring in better diagnostics infrastructure and diagnose people with cardiovascular disease earlier across a number of different countries in the continent. And I think if we can start to move forward on initiatives like that, then we can improve the infrastructure that will enable us to start looking at the future of trials and engagement in those sorts of parts of the world.
Yeah, from my side, again, fortunately not my expertise, but thank you for recognizing that, and I just want to flag that there is definitely a recognition within the company that engagement needs to happen at a bigger pace and better. The point about healthcare system readiness for bringing innovation is important. Just to follow up from what already been said, there are some programs being led to engage patients as much as possible, as diverse as possible into the trials that are already ongoing, through, trying to increase trust, also adapting our materials to the patient communities so they are understandable, clear, and generate more trust towards pharmaceutical industry. There's also support for patients participating in trial to make sure it's as easy as possible for them to travel, to stay in the clinical trial site, near the clinical trial site. So there is definitely an effort, and also on the global level, with a global health division that Novartis has, but also working with other pharmaceutical companies. For example, one of the projects called READY, which is an effort from multi-pharma community to drive inclusivity within the trials. So there are some efforts being done, but it is a very valid question. Thank you very much.
Yeah,
Can I just say that we have a rapid fire panel later about diversity in clinical trials, so we might leave that question
here as well,
and also tackling mistrust. So we might leave those questions. We're running behind, so we're only going to take one more question.
Yeah, this chap has been patiently waiting.
Please, yes, Mark.
Thank you. I want to talk about awareness. It would, first of all, I have to pay tribute to Cancer Research UK, who has its website is used all around the world to get information about cancer. It's often where people go first when they get the news. They go to that thing. So, I mean, all credit to you. But it seems to me that we should have started earlier. Perhaps there's a role in education, in actually the schools, to start talking about cancer. I'm not talking about it as an emergency, but actually just explaining that we're all cell-based life forms, and in the course of life, these things happen. It seems to me that too many people only start realizing what cancer is when they have the diagnosis. Way too late, way too late. So the question is, what role do you think could school-based education play in actually bringing awareness at an earlier time and on a more equitable basis? Everyone's the same in the school. That's the one place where you've got them all in the same room. Is there, or do you think this is not a thing?
I'm going to pitch that to you, John, first, seeing as they've picked up Cancer Research UK. You go first.
Thank you. And a very interesting question. I think there's a role in school, not just about cancer, but in health that in general. How do we talk about conditions that become more prevalent in older age? How do we get the engagement from young people? And that comes to the making sure that we get engagement from people right across the population, from clinical trials through to everything that we're trying to do for interventions and information. I think what it comes down to for me is you've got large things from a health perspective that affect people in their life. Lifetime risk of cancer is 1 in 2 people roughly will develop cancer at some point in their lifetime. It's huge. And therefore, this shouldn't be something that we just save until people have a relative or a family member who developed cancer. We need to talk about it from a young age. So I absolutely support. It would be great to see more done in schools, and it'd be great to see government policy in schools linked with charities. There's many different cancer charities who I'm sure will be very willing to play a role in how to communicate different elements of cancer to different people in the population, especially young people. And I say that with another charity panelist sitting alongside me. There's no lack of will, certainly from a charity perspective, to get engaged with initiatives, and the more that we can do, the better.
Okay, I'm going to give Keith the last word.
Yeah, I totally agree. I think it would be a great idea. So when we talk about prostate cancer, most people don't, when we speak to them, don't even know what the prostate is or where it is. Which is shocking, really, because it's such a central part of the male reproductive system. We should know what it is. So you're right. Until you have some cancers, so in this case prostate cancer, you often don't know anything about it. And I think starting from a young age is really important. Obviously, we have to be considerate in terms of raising anxiety. We don't want to raise any unnecessary anxiety. But I think the more you know about your body, the more you know about your responsibility in, one of our key spokespeople talks about this all the time, about being the CEO of your own health. And that's the message that we say to men as well. Don't wait for policies to change in order to, inquire about your own personal health. If you're concerned, if you know that you're at a higher risk, speak to your GP and see what the options are for you. In this case, if you're in a high-risk group for prostate cancer, speak to your GP about a PSA blood test. Do our online risk checker, which is a free tool to use, which only takes 30 seconds to determine, if you're at a higher risk. So yeah, be the CEO of your own health. But yeah, I agree with you. There's more that we could do in terms of raising awareness for young people.
Absolutely correct. And it's the same with breast, and it's the same with a lot of the systems. They all overlap. And actually, yes, if you start training people young, they're going to know when something's not right to be able to present early. Bookie is going to yank us off the stage. So I'd like to say thank you to all our panelists.
Can we have another round of applause for our brilliant panel? I'm going to invite Professor Alfred Ginsberg to introduce our next speaker. But can Dr. Stevie Lockwood-Byrne find me? I have your card. I found your card.
Thank you so much. It's always such a pleasure to be here at London Global Cancer Week, and thanks to Bookie for everything you do to make this day happen. What a great segue after this panel that I'm really delighted to introduce a brilliant colleague and dear friend, Professor Dario Trapani, who flew in this morning from Milan just for this session. I just want to make a comment as Dario comes up to say that wouldn't it be amazing to see a multi-pharma effort to consider how they might play a role in advancing pragmatic trials, right? The trials that we know are coming, especially in India, de-escalation trials and other dose optimization trials that could really bring innovations where they're needed most. Without further ado, Dario is a medical oncologist and researcher with a profound interest in oncology policy, cancer policy, and integrative approaches to cancer care. He specializes in breast cancer, combining rigorous scientific methods with a patient-centered perspective. Dario's led very important research also in access to medicines and optimization of therapeutic strategies, as I just mentioned, and he's involved in a lot of educational initiatives that you should check out, including as part of your humble head of, I think, the Cancer Medicines Unit at ESMO, and also deeply involved in Common Sense Oncology, which is a movement. His multidisciplinary vision bridges clinical practice, research, and health policy in his efforts to improve access to innovative therapies, and I could go on, but I'll let Dario have the floor. Thank you so much, Dario.
Wow, what an introduction. Thanks, Emily. I'm so emotional now that I told you. I know Fira since many years. She's like a mentor and hero to me, but I'm very proud and really happy to be here for my first time to the London Global Cancer Week. This is an event that I have been following for many years online, but I'm so happy that I could be invited. Thanks, Willie, for presenting to you some of the work ongoing and share some perspectives and ideas on the global cancer control, and in particular for the access to cancer treatment. So today we will really, I will really try to share with you some of the perspective and initiative to understand how we can enable access to innovative treatments, in particular as driven by the value as a principle to orient the access to the global, to the global, in particular in LMIC. These are my disclosures. And as Dr. Ginsberg was mentioning, I'm at this point leading the access to treatment initiatives at the European Society for Medical Oncology as a main initiative oriented to the access. And I want, because the title was about the emerging treatment, I really want to start to understand which are these emerging treatments, how as a medical oncologist we implement these in the clinical practice, what does this mean, and what are the impact on the access in LMIC. And you see that, in oncology, we really live a current and contemporary paradox for which we have new emerging classes that are amazing under the technology perspective. The development, the science behind is really amazing. But of course, not all of them really deliver the promise, at the patient's level to improve patient-centric outcomes. You see that we have emerging and novel treatments, in particular across a spectrum of classes that are or intended to be very targeted or to enable durable cancer control, including with immunotherapy compounds, or to be very precise and again very complicated and sophisticated, like cellular-based treatments. These are usually very sophisticated and highly inaccessible because of the complexity required to implement them. But in particular, I report this landscape study, from a couple of years ago, in which investigators try to understand all these emerging treatments that come on the market, in what extent they really improve patient-centric outcomes. That's why we have interest as investigators, as a community, as oncologists, and the broader cancer care community. And policy, it's what we have interest in to understand what is the tangible and population-oriented impact, what is the person-centric outcomes improvement. And you see that less than 20% they really deliver among all the FDA and EMA approved drugs. About 1 out of 5 really is deemed at high value, utilizing consistent and composite scores that I will show you in a while. And in particular, when we take care to quality of life improvement and overall survival that are for us the ultimate patient-centric and gold standard endpoint, you see that such an improvement is really small. It's much more less than we would like to implement in the clinical practice these interventions to reach people who are in need, because it's less than 10-11% really improving the quality of life that we consider to be a gold standard. Much of the new treatments just keep the quality of life the same. Some of them may even result in a sort of detrimental impact because of toxicity. And you see that the overall median overall survival is less than 3 months for all these treatments grouped together, but as distributed in a spectrum. And some of them may be very valuable cancer medicines, but this does mean that some of them don't really improve the outcomes as we desire. And so there is a spectrum that we have to navigate to understand which is the value that we are pretending to the people that we are treating with innovative treatments. We know, and we are working in this direction also with ESMO, but also as a community, including with the Common Sense Oncology and broadly, we're trying to understand how we can incorporate value considerations in the uptake of new treatments. And there's the value intended as a patient-centric value and also health system value is essential organizing principle for the decision-making ecosystem. You see that since the political commitment and the regulatory bodies, they have to incorporate value metrics in order to make sure that everything that reaches patients has been screened according to the intrinsic value and the feasibility to be contextually appropriate in the context of intended use. And we usually converge such a value consideration on the health technology assessment bodies, or in general, everyone is doing decision-making. That does mean everyone is deciding if a drug should in the public system reach a patient, and if this should be reimbursed, and in what extent, what population, what kind of acceptable threshold for investment on that specific interventions. So we know, and we want to, and I will show you some examples, we want to believe that value is our central organizing principles across this ecosystem, because we believe that people are at the center of our work, and the sustainability of the system is one of the outcomes in the work that we do as part of the decision-making process. And in fact, the value itself is really a complex definition. If I'm asking to diverse community, we have industry here together, but we also have policymakers, we have academia. If you ask all people what is the value of a new drug, of an emerging treatment, you will definitely have very different definitions. But we know the HTA and the general the community has agreed upon at least 2 different declinations, 2 different interpretations of the value. One is the intrinsic value, how I am improving the outcome at the patient's level. And the second second one is the extrinsic value, how I am implementing that specific interventions in a system that is able to uptake because of the existing capacity or working toward capacity building, and also how sustainable is such an uptake. And these two elements are usually taken into consideration to understand if the intervention is of a high value and if I can deliver sustainable benefit in my specific context. But of course, my question is, to what extent are we implementing, and how is important to implement patient-centric values, including improvement of quality of life and overall survival, when I am making consideration in the system and how this will drive such decisions. And I'm reporting here some data we produced. In particular, one way to report the intrinsic value of the drugs, how they improve patients' well-being, is with the use of standardized framework. And one of these that is now broadly utilized in some HTA agencies in Europe and in Asia, and a couple of, in particular one Latin American country, is the ESMO, European Society for Medical Oncology, MCBS, Magnitude of Clinical Benefit Scale. Such a scale is based on the assumption and idea that when we deliver emerging treatment benefit, it does mean we're improving primarily the quality of life and the overall survival in a tangible way. It does mean that I'm giving it a max score, the max value for these kind of drugs that really tangibly impact on patients' life, on people's life. The scale of which I'm just providing one example, how we display, it really captures elements on how you improve, how the new drugs improves the quality of life, how this impacts on the overall survival, and also what's the burden of the side effects. Because again, these new emerging treatments may come with an increasing or a worsened safety profile sometimes. And so as such, we have to make sure we upgrade and downgrade as appropriate to make sure we capture these patient-centric dimensions when we state if a cancer treatment is of high value or is not. The scale itself is displayed as scores. In the curative setting, we have 3 scores, and in general, this is in the commitment of the society to emphasize what is in the curative setting changing people's lives, because you prolong life and you reduce the cancer risk for recurrence and live longer cancer-free. So there are only 3 steps, and usually A and B, it's a little bit more generous, are considered to be of a high value. But in the metastatic setting is where we have most of the approval of the cancer medicines, and where this kind of discourse becomes very challenging, because we have many competing kind of ideas or perspective, and we have disease with a very different type of intrinsic prognosis and clinical behavior. And as such, we have a more granular distribution of the scores from 1 that's considered to be a low clinical value to 5 that's considered to be the highest clinical value for these drugs that are capable, or in general, interventions to improve tangibly the quality of life and the overall survival of patients. In the, with this in mind, to understand how we can standardize and provide results on the clinical trial results and capture within one standardized score, we try also to understand and investigate if the value is ultimately captured by the HTA agency. And we started with an easy exercise in high-income countries, because of course in the G7 economies, these economies are capable to implement the overall HTA exercise, because this requires multidisciplinary expertise and funding. Of course, you have to budget for this kind of very expensive and intensive exercise. So we selected the top 15 selling drugs in the US to make sure that we have some of the drugs that we commonly use in the clinical practice, and try to understand which were the key drivers for HTA agencies' decisions, driving the decisions and the outputs across different jurisdictions. And as you see, the clinical value was definitely prioritized, and this is for us very satisfying, because all the countries are putting patient's value and clinical value at the top in making the decision for the new drugs. It doesn't mean the therapeutic benefit, it's still our priority in the public decision-making. And also the economic contextualization to understand if the extrinsic value, how is this sustainable, and how, in what extent I can implement in my setting, is definitely something that's put at the center in the parameter for decision-making, while at defined, cost-effectiveness threshold, all specific mathematical rules were only found in 2 of these agencies, and was just a minority of these agencies being very severe, very strict in the way they implement economic metrics. In general, there was more like a dialogue around them and putting in the context across diverse disease settings. We also try to understand how countries uptake low-value interventions, the MCBS-1 metastatic setting, where you don't anticipate major improvement of the outcomes, even more toxicity. And we understood that this is very diverse across the HTA agencies, because in the resource-expanded context, sometimes government may want to invest also on this kind of low-value interventions, especially when they address rare tumors or settings in which you don't have an alternative. Because for HTA, the unmet need is a high, is an important parameter to inform the ultimate decision-making. And in one exercise we're doing, and I will show you later something with ESMO, we also understood that this is really like a high-income countries attitude. It's not really in the LMIC. If any intervention if some interventions is not pretending any benefit, even in the rare tumor setting, it's still not providing any improvement for that patients, so it's not a good alternative. In LMIC, this will not be prioritized, while in high-income countries, this is something which some governments are putting money on. We also try to understand in another exercise actually driven by the London School of Economics here in London, it was to understand how the MCBS as a score is associated with outputs of the HTA agencies across 6 different countries and jurisdictions, mostly North America, Canada jurisdictions, the UK and European Western countries. So again, high-income countries. And we saw that usually in the metastatic setting, MCBS 4 and 5, that are high-value drugs, are prioritized and are those for which governments are deliberating for positive HTA outcomes, while the low value is usually associated with a deprioritization. That doesn't mean that this kind of value matrix is capturing the way the HTA is making decision, at least the direction in which this decisions happens. And in a more, statistically complex exercise, the investigators show that in general, the value as captured and reported by the MCBS and also the contextual economic evaluations, the availability of a dedicated funding was definitely driving the decision overall. But, and in general, they also provided these in in a more granular exercise to understand how the HTA agencies in high-income countries, again, are making decisions to list drugs, to put conditions for the access, usually restricting the eligible population or providing some kind of a conditional reimbursement, risk-based agreements that's really an HTA, based high-income countries attitude, or just not to list. And again, you see that the intrinsic value and economic contextualization is important, but also what they consider the high unmet need. It doesn't mean I don't have any alternative. I should cover this population with some kind of interventions because the alternative is just not interventions at all. That's kind of attitude for high-income countries that we have found also in the decision-making consensus conferences. But what happens in LMIC? Because it is true that this kind of way that we interpret the benefit, the intrinsic benefit is definitely driving most, of the decisions in high-income countries, and the HTA are reimbursing and covering these drugs with high intrinsic value. But what's happening in LMIC setting? What's the mapping? And at this point, we don't have a global HTA mapping for LMIC, because the decisions are really made in a very complex way. Some of the countries may not really rely on the HTA. That's inappropriate for some of these institutions, especially when health system fragmentation exists and the HTA exercise is really into more resourced and perhaps centralized private cancer centers. So we know that in LMIC setting, probably HTA is not common, and also that other type of HTA-like exercise may work. And one of these has been reported by the National Cancer Grid in India. And I'm pretty sure you know the NCD, the National Cancer Grid, the NCG, because this exists, has been here for over than a decade now. It's a huge and an amazing, national network of cancer institutions with, as led by the Tata Memorial Cancer Center in Mumbai, and led by the Tata Memorial Chief Medical Officer, that has the sense to enhance the access to cancer treatments and in general therapeutics overall India, covering over 300 cancer centers that recapitulates most of 70% of the cancer burden in the country. It does mean that within this network, you cover much of the cancer burden. At least it's a strategy to make sure that you can reach people in several settings and regions. This really makes India as a one country because it's of course a very diverse country with regions, and helps to have a sort of centrally lead, Tata Mumbai lead system to make clinical cancer treatment protocol decisions and also reimbursement decisions. And in particular, in the agenda of the NCG, I just highlighted two specific outcomes for which they have worked intensively. That's the evaluation and development of standardization of care through resource-adapted clinical guidelines, and the shared procurement and cost reduction. That's a sort of pool procurement and HTA exercise. So as it pertains the clinical guidelines, it's at the very backbone, of all the decisions that we make in the clinical practice. The NCG developed 3 tiers of cancer interventions to map and score what was really critically and required, necessarily to treat cancer patients with multi-indications chemotherapy and hormone treatments. These usually are essential medicines as per the World Health Organization, and they should be available everywhere in every institutions that provide cancer care. Then they also provided some optimal kind of interventions that may be available in centralized cancer center because they do require a specific capacity that may be diagnostics or health system broadly, like the workforce skill and training. And the third one is optional, that is the clinical guidelines as developed by high-income countries. ESMO is developing guidelines, the NCCN is developing guidelines, and this one may really include all the interventions, all the evidence that we derive from the clinical trials, but they may have sometimes no relevance in many of these countries because they're just not affordable or relevant for the disease burden and priorities of the countries. With these guidelines in mind, they developed a process called adaptive HTA that is an accelerated HTA based on a mapping of the literature and a multi-stakeholder Tata Mumbai Memorial centralized but nationwide developed approach that should fast-track the decision and reduce a little bit, mitigate at least the time constraints, for addressing an urgent public health threat, and in general, to make this more sustainable and short. In general, they incorporate in the adaptive HTA mechanism the ESMO MCBS as one of the value parameters to synthesize if new cancer treatments are pretending high clinical benefit or low clinical benefit, adapted locally to give a context and also interpreted as the evidence behind. And I want to report some of the results in the value definition for the NCG, that is value for money. Is not only the intrinsic clinical value of the drugs, but is really put in the context of sustainability in this concept, on how you invest and how you get back in terms of investments. It's really health economics concept to capture affordability and equity elements in order that most of the population in need requiring that specific interventions will access that. And in this pilot exercise, with only a group of 14 medicines, mostly chemotherapy, endocrine treatments, and some targeted agents, they were able to save in 1 year in the country through an HTA value-driven procurement mechanism as driven by the AHTA in the pilot phase over $1.6 million that with a percentage of discount between the retailer cost and the procurement cost of up to 99% for some older and cheap genetic chemotherapy. That is really a success because these kind of price reductions are not really possible if you fragment the system, if you don't work as one, and if you don't incorporate value metrics that really show if something is really high value or if it's not. Because if you consider cancer care just the same, all the treatment just the same, we're not really able to capture these granular differences and also to make and enhance our capacity for negotiation. So in general, we also at ESMO, asked wondered what is the current status of access to high clinically valuable medicines worldwide. And we did this with a global access to medicine snapshot survey that was published early this year to understand what is the status of access to selected medicines. We selected all the World Health Organization essential medicines, and then we added on in priority disease, the most prevalent, and some key examples like rare cancers, targeted agents, some hematology malignancies. We also wanted to investigate MCBS 4 and 5, high-value drugs according to the clinical value, to understand how they're implemented and if they're affordable in the country in which they're utilized. We were able to cover most of the countries in the world with the except of many gaps in sub-Saharan Africa, where, as you may know, some countries may not really rely on a formal oncology service, and this may be very fragmented within internal medicine services or, let's say, formal oncology services. So it was for us a little bit challenging really to reach out who was doing the cancer care there. And also because the ESMO network is mostly Asian, European, and American. So I think it's also like society, kind of coverage for which we were not really able to cover the continent. And that's work we're trying to improve at this point. But in general, you see that we were able to cover 93% of the world population. If you consider all the countries, we did a survey over 2/3 of the country in the world, reaching or informing, on the cancer care in most of the people living with cancer worldwide. And 2/3 of these countries were LMIC, representing one of the largest survey, global survey with no skewed information toward high-income countries. That's most common because these countries have more reliable system to report the current status of access. While in LMIC, you have to go and ask to, bodies and institutions or even single providers. So what we found, and I'm showing here some selected drugs that are targeted agents, usually more expensive. Some of these available as generics and biosimilars, but still not as cheap as the older chemotherapy drugs. And I selected here inhibitors, so targeted agents for metastatic lung cancer, the monoclonal antibodies, targeted agents for early and metastatic breast cancer, and also immunotherapy for melanoma, because these are all WHO essential medicines, but they're not as cheap as the older chemotherapy and endocrine treatments. And as you see, the situation is very diverse, because in high-income countries, usually these high-value medicines are included under the benefit packages of the countries that are completely covered by the governments as part of the cancer priorities for the disease control. While in upper middle income countries, in transition economies, you see that some countries, about 1/3, that were not able to cover the population, comprehensively and fully for this kind of more expensive drugs, and patients could only access these drugs as out-of-pocket expenditure that may be pretty substantial for a monoclonal antibody that can cost, at this point, with the biosimilars, about $1,000 per month. That's actually a very substantial price. And also we have in LMIC the situation which most of these countries just had no availability of these drugs, and where this was available, usually this was only at full out-of-pocket expenditure by the patients. That does mean that it essentially creates huge disparities, because this kind of access portrays a disparity where only the wealthy can access the comprehensive cancer care with high-value medicines. I also want to display you the situation of access to immunotherapy, because this is very dramatic. Immunotherapy is a very expensive but high-value interventions. For WHO, this is an essential intervention for melanoma, but by this year, with the new essential medicines, you will also find this indication for other disease types, like cervical cancer, that's a global burden and relevant for LMIC, and also selected types of lung cancer. And you see that the access situation really displays a gradient in which high-income countries definitely have access to these treatments, but in general, everything is transitioning economies and LMIC to just don't get access. And in general, that's because these interventions, that's easy to implement because you don't require any complex biomarker. It's just very expensive at the current cost and dosing approach. So why there is this, disconnect between access and the intrinsic value? Because in the ideal world, everything is high value should be, provided to the patients at the time in which this is reported as a tangible benefit. And you see that, of course, there are many, many reasons for such a disconnect. One may be definitely the sustainability, the way in which these interventions are cost, so the original pricing problem. But in fact, the problem is a little bit more articulated and complicated, because you also have some of these interventions that bring needs for implementing diagnostic or workforce capacity and skills that are not really ready in all the countries. And this is a problem for all the countries, including in our countries in Europe, in which some of these interventions require to reshape the diagnostic capacity and approach to cancer. Some of these interventions, like, in solid tumors, have changed the way we see the biology of the tumor and we diagnose cancer. So it does mean that it's like a huge reshaping sometimes for these interventions that require a system-wide, let's say, reshape that's not necessarily easy to be provided or timely, essentially, including for, innovative and amazing interventions that may improve outcome of a lot. There is also like a regulatory problem, and HTA agencies at this point, or in general decision makers, may be key drivers to improve the access on the model, for instance, of the National Cancer Grid in India, to understand how we can reproduce such a model worldwide through a standardized approach. And this is something that at TESMO we are trying to do with the London School of Economics. We know that value metrics may work. There is consensus that what is reported as high value by the MCBS is also considered high value by patients, and we had a lot of consultation with these by decision makers, by several HT agencies that are incorporating the MCBS in the decision-making process and broadly. But we know that the score alone, the intrinsic value of a drug, is not enough, because we have all the feasibility and sustainability problem of the extrinsic, let's say, contextualization-oriented problems for which all high-value medicines are not readily available in all the countries. And that's what we're trying to develop, and that's a big challenge, a reimbursement model that can be adapted across the income and regions in the world, that's informed by the intrinsic value of the medicines. It's adapted to the body of the evidence, and also is driven by health economics consideration and health system considerations. This is a very complex model that we are still developing, and we will move in the validation process probably next year, but hopefully next year, if there will be, if we will, I will be still here. I hope I can present something more on the outcomes of this model and how this performs in specific countries in the validation exercise. With, of course, the ultimate aim to increase patients' access to high-value oncology medicines. So the way, the question that was posed, for this presentation was to understand how we can, enhance access to emerging therapeutics that are reshaped a little bit in high-value therapeutics. Everything really portends patient-centric outcomes and is sustainable for the system. And I just, try to summarize a set of, keynote, sort of key messages in the final part. But in general, all this kind of dialogue is really shaped around understanding, reporting, implementing, and incorporating the value definitions within all the work we do in the decision-making, in the research that we shape. And we have several examples in which research clinical trials, for developing drugs incorporate these metrics, and they provided many clinically relevant, answers to the important clinical questions, and also how we can reshape the ecosystem for the decision-making and access based and around the value definitions. And with this, I really want to thank again for the invitation from my first, London Global Cancer Week. I'm so happy I can be here. I know many of you, I follow your work. I am really admired for everything you're doing to change the status quo. And again, thanks for inviting me.
Amazing. Wow. Thank you so much, Dario. This was really a masterclass in several converging topics that are just so important now. For those of you who might have missed the debate last night, or you can catch it online, was very much about this idea that, what safeguards are needed to ensure that new innovations, including in cancer medicines, do not worsen inequalities. I'm just going to ask Bookie, do we have time for a few questions? I certainly hope so. We have time for 2 questions. Ooh, I know we're between you and lunch. Okay, so I can't see much here, but if nobody has a question yet, I do see one, great. And as we're going to bring the mic to the person, I'm going to start just by asking one quickie. How can regulators, clinicians, and industry collaborate to solve this problem?
Yeah, that's
easy question.
That's a big question, right? But I think, again, just to make this easy, but then we can expand. I think it's really to incorporate value metrics. Like if you understand the value, then we can understand how we can capture the value and make decisions around that, shape the research, and academia should be key in this to uptake and incorporate in the clinical, in the way we put, and pose the questions for the research. It should be really driven by the value. And that is something I learned when I was at WHO. She was an officer. I was just like someone, walking around. But, when we started work on essential medicine, it was just keep in mind that not all the drugs are the same. And if we start with this statement that not all the same, not all these new drugs are the same, just because they're innovative, I think then you can advance it toward value definition and understand why it's so important to incorporate the value in the decision-making overall.
Beautiful. Yeah.
So thank you so much, Dr. Daria, for the talk. It was interesting to hear about the coverage of high-value drugs and the fragmentation in access to medicine across the globe. So my name is Jocelyn, and I'm studying at the University of Manchester. I'm a medical student, but I come from Indonesia. And so Indonesia lacks a unified cancer network that you've talked about, like the India's national cancer grid in low and middle income countries. And as evidence in your presentation, Indonesia had no access to immunotherapy for melanoma. So my question is, given our archipelagic geography and over 1,000 ethnic groups in Indonesia, what do you think would be the critical first step for an LMIC like Indonesia to build an equivalent national cancer network?
Yeah, that's of course a very difficult
Sorry.
question. Oh, sorry, please.
I trained her well. Solid question.
Definitely well trained. Thanks really for working on that. So thanks for the question. I think this is like that's the big challenge, right? But I can report, and I can provide some examples of work that we did with other countries, not really your country, but Central Asia, a couple of years ago, trying to incorporate, value within the National Cancer Control Plan, in particular for the drug, HTA-like exercise and procurement. And what happened is that the first thing you have to convince politicians and understand if the cancer agenda is high. Because if the cancer agenda is not high, there is no political commitment. And again, this is like a WHO, like days of Fibra teaching me. If you don't convince, if you don't have the political commitment, then you don't have the budgeting, you don't have the cancer control. So incorporate at a very high level policy making what is that cancer is a priority, and then give an instrument to the decision makers to make sure that they don't result in a statement that all cancer care is unsustainable. Of course, this is a step-up exercise. Nobody's going to get access everything like in one day. This may be supported by some kind of international support and funding, but the idea and the key for sustainability of a system is really to rely on a domestic approach, something that the country can really reshape and can utilize to serve all the people in that country, trusting their politicians and trusting that they will take care of this disease priority. So this may be like one, kind of high level, not easy, of course, reshaping. I don't know specifically your country, and I know there is commitment, have friends there for the cancer control, and there is a big problem, of course, for budgeting, income, and sustainability. But I think we have to give a rule to attract some of the funding and to make sure that the perception and the outcome is value-based, that you are investing on something that's really changing the lives of people, and not really a little bit, but a lot.
Thank you so much.
Thanks, Wille.
Nice.
One more question.
One more question?
Everyone is so hungry.
I know. I think
I think it's time for the lunch.
Yes.
I would encourage people to speak with Dario during the lunch because there's so
Absolutely.
much covered. Thanks,
Thanks
Bookie.
He's still around. So we are running behind. So it's time for lunch. Please be back at 2:10.
Hello, hello. It's time to come back for the next session. Good afternoon, everyone. Hello, ladies and gentlemen. It's time for the next session. Can we take our seats? People at the back. Aruni, can we take our seats? We're starting. Okay, it's my pleasure to introduce Sarah Domer. She is the lead breast cancer nurse at Royal Marsden, Chelsea. Oh, is it Sutton? It's Chelsea. Yeah.
Thank you, Dr. Buki, the boss. Good afternoon, everyone. It's a pleasure to see everyone here this afternoon and actually staying with us the whole day. And apologies that we're running a bit late, but hopefully we can kickstart this afternoon session. So we know that cancer does not discriminate, but unfortunately, access to research and representation in clinical trials often does. So today's panel will bring together experts from across the spectrum, clinicians, researchers, policymakers, and community advocates to explore some of the systemic barriers that limit participation from ethnically diverse populations. And more importantly, what are some of the strategies that can help us to overcome them? And I'm pleased to welcome onto the stage Dr. Toro Gathani, Dr. Sheba Ershad, Ms. Samantha Dixon, Ms. Teriro Kaba, and Esther Arthur Dankwa. It's going to be a rapid discussion again, so you can introduce yourselves each, and then we will kick in with some questions. And hopefully, we'll have opportunity for the audience to also ask some questions. So, Toro. Yeah.
Thank you, Sarah. I'm Toro Gathani. I'm an academic surgeon at the University of Oxford with an interest in epidemiology, and I'm a breast cancer surgeon by trade. And huge thanks to Buki for inviting me to be on the panel, and huge congratulations on organising a really great day. Thank you.
Brilliant, thank you. So I'm Sheba Ershad. I'm a breast cancer oncologist and a cancer immunologist. My sort of interest is looking at how our lived experiences affect inflammation and how that then has an effect on cancer outcomes. And I'm also a co-investigator on a project called Sambai, which might come through as we speak. And again, thank you for inviting me today.
Hello, I'm Sam Dixon. I'm the Chief Exec of Make Seconds Count. We're a UK charity whose vision is that everybody with secondary metastatic breast cancer live longer and better lives. And our interest in this area and the importance of it has led to us setting up the UK's first nurse-led clinical trials matching service. That's quite a mouthful. Thank you.
Hi everyone, my name is Teriro Kaba. I'm a pharmacist by background and I'm here representing Gilead Sciences. I work in the public affairs team and medical affairs team, so I've got an advocacy hat and also a scientific exchange hat.
Hi everyone, I'm Esther Arthur-Dankwa. I am an Equality, Diversity and Inclusion Lead and a trial manager at the UCL and Cancer Research UK Cancer Trial Centre. And we're currently working on projects to increase accessibility to clinical trials for ethnic minorities.
Thank you very much. So my first question is going to all of you. Anyone can take this question. What is the most urgent barrier preventing proportional representation in the UK in cancer trials? And anyone can answer.
And I'm happy to start with that. I think we should be broader in terms of when we talk about research as talking about trials, but also the opportunity to take part in observational studies. I think there's a misconception amongst patients that if they're not part of the clinical trial, they're not part of research. And there are actually a lot of studies that are available that are low burden in terms of participation that could be attractive and a way of building that trust that is needed for people to engage with research and the communities that do it. I think that there are financial barriers. If you are going to recruit truly diverse populations, you need to make patient-facing material, participant-facing material available in different languages. There's a cost associated with that. You need to create diverse public and patient engagement groups, and you need to be prepared to be flexible and to go into communities and talk directly to them in order to sort of break down some of those barriers.
Sam, have you got?
Yeah, I was just going to say, I think we need to decide at this point whether we have the leadership and the appetite to really redesign the clinical trials process with patients, not for them. I think at the moment we have so this is very generalised and I'm not anyone who actually gets involved with these trials, I just see what patients say, is that we have a trial system that's built around the convenience of the system rather than meeting people where they live and reflecting the lives that they lead.
So I think, Sam, I'll come back to you now. What are... yeah? No, you shouldn't be quiet. You should actually speak. What are patients telling you about why they opt out of research? And how can we respond to that?
Okay, and I do apologise, I do have to bring a notebook with me because I've got to that age where if I don't, I'll forget everything that I want to say. So we've conducted some research recently, and it's actually, I think, just being published in Breast Journal. It's a bit of a name drop there, but there you go. And part of that shows that fewer than a quarter of the patients that we speak to are metastatic breast cancer patients report that their oncologist actually raises the opportunity of a clinical trial with them. So we've already got that starting point. And then what we hear is that there are plenty of barriers. There are, and I know we've touched on them and they've been mentioned throughout the day, structural barriers such as financial constraints, travel distances, caring responsibilities, and there are designs-related challenges. So we know that some will either explicitly or otherwise exclude people who don't have English as their first language or can't, struggle with the communication there. There's certainly information and awareness and issues and trust issues, which again has been a common theme today. The lack of accessible or culturally appropriate material, interface issues, so absence of staff who have the cultural competence to be able to talk to a diverse range of patients about trials. So those are kind of quite a mixed bag there, and bearing in mind that there's a lot of reasons, there are a lot of groups that are underrepresented in trials, whether that's different ethnicities or people from different economic backgrounds, people with comorbidities, that kind of thing.
Thank you. Do you want to?
Maybe just to add to that, really, I think also, even before we talk about clinical trials, a lot of our drug development pipelines are really based on data from patients that really don't represent the diverse communities that we then go on to serve. So, if I give the example of TCGA, which is one of the biggest sort of genomic database that a lot of cancer discovery has come from, if you really look at sort of even prostate, breast, colorectal, it's really, you have to it's quite shocking to see that the small number of samples that are from diverse patient populations that actually we know that is the group where we see the more aggressive tumor biology and things, but we're not really using the right data sets to look for the right targets. So sometimes we're designing clinical trials not for the patient population that actually you're going to be seeing coming through your clinic.
That's fantastic, because actually you've almost hit on my next question, which is
Great.
to you, really, is how do biological study designs need to change to be more inclusive?
Yeah, well, number one, I would probably say at the top that we need to have not just clinical trials, but what you just said, studies which are actually inclusive, that include sort of samples from the diverse patient community. And I think there is a little bit of, you talk about barriers, people often refer to, there's historical sort of mistrust with research and things, but I think that's a bit of an excuse, because if you speak to the people and bring them on, it's not research on patient communities, it's research with, everyone is really interested when they understand, of course we want to donate tissue and things so that there are better drugs for us in the future. So, I'd say that is number one. But then further down, clinical trial designs need to understand we have eligibility for, very fit people that don't have a lot of comorbidities, but actually many of our diverse patient populations do have genetic or sort of comorbidities, which are a lot more common, which have no effect on why they couldn't be in the clinical trial, but they've just been put there because someone said so. I go on about this a bit before about neutrophil counts and things. There is a cutoff, but we know very clearly that there is the levels are different in our Black patient community. So things like that we could do. I can see Tara wants to speak. Shall I stop talking?
Yes, go on.
I think the only other thing that I'd add, and this is sort of coming at it from a sort of population level epidemiology perspective is that we need to get better about the quality of the data that we collect, about the characteristics that we're interested in. And we need to move away about, particularly with respect to ethnicity, of talking about these groups as homogenous entities. Asians are not all the same, blacks are not all the same. And we do see very distinct differences, for example, in the tumour biology of breast cancer between black Caribbean and black African populations. We see very distinct difference in risk factor profiles between Indians and Pakistanis. And until we develop nuance in the way that we collect that data, we're not going to improve the generalizability of the data sets that we create through research. And second to that is also, you don't always have to analyze what you collect. Sometimes just reporting diversity within a study population has value. Analyzing it when you're not powered to find an outcome is scientifically disingenuous and can actually inadvertently lead to widening inequalities through the production of results that are either false positive or false negatives, just simply due to the fact that they were underpowered to find the answer that you were looking for. However, reporting the diversity of your trial population is useful. And then we also need to think more about meta-analysis, so bringing together trial results, pooling results, in order to get the power that you need to be able to answer questions in smaller groups. But all of that requires collaboration. It requires direction from institutions and funders to drive that process, and it also requires a tremendous amount of education amongst the research community to be able to do it effectively.
Fantastic. So, can I come to you, Esther? What does it look like to build inclusion into a study from day one? Not as an afterthought, but as a core principle.
So I can give an example of a study that I worked on, which was the Summit study. It was the largest lung cancer screening program in the UK, which led to the national rollout. And what we were seeing in clinics was that the Muslim population didn't want to take blood tests because they thought it was considered to break their fast during Ramadan. And so what inclusion looks like is having these people involved from the very first stage. If we had someone at the start of the study, these are the culturally sensitive topics that can be brought up and mitigated. We could have got someone in from the Muslim community to explain that, add that on the research material, but that wasn't thought about. So a lot of my role is making sure that when we get researchers come in with the research question, the first thing that I'm asking to be put on the forms is, what are the underrepresented groups and how do you plan to involve them in research? And so using frameworks like the NIHR Include framework, which has these questions and gets researchers thinking. I often get people that come to me and say, oh, Esther, there's not enough black people in my focus group. And my question to them is, are they an underrepresented group? Why do you want black people? Just because they're black? So it's people thinking and not just doing these tick box exercises of trying to be inclusive without actually being inclusive.
Thank you, that's grand. And to you, Tari, from a public affairs perspective, what policy changes could ensure that there's long-term structural inclusion available to move things forward?
Yeah, I think at Gilead and other industry partners, we recognize that we do need policy changes to happen. So I think Narman mentioned earlier, at Gilead at the moment, we are working on a joint statement document where we are challenging access to prostheses and softies and wigs. Data shows that 74% of women who use softies, for example, following surgery, were not offered one of the similar skin tone. So we need that to change. So we do need policy to change. We need to start challenging the narrative. And at Gilead, we either support initiatives, for example, whether it's where we can't have direct access to patient groups or patient communities. For example, we will look to make resources available to charitable partners who can. So people who are on the ground. So where we can, we make the difference from an advocacy perspective, but also on a policy level, we are really trying to do that. So if there are still people in the room who would love to be a part of the joint statement document, then please do reach out to any of the Gilead team or to Narman as well, and we could facilitate that.
Grant, thank you. Any other contribution from the panel? I know the question was to Tari, but have you, any of you got any other ideas to share in terms of how we get this policy change?
Well, maybe I could just add around funding, actually, in terms of, I think, again, a little bit of what you were saying, that sometimes it feels like a tick box, but, you know, in some way, we've put a lot of effort into making sure the researchers are taking into account that they're being sort of inclusive, but in many ways, maybe the funders and even, you know, when we talk about policy change, that how do we make sure, we know, for example, travel for our patients to be involved in these studies is a big thing. You know, it should really be, you have to include that in your funding when you're applying for clinical trial funding, that funders should be looking at, has that been included, rather than just they've had a PPIE event and that's, you know, like, so.
Yeah, and if I could say something to that, so for some of our studies at Gilead, we've included things like travel, a prepaid card, for example, for patients. But what we've actually found is maybe centres not being aware of the process, where perhaps it might seem, you know, at the point of feasibility, or we're still trying to unpick it. So insight would be great. People actually refuse that option. We present the option, but centres are refusing that option. So where we think it's a solution, but we're actually getting no's. So but then I guess it's the dialogue and it's the unpicking. And what we're trying to do now is to unpick the whys. So what is not clear, where we think we are doing this to facilitate travel, to make it short, to make sure, because, you know, some of our studies are at the larger centres. So how can we make sure that if you're from a DGH and you need to travel, you know, an hour plus, how can we make that feasible for you?
But maybe also just to push the, sort of be a bit controversial, maybe it's not just funding actually for travel, because, you know, we could do blood tests in the community, because actually, you know, if you have a cancer diagnosis and then, you know, you're in a clinical trial, you're having to come in and things, you know, I think I read somewhere it's nearly £800 that essentially that you're losing out per, can't remember, week or month, that, you know, a lot of our patient populations that should be getting into those clinical trials can't afford to do that. Yeah. So yes, you might be able to arrange transport, but they can't take a day off work to come in. So maybe we should be thinking about, and there are ways in which we could do that. They don't have to have a blood test in hospital.
Okay, I'll come to Toro and then Sam.
Just wanted to pick up on a couple of points. One is that money drives change, and we all know that. And certainly within the research community, the Athena Swan initiative, which many of you will be familiar with, was brought in almost 20 years ago now in order to improve gender diversity in academic institutions. But the NIHR made having Athena Swan status a condition of funding. And so the institutions basically realized that they had to do something about it, and it drove change. And I think with diversity in research populations, the widening of diversity, it will be driven in the same way. So as the funders say, if you don't do this, you won't get money, it will drive institutional change, which will filter down. The other point I want to make is about streamlined trial designs. So there's certainly evidence in the cardiovascular space of an increasing move towards doing digital trials. So essentially harnessing new technology to recruit patients into trials that they control their own participation in. You don't rely on NHS sites to be physical recruiters, and you also follow up patients through electronic linkage for outcomes. So again, reducing the burden of participation, so you're not recontacting patients the whole time. There are models, there are certain trials within cancer space that could work similarly, but it requires all of those networks to work. So getting the data from NHS England, encouraging patients, participants to use smartphones to be part of their research, and also again for educating the research community that these are trials that can give you, with certain questions, can do it in a very streamlined, low-cost way that is acceptable to participants to take part in. And thinking about all of these ways of removing the barriers to participation is important because, it was rightly said by Sam, at the moment it's a postcode lottery. You'll get invited to a clinical trial if you happen to see the right clinician in the right hospital at the right time. And we surely at this time, should be doing better than that.
Sam, quick one from you, and then we'll go to the audience for a couple of questions.
I was going off for a tangent. Come on, ask a
Sure.
question. Yes.
Okay. So we can take maybe a couple of questions from the audience if there's any questions before I'll ask my final question to the panel. Any questions from the audience in the room? I can see a hand up here. Katie? Do we have any microphones?
I don't. Hi, I'm Katie. I'm a clinical research practitioner at Adam Brooks in Cambridge, and I actually predominantly work in radiotherapy trials. And I suppose it's not really much of a question, but it is really quite interesting. I've worked in radiotherapy trials for probably about six years, and I have to say that the majority of our patients are generally white, British. And when we're therefore then not really getting a comparativeness, and your data then is very much aimed at one set of group of patients, and that's obviously therefore then not. Sorry, I've had a migraine this week, so my brain cells are slightly dead. And a comparativeness of the people who are then going into these trials or the treatments that are there for served afterwards, and I think. We really do need to do more. More needs to be done. I've said, in Cambridge, our ethnic region is not probably as wide as maybe as some other areas, but then that data then is therefore then not, good for, if you're looking at the whole picture. So that definitely really is more that we need to do, but I suppose it's how do we then move on and come up to the sort of the 21st century.
Thank you for that. I think one thing which is really important to understand in terms of study design is that you're trying to generate a trial population that's representative of the incidence of the disease within the population that you're looking at. And if we take breast cancer as an example, there's roughly 50,000 incident breast cancer cases each year, among which there are 300 incident breast cancers in women of Black African origin. There are about 300 in women of Black Caribbean origin, and maybe about 500 to 600 amongst Indians, and a sort of slightly lower number for Pakistanis. And these are national data. So I think there's also, because the diversity is so prevalent in people's thoughts currently, that actually, if you contextualize it and you take one step back, it may be that actually in a multi-centre trial looking at radiotherapy, for the centre that's working at King's, for example, where Sheba works, they really should be recruiting half of their patients from diverse populations because that's what their patient population is. Cambridge, not well known for its diversity, would be okay, right? So I think and again, it comes back to that sort of increasing knowledge of general prevalence, incidence in these groups. What is it that we're actually trying to achieve? Because you're not going to recruit a study that's 20% Black, 20% white, 20% Indian, because those numbers just simply don't exist in that disease space. So I think the sort of contextualization is really important, and it comes back to what I said earlier, that I think education at all levels within the ecosystem is desperately needed.
Sorry, I was just going to say, picking up that, it's clear we're all here because we know this is important. And I think what happens is, because I've worked alongside the NHS for a long time, is that lots of great pieces of work go on and then we don't learn from those, we don't hear about them. I know that the pharmaceutical companies want this to improve. We're doing pieces of work. I know Blood Cancer UK, Mesothelioma UK are doing good work in this area. And sort of the challenge is, how do we bring all that together so that we can learn from that? And I've been saying this for years over different things. And how do we add scale to this so the good things that we're working we can replicate?
One more question?
It was more of a comment. I'm a mum of a child that is in a clinical trial, and I just wanted to make a point about when you said about what is it that makes people take up the space in the first place. And one of the big things that I think as a mum that gets forgotten or that is really important is the communication. The communication is absolutely key throughout. My son is in a long-term trial, so it's been a fantastic partnership actually that's developed, and the level of trust that communication from day one has developed is now so implicit that the flexibility then on the families and the patient side is much greater. And I think that's also something that applies, I think, across the board of every family that, you know, contributes to these trials.
We just see lights.
I
sit there so I can see.
So Georgia Oni, I'm from Cambridge actually, so there's a bit of diversity there. I was going to ask, well, I was going to ask a couple of things, because Toril just raised the fact that actually there's not that many. So I work in the breast cancer space, and Toril just raised the point that there, in terms of how many people are diagnosed that are from an ethnic background, it's actually quite low. So I was going to be a bit controversial and say, should we have an opt-out as opposed to an opt-in type of system?
Georgia, I couldn't hear you actually.
Could you not hear me?
No.
Oh, no, I was saying that you had raised the point that the numbers, the incidence is lower in ethnic minorities. Like we both work in breast cancer, so lower. So should we be having an opt-out as opposed to an opt-in type of system to be able to capture people into research?
Well, say
it's going to be controversial.
Say from the outset that they're just opted out from research.
So they're in unless they say they absolutely want to be out.
Oh, I see what you mean.
Yeah.
So I think for non-interventional research, I think that's fine, and effectively you have that all of you in the room are taking part in research all the time if you're an NHS patient, because NHS data is used in a huge amount of epidemiological studies, and unless you have gone to the NHS and said, I don't want my data used for research, you are part of that. So I think, so to a certain extent, I think we already do that. I think we need to be much better about presenting what it is to be part of research in a way that's more diverse. You know, I think the trials are important, and I absolutely accept the trials are important, but they're not the only type of research that patients can contribute to. And I think if we can widen definitions and make it part of the research, of the clinical culture. But it's difficult, right? In a time-pressured consultation and all the rest of it, and trusts don't value it as much as perhaps they should.
Thank you. Now, I think my time is up, but I really want to ask this question before we leave here. So I want each and every one of the members on the panel to tell us one bold step we must take in the next 5 years to make cancer research truly inclusive. You've got 30 seconds each.
I mean, I think for me, it's going to be driven by the funders, because the money is going to drive change. So I think it is going to happen. We just need to make sure that it's done well.
Thank you.
I think we really can't pretend to say we're doing precision oncology if we're not being inclusive with, as I said earlier, data that we're collecting, biospecimens that we're collecting. I think when we're publishing, we need sort of the scientific community to make sure that you're being very open and transparent about ancestry and ethnicity, characteristics of your patient population that you're studying. But that, again, I'm going to go back, that puts a lot of onus on just the researchers, and in the end, the funders also have a big responsibility to make change. So, yeah.
So I loop back to my original point that we need to redesign the whole clinical trials approach, shall we say, so that it's being designed with patients, not for them, and that means embedding diverse voices at every stage of that process, from the funding decisions through to protocol designs and how results are shared, and that takes a bit of bold leadership to make that shift, but I think it's worth it.
I agree, Sam, and I think really cross-industry collaboration, so whether it's with academic institutions, with charitable organizations, with advocacy groups, we really need to talk a lot more. I mean, even with pharma industry partners, we're all seeking to improve and to make change happen, but we're all doing different things, and it's that sharing but also implementation of things that are done. So for example, the Royal College of GPs module on diagnosing breast cancer in Black women. How do we get things like that that are so significant and can make such change? How can we make things mandatory? So where we have good practice, how do we share these good initiatives?
Thank you. Last but not the least.
I would say to continue to acknowledge the role of institutional racism in representation in clinical trials. A lot of times we look at these groups as hard to reach, and they're not hard to reach, they're not reached to at all. And it was mentioned earlier as well, but if we continue to raise awareness and involve these communities in the conversation, then we would see that reflected in the research.
Amazing. Thank you very, very much. Panel and audience, thank you. Another shameless plug before I leave. Actually, I'm not ashamed of it at all. We really do want these signatures to be able to present about provision, widening the provision, and actually making it mandatory in terms of making sure that there is good provision of wigs, prostheses for people from diverse backgrounds. So if you're here, a clinician, and you are able to, please see either myself, Naaman, and we will be able to facilitate that for you. But we desperately need more signatures, please. Thank you.
Thank you. Oh, thank you. I'll pay you later. Thank you. Yes, that would be good. Do you know, I'm so poorly. I don't know what I'm doing.
Only if you want introduced.
No, yes, you were supposed to.
So we're on to the primary care session, and I think our two speakers could have had pitched in at the last session as well in clinical trials. So my name's Annie Young. I'm co-founder of Global Power of Oncology Nursing, which is a huge network which is growing with my great friend Julia Challoner from San Francisco, University of California, San Francisco. And it's because of London Global Cancer Week that we have GPON. And so I have to say thanks to Mark and Susie and Buki as well for letting us have it and starting off 6 years ago as well. On to primary care now. So we've got Professor Marka Iqbal. Where's your friend? Is she coming up?
I have no friends. She'll come on after me.
Yes, she coming up to the stage? Yeah, okay. So we're going to look at the role of primary care in addressing disparities, really. This is what the whole session's about. So it seems like you all know Margaret. No, Professor Iqbal is a GP partner in East Yorkshire. She's a GP, of course, and she's former director of Hull and York Medical School. So that's where I still work with as well. And she's been just appointed as patron of the Caribbean and African Black Healthcare Awards, and that's to recognise the wonderful work she does in that population for many years in advancing equity. But more so, she's got lots of patronages, but more so, she's now just recently the Deputy Lieutenant of East Riding of Yorkshire. So I think we have to salute Margaret.
Thank you. Honestly, that's just, I get embarrassed by the bio, I'm not going to lie. And it's not just me, the next speaker's a DL as well. So, but yeah, no, thank you very much. So, I'm just going to make a few apologies. I'm harbouring some funky lurgy that I've had for 3 weeks, but I'm not infectious, so don't worry. But I am, like Samantha, very perimenopausal, so I've got my notes to hand. So I am currently a GP in the Far East, as Annie said, otherwise known as Hull. And I'm also the vice chair for the and I use a lot of humour, I'm sorry, it's just me. It's after lunch, you know, it's always a tough gig. And I'm also the vice chair for professional development for the Royal College. So essentially I have oversight of our exam, CPD, and our annual conference. So I've been told we are a little bit behind, so I'm going to be quick and make no apologies for it. But I'm going to start with a story, as I always do, of two young women. The first woman on the left, I knew nothing of her up until 18 months ago, and her name is Jessica Brady from Stevenage. And Jessica was a talented engineer at Airbus, and she was involved in designing things like satellites. And in July 2020, probably as we're getting towards the peak of COVID, up until that point, she'd been really, really healthy. But that month, she just didn't feel right. And she contacted her GP practice 17 times over 5 months. She did get some face-to-face appointments. I think she got about 3, but mostly they were remote, and there was no referral made. What was happening with Jess? Well, she was losing a lot of weight. She was having night sweats. She had a persistent cough. Her lymph nodes were all enlarged. And because, you know, COVID was out there, you can imagine several times she was told it's just COVID. She went to A&E. She was discharged from A&E within an hour. And the family decided to arrange a private appointment for her. By the time she was referred to a specialist, it was just too late. She was given a terminal cancer diagnosis of adenocarcinoma. They weren't sure of the primary, and she died in just a few days before Christmas in 2020. The other woman on the right-hand side, that's my mum. She doesn't look like that now, and when I showed her the PowerPoint, she's like, well, you've got a beautiful Jessica up there, I want a beautiful photo of me up there. So it's my mum in her 20s, but 15 years ago, she said to me, I've got some lumps on my hairline. And I looked at them and I said, oh, you really need to see your GP. She says, I am seeing a GP, you. I said, right, Mum, you know how it works. I can't do anything for you. Go and see your GP. So in the evening, I called her and I said, right, what did the GP say? And he said, oh, well, I've got a telephone consultation and I've got some E45 cream. And I said, well, that's not going to cut it. You ring him back. So a couple of days later, I said, what did your GP say? Well, they saw me and they thought, well, actually, they said it's because of something to do with, is it traction alopecia? Or I said, but you don't wear your hair in any braided style. And you're not losing your hair. What the hell? You know, I've been given a steroid. And you know, as a clinician, it's really hard. I'm sat on my hands and I don't want to get involved. But I rang her GP up and I said, look, I'm really sorry. Can someone just stick a needle in this? And she had a follicular lymphoma. And we often talk about this, and she's still going strong. She'll be 80 in a few months' time. But Jess didn't really have any advocates at all. You know, my mum had me. So I think we've already mentioned why the disparities exist. Our previous panelists, I think, have addressed this really well. One of the things we have in primary care, the obvious is access. Yes, we are chronically underfunded, workload is at its peak, people are leaving because of burnout. But actually, there's really poor continuity of care in primary care. And from a cultural point of view, we're not as culturally sensitive as we would like to be. But more importantly, whether we like it or not, a few months ago, patient satisfaction rates were at an all-time low. People don't trust us. And our next speaker, I didn't realize how much they didn't trust us until I got involved with the Saturday workshops that happened with the Caribbean Afro Health Network. And I remember being asked by one of the attendees, you're always talking about this vaccine, but just tell me, okay, this AstraZeneca vaccine that you're talking about, how many black people were involved in the trial? And it was such a powerful question, which had really damning consequences, because I knew the numbers were less than 1% at that time. And so they were like, well, if people aren't taking part, why is it that you want us to have this vaccine? And it was really, really, really sad. The NHS Race Observatory had a report that was released in March of this year. So if anyone has got a chance to read it, please do. It did talk about what we can do to make things better and address various organisations, including Royal Colleges, in how to mind the gap. But I'm also mindful that when we have certain approaches in primary care, we always go to the places that we think patients are. So it's the obvious places, faith communities, church halls, And my daughter said something quite stark the other day. She said, you know, you've got this study that you're trying to get uptake in younger people from diverse backgrounds, but you haven't gone to any nightclubs. That's where my people are at. And I thought, she's right. So we know what works best: personalised and culturally relevant outreach. And that's the way, and using better data. The other thing we don't do really well in practice is use our data to our advantage. So I think it's really important that we try to get that message across. But again, it all comes down to trust, and it's about building trust a lot across various networks. As sad as COVID was, because it was an awful, awful time, what it did do and what it catalysed was our efforts to collaborate. In my lifetime as a general practitioner, I've been practicing for 20 years, I don't think I can remember as much engagement across various stakeholders, key stakeholders. Policy's been mentioned several times, and I'll come to that in a minute, but that's been really quite profound. I'm just whizzing through this, so forgive me. Someone talked about, and if you're still in the room, Esther, I do need to speak to you about non-attenders. I had a student the other day, because I work in the East Coast. Our population is very different. My population, the most disadvantaged person in my community is a young white male. And we often take things for granted. We don't use the data well. So we had, I'll give you a quick example. We had one of the poorest cervical screening uptakes in the country. So national average is about 80%, and we were just hitting 70% consistently. And the practice thought, well, it must be a resource issue. We'll hire 2 more nurses, and we did. And we moved up to about 72% in 18 months, which was a bit rubbish, really. And with one of my sex workers, I remember saying to her, you know, we've sent you loads of texts to come in for your smear. What's going on? And she said, well, Margaret, I can't read. And it really humbled me, because, you know, we knew the reading age was around 6, but none of us had really kind of thought what that meant in reality. So based on that, we used our social prescribers to engage that network, and it's worked to good effect. We're back up to national levels now, but that's just a really small example. But someone mentioned non-attenders the other day, and we often write in the notes, you know, a child not brought, or DNA. It's a common acronym, isn't it? And one of my trainees said, well, I don't use DNA anymore, because I rang somebody up because I was worried about her and she did not attend. And she said, well, she missed the bus, and there's only 1 bus every hour in where we live, because they have to take 3 buses to get to us. And so that was it. You know, it's not that she did not attend. She's an HTA. It was hard to access. So it's how the language that we use when we address certain populations. Sorry, again, I'm going to whiz through this. What I'd like to talk about is our attitudes, though, as a profession to certain things. So some of you will know that the Transform trial was launched not so long ago. And in the college, we have an overdiagnosis group, and I'm not pointing fingers at anybody, but for the longest time, you know, there are people who are pushing back on screening for certain conditions. And again, it was really powerful when I was told in a meeting, you know, we can't bring prostate screening into practice. And the words used were, it will just cripple the profession, because everyone and anyone over the age of 50, a man, would want a screening test. And the studies show, and that's what I was told, the studies show, Margaret, that it's actually no use or value in doing this. So I said, let's just look at this study then. And I can't remember the name of the study. It was a cancer research study, but, you know, thousands. And I said, what was the strong sort of, one of the limiting factors of this study? There was hardly any black people in this study. And if you think about who this affects more in terms of incidence, you know, it's twice as many people as black men are affected by this. So how can you say it will cripple the profession? Policy is important, and unless we engage our policymakers, and Faye might touch on what they've done with the All Parliamentary Group, unless you're in the spaces that matter, nothing moves. So when she used to work for the NHS England, our head of health and equalities, she went along to a movie screening. I think Nam and we were there at the Unseen Unheard screening from Black Women Rising. And Bola wept. And she rang my boss. And my boss just couldn't get this out of her head. And she came up to me, she said, what are we going to do? You know, we know that breast cancer can arise early in black women, so what is it that we can do? So I said, well, the first thing we have to do, and I think it was mentioned by one of the previous speakers, is education. Because unless we're talking about it and showcasing what the issues are, again, nothing's going to change. So I went along to my team, and it's not lost to me as a black woman, you know, that I was asking for these things. But having our exhibition, if anyone's in the Royal Euston anytime soon, we've got a health inequalities exhibition on the ground floor. And on there, in one of the cases are the prostheses that you can see that are now available. And people were just shocked that, how is it that black women weren't even getting the right prostheses after having a mastectomy? It was just shocking. But unless we're in the spaces that matter, so leadership, diversity of thought, but also diversity of leadership is really, really important in what we do. And thank you to Gilead as well, to Riro, I know is in the room. They were absolutely pivotal in making that module happen. So coming back to Jess, some of you might know that on the 23rd of September this year, the 3 strikes and we think Jess's rule was launched. And again, Jess's family approached us and said, what is it that you can do to help us? But often as a profession, we become quite defensive. And, you know, to be fair, that is what happened in the beginning. And then literally had to stop the room and say, what if Jess was your sister or your daughter? What would you like to happen? For people to think about the consequences. So Jess's rule, the core principle of it is the 3 times and we rethink strategy. So we reflect, in other words, reconsider what's been discussed or what you might have missed as a clinician. If your consultations, if there are any GPs in the room, if it's been remote, offer a face-to-face and a physical exam. There's not that many conditions I feel confident in treating over the phone or remotely. Review it. If you're not sure, you know, yes, we are a profession that deals with everything from cradle to grave and then some, but if you're not sure, just ask somebody. And if the patient walks through the door the 3rd time, rethink. What is it else I could be doing here? Do I need to investigate this or refer this patient on to somebody else? The other thing which Faye might touch on is the Black Health Improvement Framework for general practice. It's not specifically for general practice, but it's based around 5 pillars, but I'm going to leave that with her. But on the basis of those 5 pillars, the absolute foundation is trust. I should have mentioned one of my other hats is I'm the national lead for NIHR for primary care. So essentially, I'm tasked with driving primary care studies effectively. And I think it was November last year, inclusion is now a key condition for NIHR funding. So if the inclusion, and as not a tick box exercise, is not part of an application, you might as well just shred and bin it. I'm thinking of the rationale of putting my favourite hero on this. So I think it's almost 2 years now since he passed away. And many of you might know Benjamin Zephaniah, absolute advocate and poet. And he had a brain tumour. But I think he only found out about his brain tumour 8 weeks before he died. And I do use the arts in my presentations, and this afternoon's no different, so I'll read this out. We black men of England excel as if in sport for our people, because some people want to see our face in court. When we black men of England look the mirror in the face, through our sisters' eyes, we men shall rise as proud sons of our race. At a recent APPG, someone said, we don't need allies, maybe we need comrades. So, to all of you, comrades, assemble. Thank you.
That was a fantastic talk, thank you. I'm just going to open to any questions from the audience, please, about that. If not, I'll perhaps start with a question while Annie's sort of roving around. So, in your mind, what do you feel is the biggest missed opportunity in primary care for not only prevention but also finding patients early with their cancers?
So I think one of the biggest things, we're just so snowed under, I'm going to just tell it as it is. And with every group, every condition, whether it's cancer, whether it's menopause, because we are responsible for so many patients and conditions, it's often quite challenging to know where to start. But I think we need to realize that we're not alone. It's not a primary care responsibility, it's an all of us responsibility, and it's knowing those levers that you can lean on within the practice. So I talked about social prescribers who aren't clinicians but have more than the 10 minutes or 15 minutes that I have to give as a clinician, but we've used them to really good effect in terms of community outreach. And I think it's those things that are really missed opportunities. We're a chronically underfunded system, so even though 90% of all NHS activity happens in primary care, money's been mentioned several times, less than 10% of the funding comes our way. I mean, I could go on and bore you to death with all of this, but it's thinking of ways of how we can share that burden with others. And I think working at scale has been really quite effective, but we have to be careful about that, because working at scale is great for some practices, but in mine, we are quite geographically isolated and disadvantaged. So there's not many practices near us to work together at scale. So it's thinking outside the box. Who else is there that we can engage? Voluntary care sector, local councils. I think moving towards a multi-neighbourhood provider status will help us tremendously. Sorry, that was a really long-winded answer.
No, that was brilliant. Sort of a call to society to act.
Yeah.
In the most part, yeah. Brilliant.
I think there's two. One, two.
Question from Narmin at the front.
Thanks, Margaret. What's the role, in your opinion, of healthcare professionals to educate young people at schools about stuff like this?
So I think we so need to be embedded in that system. It's amazing how little some of our schools are aware of the health concerns that will affect them as adults. Small example, I know Ziz is in the room, but I was giving a talk on menopause, and my 16-year-old said, "What's menopause?" And I said, "Oh, it's when your periods stop." She said, "Oh my God, they stop?" And I was like, "How would you not know this?" You know, so, you know, it's a loose example, but it's doing it in a balanced way that doesn't imbibe them with fear and anxiety of what to look for. But actually, I think there's loads of stuff that is happening in schools at the moment. So in terms of research, we have what we call settings leads now. So I cover primary care settings, but Shira Chok, who some of you might know, covers community, which includes schools. So there are some initiatives, some really good initiatives, which are trying to get into schools and educate them. Yeah.
So Margaret, you sound as if you engender trust in your patients.
Yeah.
And is there anything else that could be done? Because we've talked about trust a lot today, and is there anything else that we could do for culturally competence or just teaching it, education, that we could do to build that trust?
I think it's just engaging with your local GP practices and finding out who they are and what it is they are doing and how you can work together, because we all have a common cause, which is the patient that needs to be at the centre of absolutely everything. The challenge that we have in primary care, in terms of, because I do a lot of work around EDI and accessibility, we're not structured the same way as secondary care. So 50% of us are independent contractors, so we're not thinking about EDI and belonging or accessibility. It's an afterthought. And so how can we get those programs in, and I don't want to steal Faye's thunder, in terms of being culturally sensitive and safe and allowing our practices to have those discussions, because I could give you so many examples and you'd think, oh my goodness, how would you not know this? But it's because it's not something that's mandated. You know, I don't want to add to people's learning, but you do need to know, you know, how your wheelchair user needs, what their needs are in the practice, or when someone comes and says, I don't want to see a black doctor, how would you deal with things like that in practice? Because these things happen.
Yeah.
So I'm mindful there's a lady right at the back, I can just see through the lights.
Here we go.
Thank you so much, Margaret. Really nice. I had an experience, you know, and I just want to share it with the room. And the experience was that when I'm a pancreatic cancer survivor, and when I had that episode, I was always going to my GP, always. Throughout 2018, I was going to my GP, and my GP would say, oh, there's nothing wrong with you. You're just short of blood, you're anemic, you know. And they were pumping me with iron transfusion and blood transfusion. And I kept on telling them, even if you're pumping me, there must be somewhere the blood is going to, you know. And when I go back, they will tell me, oh, don't worry, there's nothing wrong with you. Until somebody now said, no, this is not normal. How can you be short of breath? And all the symptoms are there, and yet they did not see it. You know, for me, it was carelessness. If I had not changed hospital, I would not have been here today. And by the time I got to the hospital, I was told all my systems were shutting down. So, and also because of that, I started a charity called G-Changer, and the people in my group are now experiencing the same thing. I lost somebody about 2 weeks ago. She kept on going to her doctor, telling her, I'm not feeling fine. The way I am feeling, it's not right. And the doctor kept on telling her, no, she's okay, she's fine. Okay, at one time they told her to go to the for a scan, and then they diagnosed she had breast cancer. She got, fortunately for her, it was still intact. But by the time they dilly-dally, that cancer spread. And she passed. They caught it on time, but from that time to the time she passed away, it was too late. And also, consultants, they should please, I don't know how many consultants are in this room, they should try and listen to the patients. Your patients are human beings. And when they're telling you they're feeling one way, please listen. They own the body and they know how they feel. The way they respond to the feelings of patients is poor.
Thank you for sharing that.
Thank you.
I didn't want to, I really thank you for sharing that. To be honest with you, it's a really difficult story for me to hear, because you don't want to come out like you're slating your colleagues. That's not what I'm trying to achieve. And in fact, the story I wanted to tell wasn't about my mother, it was about my aunt who died 2 years ago with pancreatic cancer. But I didn't think I'd be able to get through the story. So, thank you. I think we need to connect. I think self-advocacy is really important. And I think it's really upsetting to hear that people have to go through those hurdles just to be heard, just for someone to listen. So, yeah, sorry. It's the fact that I didn't put my HRT patch on this morning. It's I'm struggling. Yeah. Thank you.
Thank you so much. That was absolutely brilliant, very inspiring. Thank you. So I'm going to welcome onto stage now Professor Faye Ruddock, who is Chair of the Health Equity at the University of Greater Manchester and founding Chair of the Caribbean and African Health Network, which is an organisation, a national organisation, which is Black-led and tackles health inequalities. She's a leading advocate for Black women's health, focusing on fibroids, reproductive equity and maternal outcomes. She also chairs Greater Manchester's Maternity and Neonatal Equity Group and serves as NHS England North West Independent Chair for Anti-Racism in Nursing and Midwifery. Thank you so much.
Thank you, and thanks for the invitation to be here. I think I received this invitation was it about February, Bucky? And I thought, oh my gosh, we've got ages, and here we are. So thank you for the invitation, and yeah, it's good to be here and to hear some of the conversations, and some of that, what I'm going to say, which I probably won't say, because people have said it already, and I've been here since probably the last presentation this morning, just listening to those key things about trust and how important it is when we're actually dealing with some of these health disparities that we all know too well. So I just want to start by just talking about CARN. I just want to give a bit of insight into this organisation. So I'm coming from this as a kind of from a community organisational perspective, and I don't know whether that's been kind of discussed so far, but I just want to kind of give you some reality checks really in terms of where we are and why it's so important to engage with community organisations when we're trying to address kind of cancer care disparities. So about 13 years ago, I worked in, I'm a nurse by background. I went into the university sector, and I was doing quite a lot of work with our nursing students, developing nursing degrees, things like that, and kind of seeing how so much was missing from the curriculum. And I wanted to change that. And the reason why I actually left the front line is because I wanted to do something to change the way nurses were practicing, because in nursing we often say see one, do one. That's the way we tend to kind of like watch how other people do it, so we learn and we think we're doing it the best way, but actually we're not. So I went into universities to stop them in their tracks. I wanted to do some education that would produce nurses that were actually going to be practicing much better with equity and fairness to all patients, not just the few. And so I was in nursing education, but then again, I'm starting to notice the disparities within education as well. One of the things that I kind of wanted to do was to really understand from what I was seeing in the clinical areas, which were disparities, what I'm seeing in the university perspective as disparities, what was actually going on. So I decided to go into the community settings, into the Black community settings, because that's where I was seeing more of the disparities around health. And I asked the question, and this was part of my master's thesis, I asked the question, what relationship does the community have with the then Primary Care Trust? So for those that were around PCT days before it became CCGs, and then of course ICBs. And what I was hearing was that there was no relationship. Nobody was really speaking to our communities. So we knew about all of these health inequalities around cardiovascular disease, strokes, diabetes. We were seeing people with amputations. We were seeing people that were dying in their 30s and 40s. And we're like, well, what's going on? Why isn't anyone really engaging with these communities? That's what made me take it to a degree and to a doctorate, because I wanted to dig a lot deeper into understanding why these disparities actually existed. And where we often say, and somebody mentioned it before, where people say, oh, we're hard to reach, and people like us don't come forward for research and things like that. I had 4 focus groups. I put it into, I had it in a church. And what I created was this ethnographic setting where people would come into a space. So it was a very well-known community church, and everything happened there. So people, when I put this advert out, I'm thinking, oh my gosh, people aren't going to turn up. But actually, they did, because the question that I asked was, why are we, as Black people, having so many kind of heart-related outcomes? Why does that exist? And people wanted to know, but what they wanted to know was, what was I going to do with that information? They didn't want to, and somebody has said it as well, we often get asked question after question, but we don't actually see what happens with all that information. So what I said then was, I don't know what I'm going to do, but I won't just leave this. I won't just leave it on the shelf. I'll do something with it. And so that was when the Caribbean and African Health Network was developed, because what I took was a grassroots approach to addressing health inequalities in the Black community, because what they were all saying is, you know, we are here, we go to our GPs occasionally, people are just doing things to us that don't make sense. So how can we change this? And that's why we had so much support with CALM. So in 2017, so I'm still doing my PhD, I haven't finished yet, but we had devolution in Greater Manchester. We were the only region to have it. And I said, well, look, I want my slice of the cake for my community. How do we make sure that we are around the table? These are with my directors that were part of my lived experience group to really shape devolution and health outcomes for our community. So in 2017, we had this mission to end health inequalities for the Black community within a generation. And of course, it's a very ambitious mission. but we set out to do something that was very quite radical, very different. And this vision is about this society that embeds racial equity. And I just remember when I was doing my PhD as well, my supervisors, they did change about 3 or 4 times, was that they were saying to me, it's not about race. It's not about race and racism. It's about diet. It's about all the other things. But nobody wanted to actually address the fact that race and racism was a real kind of integral part of what was actually going on. And I always remember challenging Michael Marmot. This was just 2019. He came to our office and I said, why is racism not one of the determinants of health? And he said, we've got no evidence for it. And of course, fast forward to COVID, we can see that it's very, very much embedded in that. So this is the case that we have for Khan, and these are what communities tell us. They tell us that there is poor access, there's poor experiences, and there's poor outcomes, and we've heard a lot about that already. There's a lack of trust. Again, we've heard a lot of that. There's poor engagement, and that's part of the reasons because we don't engage for the reasons that we know. And so there's poor engagement, there's lack of targeted research, and also there's the structural racism. And what we kind of focus in on is decision-making and representation. And I think what we all kind of, or maybe many of us do know, is that we tend not to be at the decision-making tables. We tend, whether it's in nursing, whether it's in medicine, wherever you look, there's not many people that look like me. We tend to benchmark to majority populations, and I remember being involved in one study just recently, in one piece of work, where we've now got a gold standard for a protocol, because the protocol that they used for clinical trials was very much benchmarked to majority population. So even though a health condition is very likely in a black woman, what we've done is I've stripped it right back. All the biomarkers and everything didn't mean anything to somebody, a black woman. What that would mean is that we would actually exclude all black women from taking part in that study. There's also the racial discrimination and also poor community engagement. And what we do have as well is we have, in our organisation, we've got 50 staff now, and we are a national, we started in Greater Manchester, but we are national now, is we have somebody called a faith liaison officer that actually engages with our faith community, because 84% of black people will go to a church or have some affiliation to a church. So it's really kind of quite key that we have somebody that focuses in on our faith sector. And these are the streams of work that we have. And of course, there's cancer there, which is what I'm just going to kind of focus in on now. So just to say, and again, this has been probably mentioned already, is that black people in the UK have a overall lower cancer risk. But we know that we face higher kind of poorer outcomes. So even though overall we have a lower risk, we know that things like prostate cancer is like 40%. We know breast cancer, late diagnosis, and things that we've already mentioned. We also have mentioned as well around there's so many challenges and working in community organisations and actually hearing it from the grassroots up when people talk to you. Because I remember years ago, and this is before I kind of got into this space, is I was speaking to some black young men, and I was saying, why is your attitude so, they seem so angry about things? And they were saying, it's because of the way that we've been treated, the way things have been done to us, and really kind of laying back to that historical kind of treatment that we've had. And so things like historical trauma is still very, very evident. We have so much unresolved trauma in the black community. There is that invisibility as well in medical research, which is something that I've already mentioned. And also that skepticism as well around research is still very much there. And I'm speaking from a perspective where I'm dealing with our communities all the time, and these are the things that people are saying. There's also the structural and global barriers as well, underrepresentation. There's the research that's extractive, and also the systemic racism, and also the community and engagement barriers. And again, the panel discussed a lot of those earlier on. So these are the kind of things that we are doing within the organisation. We do an awful lot of education and awareness. So Margaret mentioned the Black Health Improvement Framework, which was really set up for primary care. So this is about, you know, us speaking, having 1 hour webinars with primary care practices, talking about how do they actually engage our communities better. We do a lot of advocacy and representation, which is very, very key. And even just listening to the story of, you know, the one that was just shared just now and some that Margaret's just shared, advocacy is so important. And, you know, we often talk about second opinions. We do things like health hours on a Saturday morning. Again, Margaret's mentioned that, because we need to speak to our communities to say, look, we can advocate for you, we can support you, we can give you lots of guidance and help to support you through when you've been told by the GP, you know, just go away, or just take this. You know, we can do that advocacy. There's also the inclusive recruitment. I've mentioned that already. Feedback and accountability is really, really important, and capacity strengthening as well. These are just some of the health hours that we've been doing. I've just put some of them up. We've been doing them now since May 2020, and we do them for 50 weeks of the year. Every Saturday morning, if you log on to Khan, you will find a doctor, a GP, consultant, surgeon, whoever, actually delivering a session to our community, and that happens 50 weeks of the year. And these are just some of the ones that we've been doing around cancer in specifically. I've talked about the engagement in research, so I'm not going to go through that, but just some of the kind of principles of culturally competent care, really key about respecting our cultural identity. The tailored communications, again, really, really important that we do tailor them. I always remember when we were going through COVID and there was a piece of communication that we sent out. This was just before it was actually announced as a pandemic. So we have a newsletter, we sent it out and we said, look, our communities are going to be affected the worst through COVID. We knew that because we know about all of the different comorbidities, the way people live, etc., etc. And of course, that's what happened. But when we approached public health at the time, they said, oh, all the material that's going out is fine. It didn't need to be culturally tailored to our communities. But of course, that did change. Representation in care teams, faith and spirituality awareness, knowing that when you speak to many people in our communities, faith is so important. And if you ignore faith, I mean, some people will not do anything until they've spoken to their pastor or their faith leader. They'll not agree, they'll not take medications, they'll not do things until they are, you know, their pastor or elder will actually say, yes, it's okay. So faith is really, really important. Language, and not just language, dialect, all of those things are really key. Partnerships, avoiding assumptions as well, and making spaces more welcoming for everybody. And just, this is some of the kind of guidance that we'll give to people. I was just saying before that when I went for my mammogram the other day, people, the people that were doing the mammogram said to me, as soon as it came to taking my ethnicity, they said, oh, don't feel you need to give it. Don't feel you need to give your ethnicity. You know, it's just one of the questions that we ask. And the fear that people have actually trying to get this information, it almost put me off giving the information. If it wasn't for myself knowing the importance of it, many people will be put off by that. So we say when you attend your regular screening make sure that people know, you know, you give the information, because it will help with future treatments and services and etc. Know your family history. Again, that's going to be quite challenging for some people. Again, if you're a migrant or if you're asylum seeker, all of those things can create challenges. Adopting healthy lifestyle habits. again, we're often told it's because of what we eat that causes cancer, you know, but when we look at the Eat Well guide and we look at these things, they don't really accommodate us. They don't really, you know, speak to us as well. Things like smoking and limiting alcohol. When we often talk about smoking, we talk about smoking cigarettes, but actually, if you think about our communities, and this is where there's a lot of public health messages that need to change, is that we don't tend to smoke normal cigarettes. You know, we tend to smoke other things, you know, and so who's talking about that? Nobody's really talking about that. And of course, these things can cause cancers as well. So the challenge of medical bias, culturally tailored resources, we do an awful lot of that, and we tend to do that in co-production with our communities as well. Because one of the things that's really important is that people can own it, they see it, they say, I've been part of that. It makes a huge difference with engagement. And again, we talked about participating in trials, etc. And I just want to play this just to finish, because this is, we tend to do an awful lot of event days, awareness days, and things like that, because we know that our communities, they like to come together, and we share an awful lot, we learn an awful lot. But this is what we did in October, and it was just an awareness day. There was about 40 women that were here, and it was talking about breast cancer awareness. And even when we talk about cancer, the word cancer, language is so important. Because even in 2017, when I tried to put a breast cancer and prostate cancer awareness day together, I couldn't get people to come because it had the word cancer, you know, and for many of us, we see it as a death sentence. Things changed as soon as we started to change the language a bit, but now we've been able to move towards actually saying and using the words, and people are engaging a lot more. But this is just what I want to end with, so I'm just going to play it. Hopefully it will play.
See what it feels to have a lump in the breast. And Gazala said so much about touching it by yourself. So we're all going to touch on boobie and see what it looks like, so that when we touch our own, when something is different, we'll be able to spot it in time. So thank you so much.
What better way to talk about breast cancer than to bring breast cancer warriors to you to share their amazing stories. So today I've got my gorgeous ladies here. As you know, that's Gloria. Yeah. And that's Bola. And Jenny. So these are my wonderful, beautiful ladies that have wonderful, amazing stories to tell. And without wasting much time, we're gonna have like a panel discussion. We'll talk about their journeys, they're telling their stories in their own words, with their own voice, so you can hear, you know, learn from them. And you know, nobody knows what tomorrow holds for us. Research is saying in our lifetime, 1 in 2 people, 1 in 2. So we're like 40 in the room today. 20 of us are going to have cancer in our lifetime. So we have to be prepared for it. Cancer is not a death sentence. You're not going to die because you have cancer. If you catch it early, do the right thing, go for treatment, get it checked, get whatever it is removed. Trust me, you can be like one of my beautiful ladies if that time comes. I'll start with Gloria. So, how did you find out you had cancer? So what symptoms did you notice, and what prompted you to go for that first appointment where you got that news? That
So me, I didn't have any symptoms. All I noticed that my right nipple was covered with lumps, and it was so unusual. I kept kind of contemplating, is it normal, is it not normal? But then again, my instincts asked me to just go to see the GP. I almost got misdiagnosed. So that was why I always advocate for second opinion. So if you are not comfortable with what the doctors or nurses are telling you, just seek for second opinion, because you might be saving your own life.
That second opinion, it's your life. It's not the nurse's life, it's not the doctor, it's your life. So you're in control of your life. If you think there's something there and they say, oh, because Gloria is not alone in that misdiagnosis thing. I'll just give you a quick story. There was another lady that we supported in our charity, and she had ovarian cancer. For 2 years, she kept going to her GP. The GP kept saying, oh, you're bloated. Oh, it might be an early onset of menopause. Oh, you know, and she knew something was wrong. sadly it was stage 3 cancer. So yes, so that's an amazing story, Gloria. And yeah, I was going to just talk about some myths that people have about cancer, things like that make people afraid. One that just came to mind is when people see lungs and maybe the first clinician says it's nothing, they're happy, they're actually happy. Don't think it's, I don't know, I don't want to know it's cancer, because knowing actually it speeds up the treatment, yeah, because the earlier it's caught, the better. So how was your experience with the doctors? Did you feel you were properly looked after? Did you think throughout your treatment, and then were the options available explained to you better?
My story is just that I patched it up myself because it happens that.
Okay, so yeah, that's it just for now, and I'll share the slides if anybody wants to.
And if you share
watch
the
rest
video
of
at the
video.
end, that would,
Yes,
I'm sorry
you.
to cut you short, but that was real leadership in action. And I loved your can, and I think Barack Obama may have stolen your can. Yeah, I can, you can, we can. Thank you.
Do we have time for a question for Professor Ruddock? Perhaps she's gone. Maybe if I could ask you a question, if that's okay, we can perhaps give you a microphone or ask you to come back on stage. I was reflecting when you were talking that, certainly in my practice, and I'm a clinical oncologist in, quite a diverse community in West London, that, I go into my new patient clinic, as I did yesterday, and I get 30 minutes in my clinic session to meet a new patient, tell them their diagnosis, talk to them about treatments, consent them, and then book everything and dictate my letter. And yesterday, for example, my new patients came from Romania, the Philippines, and Nigeria. And I'm very aware that they probably get from me a very standard script of what I say. So I guess for clinicians like me, how do we start giving better culturally intelligent information and communication within that very busy NHS space?
Yeah, I think just take a step before that. I think it's really important that we co-produce some of those conversations. So one of the things that we've been doing in Greater Manchester is part of the Call 20+5. So we've been working with GP practices to ensure that when patients do, from those different areas that you've talked about, get the best 5-10 minutes of consultation that they can, they co-produce it with patients so it's more meaningful. They use lived experiences to give that insight about cultural competency. So I think it's about co-creating rather than thinking that you can do it on your own. So that's what I would say. Yeah.
Okay, thank you. That's very interesting. I think we have any other questions at all? Any more questions? If not, I have Bookie coming onto the stage. Thank you. Thank you.
Thank you, Katie. So it looks like we have been able to cover the time back, so thankfully. It's time for me to move to the second rapid fire panel of the day, which will be talking about tackling misinformation and mistrust. And I have the pleasure of introducing the moderator for the session. She is no other than Leanne Pera, MBE. She is a multi-award-winning social entrepreneur, speaker, host, author, and breast cancer survivor. She set up her dance company, The Movement Factory, when she was just 15 years old. Since then, she has successfully fundraised over £500,000 to run community dance programs for young people all over London and is an official Nike London partner. After being diagnosed with breast cancer in 2016 at the age of 30, Leanne then set up her namesake charity, which houses the infamous Black Women Rising Cancer Support Program that won the National Lottery Award for Health in 2021 and now helps over 500 women of color in the UK who have had a cancer diagnosis. Leanne has been featured on many, many media outlets such as The Telegraph, Marie Claire, The Voice, South London Press, The Express. I could go on and on. There's nowhere she hasn't been, you're gonna see, but she's a wonderful person. You know, I've had the opportunity to know her for a short period of time, but in that short period of time, I've seen how genuine she is, how she wants to change things, and what a strong voice she had. So when I was thinking about tackling misinformation and mistrust, the only person I could think of was her. So please welcome Leanne Farrell.
Thank you, guys. That was a lovely intro. And yeah, thank you for having me here today. And as Dr. Buki said, you know, this is something that we tackle day to day within our work at Black Women Rising. So it is an absolute pleasure to welcome some incredible panelists that I am so excited to talk to today. So can I invite Martina, Ashley, Aziza, Owen and Rihanna to the stage to help me. Thanks, guys. Let's keep the claps going. Come on, guys. Incredible. Well, look, we know that misinformation and mistrusts are two of the main factors that drive inequalities in healthcare, and stigma contributes to this alongside issues around engagement and trust. How can we change it? So I've got a question directed at each and every one of you. So Martina, let's start with you. And if you can, before you answer the question, introduce yourself as well. But how does health misinformation influence patient behaviour in low, middle income countries settings, and what can we learn from that?
Yes, my name is Sinta Kristanti from Universitas Gadjah Mada and representative from Global Power of Oncology Nursing. So I guess information is very important at the moment, especially in lower middle income country. We also suffer from lots of misleading information related to unresponsible sources as well. So I think as healthcare professionals, we also have the task to make clear information in direct and simple way.
Yeah, thank you so much. And Aziza, how can clinicians use digital platforms more effectively to counter misinformation? Because we know that's something that you do so well.
Oh, thank you so much. Thanks.
Yeah,
hello, everyone. How you doing? I'm Aziza. I'm a GP and I wear a few hats. But before I start, because you said that. Before I start, you mentioned about taboo and stigma being one of the issues, and I'm a big advocate for destigmatizing a lot of things, and particularly when it comes to female reproductive health. So yes. I have this. I'd love you guys to tell me what this is. You could, what is it? You can
say it out louder.
It's not bad word. Okay, on the count of 3, can I get everyone to shout vulva? 1, 2, 3.
Vulva.
Because they are not bad words. And if you're okay saying that, can you say what's behind my back? What does that say? Vagina, vulva. There's a song. Okay. All right. So I do a lot of health information online. I run a platform called Talks with Dr. Cissé, and I share engaging, fun information on health, because what I want to do is try and capture people's attention, and they don't realize that they're going to watch something that could potentially save their lives. And actually, this is something that's happened a lot. So I've had there's a video that I shared with a line diagram of a vulva, and it has a black vulva. And when my aunt saw the video during Ramadan, I'm Muslim, she was like, oh my God, Aziza, astaghfirullah lazim, that means God forgive you. She said, how can you post this in Ramadan? And I was like, but people can get diagnosed with cancer in Ramadan. And actually, I had someone who looked at the video and she paid attention because it's the first time she'd ever seen a brown or black vulva on screen, because you don't get that representation. And then she saw a doctor who looked like her telling her that you need to check it. So she checked it, and now she's been diagnosed with a condition which we hope will not progress to cancer. So it's these things that are really important, and I think it's so important for us as healthcare professionals to be in the forefront to tackle the misinformation, disinformation that is out there. And Faye mentioned that racism is a determinant of health. I always say that health literacy is a determinant of health. It is the difference between life and death. And the reason my platform even started was because of a misinformation that my aunt called me about. She had hypertension, high blood pressure. She had blood pressure tablets. And then she called me in the height of the pandemic, ecstatic. I was like, what? My blood pressure is normal. Oh, that's amazing. So I stopped taking my blood pressure tablets. That's why we need to talk about these things. So, yeah.
Wow. Thank you, Aziza. No, thank you. So, Owen, I mean, what sort of, things are you seeing in primary care? Like, what things are you hearing about misinformation, and how do you address that?
Yes, so hi everyone, I'm Owen. I'm a National Clinical Advisor for Macmillan Cancer Support and then a GP with specialist interest in oncology. In answer to your question, I'm seeing it increasingly actually, and not just in cancer but in everything. Yeah. And I think it's really thinking about where that's a theme that we've seen so much of it today in terms of that mistrust, and just understanding why people from sort of that trauma-informed background, where is that coming from? Even just this week, I had a patient who has much the similar story, just completely disengaged, stopped all of their medications, and saying, actually, I feel fine, so I'm all right. And it's very easy to sit there as a GP in your consultation room going, this is ridiculous, and this is what you need to do. We've got to think about it in a different way.
Yeah, I always say this, yeah.
And it has to be with true collaboration and understanding and bringing together minds rather than just authoritarian us just demanding on us.
And learning.
Absolutely.
Learning about people's different experiences. Yeah. I mean, Ashley, this is a great time to bring you in now, with the incredible work that you guys do, you and your mum at your incredible charity. Can you talk about some of the practical things that you guys are doing that's helping us address this? Yes, of course.
Hi everyone, my name's Ashley Neptune. I'm the co-founder and advocacy lead at From Me to You. We are a charity that aims to bridge the gap between the community, a cancer charity that aims to bridge the gap between the community and the healthcare system. And we do that via community advocacy, education and research. Now, one of the key ways, the reason why we actually set up initially was because my mum was given a terminal cancer diagnosis and was given less than a year to live. And what we found is that she faced a lot of barriers to access. And therefore we carved out our core pillars, community being because we didn't have one initially, definitely not a place where we could find answers that we needed. Advocacy, because when my mum didn't have a voice, I became her voice. When she was told that there were no clinical trials available, I went and did that research. Down to education, when it came to understanding how to navigate the system, these are all things that we had to learn. It wasn't something that was handed to us. So therefore, we went on to make sure that we created an organisation that we knew we needed when we were going through what we were.
Thank you. Amazing. And, I think this is a really good example of, very similar organisations, Black Women Rising, yours, and where we've set up these things because they're not being addressed, right? And we've had to go, actually, this is what we've gone through and gone, actually, we've had to set these things up ourselves,
Exactly that.
And I think Jamila's legacy is the same, right? Did I say that right, Rihanna? Rahana, yeah, thank you. What mental health dynamics intersect with cancer misinformation in racialized communities? And it'd be nice to hear a bit about your organisation as well.
Hello everyone, I'm Rahana Sidat, founder and chief exec of Jamila's Legacy. We're a non-profit community organisation based in Leicester, and we support and educate communities and organisations in mental health well-being. We set up Jamila's Legacy in memory of Jamila. She passed away about 15 years ago. She was only 35 years old. She was South Asian. She developed postnatal depression after her second child. Unfortunately, her husband didn't understand that she was having mental health problems and basically ended the marriage, and she was not allowed to see her 2 children ever again. That resulted in her developing severe mental illness over many, many years. She was somebody who was known to the community, but because of the stigma around mental health and people not knowing what to do, they just basically labelled her as the woman who talked to herself, the mad girl who stood in the street. Even her own family didn't support her. She didn't even have a GP when she passed away, because she was trying to communicate to the receptionist that she really needed to see the doctor, which resulted in an argument, and it was all zero tolerance. We strike you off the register, you've been abusive to our staff. She was so unwell, she was unable to get another GP, and sadly, eventually she passed away because she was just so unwell to take care of herself. And I got the call, because I'm also founder of another charity for adults with learning disabilities and carers, to say that, Rahana, can you come over to the hospital? We need some interpreting. Our daughter's really unwell and we don't know what's going on. So for me, it was a big shock, because I knew this family and I'd supported others, and yet I didn't support Jamila because I didn't know she wasn't getting the help. And it hit me really hard, because I thought I could have done something. Had I maybe been a bit more nosy, maybe asked a few more questions. And I thought, we've got too much stigma, we need to address this stigma. And if our people are needing help, where is that help? What does that help look like? What does it need to look like? Where are the gaps, etc.? So I started this 10 years ago, and the work is very much what everybody in this room is doing. It's about basically us putting it in the forefront that these people are not being heard, these people are not getting the services that they need. Inequity, inequality needs to be addressed. We need to continue to voice that. We need to be advocates for others, but we also need to empower individuals to be self-advocates, because there's nothing more powerful than the individual speaking up for themselves.
They're very true, yeah. Thank you. Thank you so much. And I wish we had more time, but I have got a closing question to ask all of you, actually. I'm actually really keen to learn about this as well. What misinformation themes are you guys seeing a lot more, but are most harmful right now in cancer prevention and treatment? I have many, but I'm going to leave it to you guys to answer.
Do you want me to start?
Please, start.
And I'm sorry I didn't say much about the misinformation when you asked me earlier.
It's okay.
I think we live in a world now where news travels very fast. We know from the examples of COVID, and everybody has access to mobile phones, and whether that's your elderly grandmother in her 90s who's getting WhatsApp messages and videos. I had a client come into our neighbourhood mental health cafe in her 50s, and she said to me, did you know that GPs are going to start charging to see us? I said, what do you mean?
Oh my God,
she said, no, I saw it on TikTok.
Yeah.
Yeah. So that misinformation now, because they don't know what's fact and not fact, that's a new challenge we have now.
Yeah.
But then we have what we used to call old wives' tales, which continue. So nobody wants to have the conversations about cancer, because cancer means death. Yeah. They're not aware that there's so much out there now, and people can live longer and can be cancer-free. So we have a lot of work to do, and it needs to start right from the bottom, and that's where trust can be built, but it's not going to happen overnight. It takes work, like Keith said this morning. Trust takes time to build, and it can be broken within seconds. So we've got a lot of work to do.
True, true. Anyone else?
Right, so like what I discussed before in regards to misinformation and good information is needed. What we do in Indonesia at the moment is building the community. So healthcare professional is trying to work with community. In Indonesia, we had what we call local kader. That's actually the community health volunteers that working to provide social and health support for their community. So what we are doing at the moment is really to get in touch with them, educate them, and using various and innovative way of learning, because as a volunteer, community health volunteer, you cannot ask them to sit for many hours, 7 hours to listen to classes. So we're trying to set up more educational program, but only in short period of time, maximum of 3 hours, and having a discussion and talk to them. So we're trying to work with the community to sort of tackle all misinformation in the community themselves.
But what misinformation are you hearing? Because this is the real question, because when I'm working with our women, these are the things, you know, I'm 9 years on from my cancer journey, right? But I'm still hearing the same things regardless of what we're showing out online. And I'm hearing that black people don't get cancer.
Yeah.
I'm hearing that, you know, cancer means death. I'm hearing that chemo drugs are not meant for black people. So what other things? Are you guys hearing this? What themes are so hurtful right now and we're still hearing?
Absolutely. No, there's so many themes. And I think what's really scary is, just like you were saying, social media is accessible to everyone and anyone. And the thing is, one person hears it and it spreads like wildfire through WhatsApp. You know, they all make the jokes about the WhatsApp aunties and so on. But the information started, like you say, oh, it doesn't happen to within our community, or, you know, you should just pray yourself away, or you should take these supplements, because it's always supplements that's going to cure any condition, which is really, it's getting really tough out there. And depending on the community leaders again, sometimes they can be great, but sometimes they can actually be the detriment. And the reason that people are not coming forward for the treatment and the medication. We have loads of patient advocates, and I think it's great that people are there and sharing their story, but the problem is that you have individuals, often people will always share the most negative experience. So if we talk, for instance, about cervical screening, I'm such a big advocate for cervical cancer prevention, and hopefully, yes, it will be eradicated one day, but there's still loads of people who say things like, you know, the tip of the swab that they use, the swab stick that they use has chemicals in it, which means that when they're doing the screening, they're giving you cancer. So then people don't come forward, or, oh my God, it's the most traumatizing and most painful procedure in the world, so they don't come forward about it. And this is where us, again, because even within my profession, there's still people who put their noses, like they look down on you for being on social media and sharing things on social media. But here is a stat, okay, and this is factual. If I were to ask you guys, and you just shout it out, how many views on health conditions were on YouTube in a year in the UK in 2024? How many views would you say? Huh? 1 billion? Okay. Any other takers? You said billion. Oh, billion. Okay. How did you know? Okay, so you were supposed to say billion. Yes. No, but it's not 7.4 billion. I think it's about 6.8 billion, which is basically the same. But basically that. Sorry? That was really close. That's why you should play the lottery today. If you were guessing that. But if you knew that, that's fine. So 6.8 billion views in the UK on YouTube alone, the one platform, in 1 year, in one country. People are accessing social media for their healthcare information. Not many people go to NHS UK or Cancer Research UK or all these other places, which actually do have the reputable information. And this is where us as healthcare professionals, being on these sites and using, you know, I have many props, and I brought this other one. So this, you guys know what this is. Boobies or breasts with a smiley face. Don't forget to look underneath. No, and again, my props, the reason that they're always brown is for representation, because there's so many people who are excluded, and until you have been excluded, you will not even realize that that certain groups are excluded. So yes, many black women don't believe that you can get breast cancer, because if you look at, I mean, thank God for people like Leanne and all the other groups that are doing the work to ensure that there's representation, but finally you are seeing black women or South Asian women on pamphlets of breast cancer. So now you know, oh, it can happen to me, because there's so many who get the diagnosis and say, nah, this doesn't happen to black women, it's a white woman disease. So this is where it's important, again, that we share this sort of information and make sure that it's inclusive and representative. And also, what I have found personally is being relatable and fun. means more people will access and take in the information. I'm not the smartest person in the room, but I share things in a way that's accessible, fun, engaging, and easy to understand. And that makes the difference, I found.
I think you're right. Yeah, it's so true. Yeah. Ashley, what are you seeing now?
Do you know what? It's all being said. I mean, look,
Yeah.
supplements. I've had an advocacy one-to-one not too long ago, and someone said to me, "Oh, well, actually, I was told I'm going to go to church, and it's fine, and that God will deal with this." I'm a Christian myself. However, I also am a believer that God helps those who helps themselves. And I think if you're from the Caribbean, you've probably heard of soursop, that I've been taking all my soursop and, I'm sure that will be fine.
Yeah.
I think what we have to look at here is how we address these things in the community, because what I found, the consistent themes when I am speaking to the community is like, okay, someone hears that, okay, I prefer to do this way. This is the way to do it. Now, we have members of our community that are completely towards that holistic approach that can be sometimes stemmed in misinformation, but it's about what else you bring to the table to complement that and say, okay, that's your belief, but have you heard of XXX? I'll give you an example. We had a breast cancer webinar last month, and we had a lot of people in that webinar that usually would traditionally have just excluded anything from the medical framework. We had Dr. Ayadeli come in, and she actually spoke to people, and women actually who traditionally said, I will not engage with that, actively are asking questions and exploring what this framework looks like and what an integrative approach looks like. Now, I'm not saying that's not the ideal response that you want, but at least you're acknowledging what their differences are and giving them a culturally aligned response and a safe space that they can have and navigate these conversations.
Yeah, exactly. Yeah.
Yeah, I was going to flip it slightly in terms of thinking, actually, probably the biggest issue for thinking more widely is actually who's not in my consultation room. And actually, the misinformation is actually that we don't care. And actually, we are all in this profession because we do care.
Yeah, true.
And thinking about actually, why are people not coming through our doors and having those conversations? Certainly within Macmillan, we're using a cancer champion program where we're using local anchor institutions where people are working within those communities, not based within clinics, based outside in communities where people actually work and live. And I think that's the biggest challenge now, is to be thinking about who's not there and how can we break down those barriers and recognise to say we are all working together on the same thing.
Yeah, agreed. Thank you. Thanks so much. I don't know if we've got time for questions, Doctor? Yeah. Okay. Anybody got any questions for our incredible panel?
Thank you, everyone. I think Ashley touched on this a little bit. So I have a brother who was a follower of, well, probably still is, a follower of Dr. Sebi and Yaki Awakened, if you know them. And he done an alkaline diet to the extent that he ended up in ICU. And earlier we had a conversation about Ayurvedic medicine and how that was aligned. So has anyone looked at an approach where you can kind of complement them? So the best way my director explained it to me is sometimes what they're doing is symptom control. And have we looked at trying to educate from that perspective and then speaking about how we can then integrate medicine for a cure per se? You mentioned that these conversations keep on going. I wonder if we start to have these types of conversations, maybe we would then be able to tackle that angle of misinformation.
That's a good question.
Yeah.
Yeah.
100%, and to be fair, that is what I was leaning towards. I think it's really, really important to open up the conversation of how things can complement that. So if someone isn't, and look, I've had that instance on so many occasions, if someone is choosing not to engage or has chosen previously not to engage, when we have doctors come in and they discuss, these are the treatments that, that you can have if you do have a certain diagnosis, these are the things that you can do. At no point do we ever disregard that person and say, stop taking the soursop, stop the supplements. Because ultimately, if I'm being honest, from a community perspective, that's the reason why they can sometimes stop even disengaging with the healthcare system anyway. You know, you have to create that environment like, okay, I understand, but there's also access to this information and do as you wish. And what we really aim to do, is what we're continuing to do at From Me to You, is to make sure that we have medical professionals come in and consistently have those conversations and consistently make them aware of what is available. And then on top of that, we feed into our advocacy framework where we have our one-to-ones, and we're like, okay, you have your soursop, you have your supplements, let's look at what you're going through, let's look at how we can help you engage with the system and what stops you getting there in the first place. Hopefully that answers that. Apologies.
I just want to add, I love that. It's so true. And I think this, again, is where cultural competency training for healthcare professionals
100%.
and staff is really important, so that we don't dismiss and we don't disregard, and also we work collaboratively with the patient, just like Owen mentioned. The second thing I want to say is in terms of having the time to have the conversation. So I'm going to share a really quick story because it's funny, and this actually happened to me. A patient came in with her daughter. She didn't speak English. She's a South Asian lady, and she needed to be on statins. And you know, even before we started the conversation, her daughter was just like, she's not going to take it. Don't even bother. So I said, it's fine. Let me explain. And I explained to her. And then after I was done with everything, and when she was about to leave, she told her daughter, I want the medication. And her daughter was like, what? Like literally, because her daughter was about to say, we don't want it. And she's like, no, I want it. And it's because, and I wish we had, I'm always running late, but I wish we had the time to have those conversations. And there are loads of instances, and I've seen it, where patients, they're taking their medication, but they're not taking their medication because it's just being prescribed. And part of the reason why they're not taking it is because they don't understand, again, health literacy education. And really quickly, just because someone mentioned this so many times today, education from schools. We can talk about this in schools. I went to a school a few weeks ago, and I spoke to year 10 to 13. They believed me when I said I was 25. Oh, wait, why are you laughing? I am 25. 2 years ago, plus 10. And then another one. Okay, so basically, we spoke about, I told them the numbers about gynecological cancer. And even before I said the numbers, they were on my presentation slide. They were like, 22,000 a year is newly diagnosed, 60 a day, 21 a day are dying? They were shocked. And then the realization that there are 5 main gynecological cancers, but they weren't scared. They were very curious, alert, aware, and just wanted to know more. We can start from that age. They were between the ages of 15 to 17, and they took it in. And there was no shame, no embarrassment. And we talk about the reason I'm not just obsessed with the words vulva, vagina, clitoris, and also singing them. It's because I have, loads of stories. I had a patient earlier this year who came to see me with a massive vulval lump. Huge. So she would have had this for a while. The only reason she came in was because she was in agonizing pain. Otherwise, she wouldn't have come in. I knew it was vulval cancer as soon as I saw it. Got diagnosed stage 4 vulval cancer. That could have been different if there was no shame, stigma, and embarrassment associated. So keep singing the song. Make it Christmas #1.
You should have done a performance for us today to close the conference.
All right, go on, let's go. You guys ready? 1, 2, 3, let's go. Vagina, vulva, clitoris. Rewind it. Hey, vagina, vulva, clitoris. Rewind it. It's on Spotify, YouTube.
Wow. Look, it's amazing, and I know I have to wrap up because we've got to move on to the next panel, but thank you so much. I think that was brilliant, and I think we need to give them a massive round of applause. Thanks, guys.
Sorry, we've got one more question. If that's okay.
Sure.
Hi there. Sorry, I feel bad taking
got one more
airtime
question.
away from the Vagina Vulva Clitoris song, but I just wanted to ask, and I hate to be the person that says, what about AI? But with kind of misinformation and, we've seen how social media can do so much good, but also so much damage. and with kind of generative AI and kind of deep fakes and things getting kind of really convincing to not know what's true and not, how do you navigate that in terms of how can you get in front of it, or how do we help people navigate between what's true and what isn't when it's really convincing when something isn't these days?
Yeah, well, I guess in my case in Indonesia, what I learned about our project in Communicated, working with local community, is that sometimes they can think different way, like much different. Like after our training program regarding metastatic breast cancer, one of our cadre came up and she said, "No, I am more happy become a local cadre because then I know metastatic breast cancer is not communicable disease." And then we were shocked, like at the beginning she doesn't really know what breast cancer is and those kind of, thinking that out of the box. So after that we learned to listen to, their stories and to really not assume that they already know. Maybe they don't know nothing, maybe they know nothing. So then, starting with a discussion and listen to them. That's what I learned about working with local community.
Can I just say something very quickly about generative AI? I cannot differentiate it. We have a tsunami coming because it does look really real. We now have AI authors, AI singers, AI everything. Yeah. So I think this is why going to the community really matters. We need to face-to-face talk with people and not just allow them to rely on what they watch on TV or on the phones. Because right now, I can tell you, sometimes I don't know what's real anymore. It's very difficult. So I think that's another thing we have to think about in the future. But just going on what Aziza said, if we start from the school when they're young, then they already know what is right. So I think it will take away a lot of that problem if we're teaching them early.
Just wanted to add from what you said as well, it's about getting ahead of it. And I think we're already, as ethnic minority communities, on the back foot of everything. So things like digital literacy, health literacy, all of this. So it's going back into communities as well as schools and educating and equipping people so they feel confident. Is this a reliable source? They don't feel ashamed to actually have a conversation with somebody. Rohana, is this right? I read this today. Is this an official page? It's okay. It's great. We've got people like yourselves on because that is becoming a more reliable source for people now. They are looking at the Dr. Nigar Arifs and the Dr. Khans and the Dr. whoever because they know these people, but because there can be fakes, as you all said, they need to watch out for that as well because they'll say, well, so-and-so said this, but actually it was a deep fake, but we didn't know. So we need to be educated. Exactly. And that means taking the most vulnerable with us on that journey.
But this is where the government needs to get involved and sort something out, like before it goes crazy. Like people should get penalized, and there should be big repercussions for making deep fakes and those sort of things. So that because these doctors, I haven't had one yet, thank God. Hopefully not anytime soon. But there are loads of credible doctors who have deep fakes made of them, sadly, selling supplements again.
Thank you, guys. Thank you so much. Thank you. Thanks so much, guys. Okay. I know time is... oh, gosh, no, it keeps happening. Right, guys, so we're going to move swiftly on to our lived experiences panel. And we've got 4 patients with lived experience that are going to explain their own stories. So can I invite on the stage Louise McKenna-Mays, Sophia Sewell, Toral Shah, and Yinka Sawimmo Koka. Hi. Hello. How are you? Hello. Oh, there's only 2. Sophia? Where's Sophia? Oh, Sophia isn't here. What about Yinka? Oh, hi, Yinka. Okay, we're just going to go straight to you then, Toral. You're the first one on my list.
Hello.
Off you go.
So, am I just sharing my story? Or am I going to do?
Yeah, I'm going to ask
whole-
you the question
okay,
afterwards.
Sure. I'm Toro. I actually come with two hats on. So I have lived experience of breast cancer, but I also have had cancer be the center of my professional life, my whole life. When I was 11 years old, I read a book about cancer, and I was like, right, I'm going to cure cancer, because I was precocious and had no idea how the world worked. And then went to medical school, left medicine, and then did a master's in nutritional medicine and worked in research. So that's kind of me. But I have had breast cancer 3 times, and I don't have metastatic breast cancer, but I do live with cancer in the way that I have to be I've got very high risk of reoccurrence. So for me, this work's very important because I'm a passionate advocate for our marginalized communities, whether they're ethnic minorities or those with disabilities of other sorts, or low socioeconomic groups, and how education and awareness is so, so important. And I know that's a theme that keeps coming back through today.
Thank you, Toro. Thank you so much. Okay, Louise.
Hello, thank you, Leanne. Hi, so my name is Louise McKenna-Mays, and so I'm also wear 2 hats. I'm a patient with lived experience of breast cancer. And then what I actually did in terms of what happened to me is then I set about co-founding a social enterprise to address the injustice which I faced, which was essentially when I went through making a decision about what type of reconstruction I was going to have as part of my mastectomy. I had no access to images to help me make an informed decision. And then fast forward a few months, I kind of sat there and thought, what could I do with my lived and work experience in order to help address this issue? Co-founded Tony, Bob and Lou. And fast forward, we have now produced the UK's first resource, and it's a project called Brave. So I have a copy here, and we've been photographing for the last 2.5 years women who have been through a mastectomy. But what we found out essentially was that not only did this resource not exist within the UK, but there was no representation in terms of what women could have access to from an image point of view. And so there were no images online, and black people, Asian people, minority communities were not represented either. And so it's wonderful to be sat here today right next to Leanne Perrow, because it was actually Leanne's involvement in the Black Women Rising group that we contacted, because we couldn't get anyone to come forward from minority backgrounds to come forward and be photographed. And so we asked Black Women Rising for their help. Yeah, and then that has essentially meant that the resource that I'm holding in my hand today, which there are other people within this room which have also been a key part of, have helped. And also Tony somewhere, my co-founder, is also here. There she is there. And she's the award-winning photographer who has created now the UK's largest bank of women who have been through a mastectomy, and all of our portraiture is done in a fine art portraiture style, so it's slightly different, but it's the combination of medical information and artistic imagery which helps create images so that women, along with their clinical team, can look at different types of reconstructions, and so they can help make an informed decision.
Amazing! Amazing piece of work. Amazing. Okay, Yinka, can hear your story, please.
Thank you. My name is Yinka Shoemimo Koka, and a pancreatic cancer survivor. That was in 2018, 2019, I was diagnosed. 2018, I was misdiagnosed. It was delay in my diagnosis, and at the end of the day, yes, I was diagnosed with cancer. And I went through, of course, the chemotherapy and also Whipple's surgery. Now, where I'm coming from is because what actually prompted this whole scenario of problems with cancer is the way a manner it went by. I had all the symptoms of pancreatic cancer, and yet I was not diagnosed with it. You know, if I had not gone to the second, if I had not gone for my second opinion, I might not have been alive today. But thank God for my husband who said, no, let's try somewhere else. And by the time I got there, I was told, one of the doctors said, oh, there's nothing they can really do for you. You've had pancreatic cancer for a long time and there's blah, 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 blah. Anyway, at the end of the day, I am thankful I am alive. And why going through all this, I thought, look, if I can go through all this, through isolation, loneliness, you know, I was actually sad in my spirit because I didn't know any other person who could help me, you know. And if I could go through all these things, I now realize that I will not be the only one going through this, but there are so many people in the community that will be going through this. And that was what prompted me to start a charity called D-Changer UK. We started D-Changer UK 2021, but actually started working 2022. And all the reason being that there are so many people in my community, the Black people, who do not want to come out to tell the world that they are sick. My background is a background whereby you just keep quiet. You just go along with it. You don't want to tell your family. There are some people who don't want to talk to their parents about it or their children about it. It's a lonesome journey, you know, and if you're not careful, you will die in it. And that is the reason why D-Changer came to play. Secondly, I'm a Christian, a faith lady in the church. People don't even want to talk about it because they believe that you're going to be stigmatized and it's like a taboo. How can a child of God have cancer? And of course, cancer is demonic. How can cancer be in a body that we think it's Christ lived, you know? And we need education in that area. And we from D-Changer and also other small charities are actually taking this beyond the community itself to the faith community. Pancreatic cancer is something that is, I mean, from here, since I've been here, it's just about breast cancer and colon cancer I've been hearing, you know. And pancreatic cancer is also becoming very rampant and also very deadly. I do not want people to just go ahead and just believe that, oh, pancreatic cancer is only for a very few people. If you have pain anywhere, please, please, please go and check it out. There is no shame in it. It could happen to a black, a young, a white, a green, whatever color you think you are. Just go and check. Just go and check it. You know. And for cancer, there is something called CAN in cancer. So there's a possibility that you can even still. You can make it, you know, I made it, you know, and a lot of people in this room also made it. So there is always something called CAN. And I believe there is life before cancer, and there is life during cancer, and there is also life after cancer. Yes. The issue is life after cancer could be here on earth, and it could be, thank you. Life after cancer could be here on earth, or it could be eternity, whichever way it falls. Just be ready and take it. We will all die one day. Anyway, God bless you. Thank you.
Just wonderful testimonies, and also all three of you doing absolutely incredible work across the board. So I've got a targeted question for each of you, and then I guess we can open up. But Toril, I know your work really well and all the incredible things that you do for your community and beyond. You know, you've also helped Black Women Rising so much in our early days as well. But as a person with lived experience, what's the deepest inequality you've faced along this journey of your multiple cancer diagnoses?
And I think, thank you for that question. And so I have to set the context for this, and I didn't do a very good job of really showing the context. So I come from a family which is actually atypical for South Asians. So I didn't have any of the risk factors that even younger women might have for breast cancer. I wasn't overweight. I mean, you know, at that time, I was very lean. I was doing loads of exercise. I've never smoked. I ate a healthy diet. My family were very body comfortable. So, we talked about our bodies. We talked about our health. We all did exercise as a family. You know, all of those things. And my mother was diagnosed with breast cancer 7 years before me, and then my mum's sister was diagnosed with breast cancer maybe, I think 2 years before I was. And my mum was still in that younger age group. She was 49, and so, you know, premenopausal. And I think I had all that information. I also had been to medical school. I was very body aware, and I was already doing my master's in nutritional medicine, so I was very aware of cancer. Yet, when I found a lump, I showed my mum, and my mum believed me straight away. And there was no question. She was very supportive. But then when I went to the GP, my family GP was basically like, look, there's a new female GP starting next week. Is it okay if you show her? And I understood that because he was a very close family friend, and fine. But the new female GP hadn't really looked at our family records, that my mum had breast cancer and that my mum's sister had breast cancer, and we had some family history with multiple of my mum's sister, aunts and cousins having breast cancer. And so rather than doing urgent referral, because I had a very clear lump, she actually just ignored me and just didn't do anything. And the only reason I was actually seen in the end, because my mum worked in the NHS and somehow managed to get me seen she worked in the radiology team. So she actually ended up having, organising a kind of mammogram ultrasound, and then I ended up having a biopsy. But that wasn't because of I went through the system. It's because we managed to circumnavigate the system, and that's only because we're educated and we have privileges that I was able to do that. Fast forward 12 and a half years, and I can't describe this any other than my mastectomy scar felt odd. There's nothing else I can say, and I've talked about this with multiple people who felt it, and I kind of went back to my hospital and at that point, again, it took something to be diagnosed, because despite already having family history and being treated at that hospital, which specializes in younger women, and so but that wasn't so bad actually in the end, because I just, again, rather than going through the system, I knew my secretary of my consultants, and I just went direct to her, and that was I'm a known entity there. But then the third time, when I was diagnosed in that summer of the first year of the pandemic, I went through kind of the open access route. I rang 17 times. I'm a known patient who's had breast cancer twice, and I'm younger, and I had severe pain. And so for me, that was problematic, because I'm knowledgeable, I know how to use the system, I have all my friends are doctors, I know my consultant, and in the end, again, I did the same thing. I ended up just calling my consultant's private secretary and saying, listen, I can't get hold of it, and this is ridiculous. And that shouldn't be happening. So the reason I really get passionate about this work is I have a voice. I also know how to advocate for myself and others. I also have the scientific and medical knowledge. So many people don't. And I want to bring up health literacy, which everybody has brought up, and no one's actually explained it. So health literacy is how much people understand. In the UK, 24% of the population have the health literacy of a 9-year-old, meaning they only understand what a 9-year-old can. And if you think about if you have children or you have no children, a 9-year-old doesn't understand that much. And so we have to remember that we have to make this information understandable for it. It's not even about whether it's the English, their first language, it's just about whatever language it is. People don't have that understanding. And so for me, because I faced this inequity, and then when I was diagnosed the third time, I just will add this, when I was being consented, I had several questions. The registrar who was consenting me was a young white woman who would not listen to me, and I ended up crying, because I was just like, I have these questions and I want to understand a little bit more about the detail of the surgery before I have this surgery. And the door happened to be open, and my own consultant walked past, and he was like, what's happening? And then I got the answers, but that shouldn't have happened. And then I had to make an official complaint in the middle of a pandemic, 3 weeks after having DX surgery, and that's not acceptable.
It's a lot that we have to deal with and navigate, and even for someone who is informed like yourself.
So think about the people who are not informed.
Reminding me of Jen, because this is what she had to go through.
And the
in the
amount of phone
pandemic.
calls we all had with Jen, right?
Yeah, and that was someone who passed away.
A good friend of ours,
Yeah. Thank you, Toril. Thank you so much for sharing. Louise, what was missing from your cancer pathway? And, obviously you spoke about it a little bit before, but how did that influence this incredible project? Can I see this, by the way, because it looks amazing.
Absolutely.
First time having this in my hand.
So what was missing? Well, access to images to help me make an informed decision, as clear as that. And it was actually my medical team. I asked them consistently, so over and over again. I'd had 2 lumpectomies, in the October and November, then 6 months of chemotherapy. I knew throughout my chemotherapy I needed to have a mastectomy at the end of it, and so several times, several occasions, I would ask every time, can I see some images of the different types of surgery that I can have? And so essentially what I then ended up doing is both of my surgeons who did not have access to images, that they could show me which would not traumatize me, which is the key point. They didn't have images that they wanted to show me. I asked them to come on board with a project, and so they actually sit in the middle of this book, and they have helped us and been pivotal in designing and developing these resources over the past 2.5 years.
It's absolutely incredible.
And so, you know, in direct answer to your question, we decided, Tony and I, to do something about the injustice that I faced, and then realised that it wasn't just a UK issue, it's actually a global systemic issue. Nothing like this exists within the UK, nothing like this exists within the world as we know it.
Thank you, thank you, thank you, thank you. It's absolutely incredible. Amazing. Yinka, what one change would have made the biggest difference to your cancer pathway? Your care pathway, sorry.
For me, I think I needed, as at that time, I wanted empathy. Somebody to go along with me. I don't want them to talk to me. I don't want to talk back at me. I want them to listen, understand where I am coming from. I am the owner of my body. I understand my body. If I'm telling you there is something wrong somewhere, I want you to believe what I'm saying, not to discard me and say, no, you are not. You might be a doctor, but you don't have the experience. I'm telling you the way I'm feeling, and you're telling me, no, it cannot be this, it cannot be that. Okay, I've given you, you've given yourself the privilege to tell me what it is, and yet you cannot diagnose what is wrong with me. So what about if I had not gone into hospital for my second opinion? What if the doctor at the end of the day will have thought, oh, it's one of them? I don't want to become a statistics. I want to live. I want people to know that you can make a journey out of cancer. Thank you.
Thank you. And I think we've got a couple of minutes just for any questions to this wonderful panel as well. Anyone? No one? Well, let's give them a massive round of applause. Thank you so much, ladies. Honestly, thank you so much. And thank you guys for listening as well. It's been an absolute honor just to moderate this, and it's making me wish I was here for the rest of the day listening to some of these conversations. But thank you so much, and I hope everybody's enjoyed those. Thank you.
Oh my God, that was so moving. When I thought about bringing in lived experience, I didn't realize how much emotional it was going to get. But I think it's really vital that we hear from people who have experienced this, because like Yinka said, they know their bodies more than us. You know, we might be doctors, we might feel we have knowledge, but we don't know their bodies, and we need to listen more and communicate better. So we are coming towards the end, but before we end, we have our keynote. There's a second keynote, a closing keynote. And Lacey Hubbard, who is someone I mentioned that I admire big time, is going to talk about the future of cancer equity. So Lacey Hubbard is the founding president and CEO of Elector Foundation. So don't mistake it with the Elector that does radiotherapy machines, because I think people make that mistake. It's not the same. It's a Swedish NGO expanding access to cancer care in underserved countries. Since 2022, she has championed scalable, sustainable models with the Rwanda Ministry of Health, screening over 300 225,000 women through the FAST model for cervical cancer elimination, as well as introducing dual screening for breast cancer. She's also launched a community-based palliative care program, including One Egg a Day initiative, ensuring no patient is left behind. The foundation, now a lead implementer for the World Health Organization, has been recognized by global health leaders and featured in the U.S. Cancer Moonshot Initiative. Lacey Hubbard.
Well, thank you. So glad to be here today. I think after a day filled with dialogues, insights, and personal stories, I think many of us feel the same, inspired by what's possible, and yet aware how far we still have to go. Cancer is a very complex challenge, so no one can tackle it all. So today, I will speak from what I know the best: cervical cancer screening and prevention. No slides from me, so I just want to speak directly from what I'm seeing on the ground. But the principles behind our work are universal. They can apply to other cancers, other countries, and other contexts. I'm Lacey Hubbard, president of Ilata Foundation. As Boogie was saying, we are a Swedish foundation dedicated to improving access to cancer care in underserved countries. We believe where you live should not determine how long or how well you live. Too often, women living in poverty don't seek medical care until it's too late. So by focusing on women's cancer, we aim to change that, because saving women means saving their children and their families. Over the past 3 years, we've been working in Rwanda to develop a screening model that is scalable, sustainable, and adaptable in low-resource settings. Over the past 3 years, we've been working in Rwanda to develop this model. And now, you might wonder, why cervical cancer? Why Rwanda? Here's a fact that still shocks me every time I say it. Every 2 minutes, a woman dies from cervical cancer. But here's the thing, they don't have to. Cervical cancer is highly preventable and treatable. We know the cause, human papillomavirus or HPV, and we have the tools. Vaccination to prevent it, screening to detect precancerous lesion and treat it early. And that is why the World Health Organization, WHO, set a global target to eliminate cervical cancer by 2030. This is no longer about science, it's about access and equity. And we choose to work in Rwanda because they have vaccinated over 90% younger girls against HPV. Their Minister of Health asked us to help them reach the 70% screening target for adult women, these mamas. So together with the partners and experts, we developed what we call the FAST model. FAST stands for fast HPV testing, affordable cost, systematic tracking, and a timely diagnosis and treatment. Through this model, we now have screened over 370,000 women and treated over 8,000 with precancerous lesion, preventing thousands of future cancer cases. Building on this success, earlier this year, Rwanda launched Mission 2027, a bold national movement to reach the WHO's cervical cancer elimination 3 years ahead of time. So they will become the first African country to achieve that milestone. You might think we are a seasoned foundation with decades expertise. The truth is, we're not. The Ilata Foundation even not over 4 years old. And for me, after working in years in radiotherapy industry, I know a little bit about cancer treatment, but screening and the treatment were very new to me. So when I first learned about the WHO's 2030 targets, I had to admit, I was skeptical. The scale of the screening need is alone just overwhelming. Like for Rwanda, a small country, over 1.2 million women need to be screened. It just felt like a mission impossible. Yet today, after we successfully screened over 370,000 women, I'm not just hopeful, I'm convinced. I believe we can eliminate cervical cancer, not someday, but in our lifetime. Looking back, there are many things we have learned, but I want to highlight 3 that have truly shaped our journey. First, be ambitious, set the bar high. So let me share a story from the early days of our program. So I was looking for a clear KPI, something simple, like a daily throughput. I asked this expert in the field, and after he was hearing we're doing screening in Africa, then he said, if you can do 200 a day, you should be happy. If you somehow can reach 250, you should be really, really proud of yourself. I must have looked unimpressed because he repeated. So instead of aiming for 250, we decided to double it, just to see what's possible. We even did not know if it even made sense. We just want to understand what is our true capacity. Our local partners, they are great because together with the local community health workers, they brought 500 women a day, sometimes 700, even 900. Great, right? Not really. Our lab couldn't keep up. So then you see the samples just piled up, the lab technicians working day and nights and weekends, but still couldn't catch up. Then the worst nightmare happened, contamination in the lab. Not once, but 3 times a week. I panicked. I called the CEO of the HPV kit supplier, and I said, you need to send someone to Rwanda now. And he did. The findings surprised all of us. The cause is not because the lab, the machine, or all the complicated technical stuff we are thinking. It's simply these sample disposals need to be sealed. Solution? Ziploc bags. Easy, right? Well, not in Rwanda. If you've ever been there, you would know what I'm talking about. Finding Ziploc bags is harder than spotting unicorn, thanks to their strong environmental law. So I went to Walmart, bought a 600 bag. When I passed through customs, I prayed these bags were not confiscated. And I was lucky, these bags made it to the lab, and sure enough, contamination stopped. So after that, we had a much better understanding of the situation. We knew our local partners can mobilize women, a lot of women. We just need to find a HPV testing solution that works better in the low resource settings and with much higher throughput. And then we found a Swedish partners willing to work with us. Together, we faced many obstacles, technicals, logisticals, and operationals. And together, we tackled one by one. And the result is amazing. So today, our lab can process 2,400 samples a day. And with that capacity, we can screen 50 to 60,000 women in just 3 to 4 months. So this experience taught us a valuable lesson. Aim for the stars, you might just land on the moon. Second, be innovative. So innovation is the core of our work. In our programs, we introduced many new technologies, such as high-throughput HPV, mobile colposcopy device, and we also implement many workflows to make the program more efficient. But innovation is beyond technology and efficiency. Sometimes it's about humanity. The one that I'm most proud of is our One Egg a Day program. As you know, nutrition is very important during the cancer treatment. But unfortunately, many village women live on diet of beans and potatoes. So to help these women, we introduced the Egg Project, providing eggs for nutrition, but more importantly, for social cohesion. As some speakers said earlier, same thing in Africa. Women living cancer are not only fighting cancer, they also have to deal with stigma and social isolations from their families, their neighbors, and their friends. Because some of them, like earlier somebody was saying, they think cancer means death or cancer is contagious. Then others think evil spirit causes it. I even heard this woman said she knew exactly why she got cancer, because during genocide, she had to hide under dead body for 3 days, and that blood get onto her body and cause the cancer. That's their belief. So I still remember vividly about this woman, Claire. She told me that she had to hide her medicine in porridge, so her family won't find out she has cancer. She was scared her husband would abandon her. So imagine she's alone at home and in pain. Then a nurse or community health worker knocks the door with eggs in hand. Instead of talk about this depressing topics about her cancer, they sit down and talk about eggs, such as, hey, how do you like eggs to be cooked? Do you like boiled, fried? Do you like omelets? And that moment, that woman feels seen, heard, and loved. As you can see, equity is not only about access, it is also about empathy. Third, be systematic. Build a system that lasts. So in Rwanda, we didn't just implement a screening program, we help strengthen a system. For example, we invested heavily in local capacity buildings through a task-shifting approach. There are severe shortage of doctors in Africa. Many primary health facilities only have nurses and midwives. So we train them there to conduct screening and the pre-cancerous lesion treatment. So this way, these women can just walk to their local health centers to get screened instead of have to travel to the big cities. And we knew that gonna happen. And we also use real-time data to advocate. The statistics can clearly show the Minister of Health how screening prevention reduces cancer cases, why prevention is far more cost-efficient than treatment, and how these insights can guide their national cancer control strategies. So with that, Rwanda not only is now focusing on screening and prevention, they are building a cancer treatment capacities from surgery, chemotherapies, and radiotherapy. The country is building a strong and a comprehensive cancer system. And that is kind of the sustainability we really like to see. So together, these three principles, ambition, innovation, and a systematic approach, has guided our journey and turned vision into reality. What excites me the most is that these solutions aren't secondhand. Rather than simply copying and pasting, the team leveraged best practices to create an even better solution that works for the country. And that's exactly what the future of a cancer equity requires. We are very proud of what we have achieved, but cervical cancer is just such a small part and in compared to the overall cancer burden. There are many cancers we must address. And that the urgency is real. By 2040, we will see 25% more cancer cases globally. And without action, the gap in cancer care will only widen in low-resource countries. That is why we must act now, and act fast. Our elected foundation may be young and small, but if we can achieve that much in Rwanda, just imagine what all of you with a far greater experience, resources, influence can achieve. So let's work together. Let's work harder. Let's create a future where everyone has access to the cancer care they deserve. Thank you.
Amazing, amazing. Any questions for Lacey? No? I have one question. And the question is, what urgent actions should global partnership prioritize over the next 5 years?
Global partnership, wow, there are a lot of them.
One or two?
Let me name 3.
Okay.
So I think the first one, really focus on the prevention, screening, prevention, the early detection. Because we all know cancer will have the patient has much chance to survive if you are detected early. And really, a lot of cancers you have mastered to have a prevention. So I see that has the fastest impact to do that, right? The second, I think the partners should really focus on the sustainability. Not just the program, just you really ask yourself, if you leave this country or leave the area you work, is this system is still gonna work? Or after you're gone, and then just kind of everybody going back to normal, and that unnormal, right? So that's what I see. The third thing, I feel all the partners should really have a genuine coordination. Let's sit down together to learn about each other, learn about each other's objectives. Let me give you an example. So we work in Rwanda doing cervical cancer. I talk about a lot of cervical cancer screening. We actually doing 2-in-1. We also screen the breast cancer. When we first started, we do the cervical cancer, and then funding is the issue, right? We want to screen that many women, and we don't have enough money. Then I learned that this PIH, partners in, how do I say that? Anyway, they are the large one in Boston. They're doing breast cancer screening. So we talked about it to working together, because together we mobilize the same women, we're training the same nurses and midwives. If we combine together and this cost come down, and then we can do more. So that's what I see is all the partners should really working together. There's a way can meet your objective and my objective, and then let's doing together and our objective. And that's what my view. I have other more.
Thank you. Thank you so much, Lacey.
Thank you.
Can I just mention very quickly, I know that it's been a really packed day, and a lot of people have not had a chance to do a lot of networking. So after the meeting, we're going to move to a smaller room for a bit of evening drinks. So I'm just going to leave it as that. But please don't run away. I know everyone is tired, but please, there is some more ways where we can network in the other room, okay? It's my pleasure to invite no one other than Susie Stanway. I think everybody knows Susie. I don't know how to and where to start to introduce you, Susie, but she's going to give us an overview of London Global Cancer Week of 2025.
Thank you ever so much, Vicky. So firstly, thank you for putting together such a fabulous day and convening us all. It's really been quite stellar. So London Global Cancer Week really came about because we felt that there was a gap that needed to be plugged, and we wanted to have a series of meetings that really span the cancer continuum, that convened people in person and virtually, acknowledging that it's not possible for everybody to travel. We want to be inclusive. It's difficult financially for people to get visas to come. So that's why most of our meetings are virtual. We wanted to have space for holistic discussions, to encourage coherence in policy making. We wanted this to be multidisciplinary because we need to have everybody at the table. Addressing cancer needs an all-of-society approach, an all-of-government approach, an all-of-sustainable development goals approach. We want to make sure that as well as addressing the cancer continuum from prevention to diagnostics, treatment and all its multimodalities, palliative care, living with and beyond cancer, that we address the existential challenges that are currently facing the world, from conflict, artificial intelligence, which is going to be turbocharged by quantum computing, Earth systems governance, climate change, and other issues such as pandemics, which we featured in historic London Global Cancer Weeks, and the effect that that's had and how that's exposed the fragilities in all of our health systems. So as well as addressing the continuum, those challenges, we also wanted to make sure that we address other interacting domains which play a hugely important part. So I think the raging inequalities and equities that we see around the world, which Buki has so amazingly brought together in this day, is so incredibly important. We want to address the economic challenges. So we have had an evening meeting this week on how global cancer care is going to be financed. We've held a high-level roundtable with international leaders, economists from the WHO, to look at not just what kind of novel financing mechanisms are probably going to be needed as we move forward, but also how that interacts with issues such as debt, corruption, waste. Are we spending money on the right things? Who's setting the agendas? Are they the right agendas? We also want to address demographics. We know that there are huge movements of populations, urbanizations, aging populations, and who's going to provide cancer care to refugee populations? We had a fantastic session provided by Aortic around cancer care in humanitarian settings in the Sahel earlier in the week. We didn't want the week to be just didactic. We've held roundtables, we've held in-person meetings, we've held suppers, we've held meetings in places of faith, because as people have alluded to today, that's also hugely important. We've had debates. And we also want to be a movement where there's action, where it's not just about listening to people talk and talk shops and then nothing happening. So we've had some fantastic outputs. We have had World Radiotherapy Awareness Day, which fabulous Katie Wakeham at the back has led with Sandra Turner, which now has engagement from 109 countries. This is aiming to increase access to radiotherapy, because we know that 200 million people around the world don't have access to radiotherapy currently. And this amazing campaign, which was launched this year on September the 7th, has now had 1/3 imprints on social media and the internet. So it's really, really raging ahead, which is fantastic. We've had Eduardo Cazap in Argentina, who has led LATAM Global Cancer Week along the same kind of lines that we've run London Global Cancer Week off, and we'd like to see that taking place in more geographical areas. And we've seen the global power of oncology nursing that Annie Young and colleagues have spearheaded. It's now a really, really very active WhatsApp group of nearly 400 cancer nurses from around the world. Their 2 sessions this week were absolutely stellar, featured over nurses and attendees from over 38 countries. So I think it would potentially be a little bit undiplomatic of me to talk about highlights of the week, but we started off with a fantastic session with one of China's largest cancer societies, the China Anti-Cancer Association, which was absolutely brilliant. We have had meetings around lived experience. One of them was spoken at by one of our ex-steering group members, who very candidly and bravely spoke about her journey with cancer, which was really incredible. We've heard from leaders in Kazakhstan about the incredible reduction in cancer mortality they've managed to make in Kazakhstan over the last 20 years. And we have heard from other issues that we don't often hear about, such as an academic group in Bath talking about how the tobacco industry influences the medical profession. So I'd really like to just thank Katie Wakeham, my co-convener. I'd like to thank the other 13 international multidisciplinary members of our steering group. I'd like to thank Bookie, who has decided and has said yes that she's going to co-convene with me next year to replace Katie, so thank you both so much. I'd like to thank our 3-strong management committee who, with their social media help, website input, have managed to make this week the success that it has been. I'd like to thank everybody that's come to our meetings. I'd like to thank everybody that's hosted our near 50 meetings this week, our supporters both financially and in other ways, and we would welcome ideas for meetings next year. Thank you all so much. Thank you.
I won't keep you for very long, not least because then you don't have to listen to my terrible voice. But it has been a very wonderful and very informative day, and I wanted to end with some final remarks. The theme of today has been awareness to action, and we have heard a lot about how this pertains to the determinants of health, and particularly the socioeconomic determinants as drivers of disparities. Multiple speakers have talked about how we identify and understand what these determinants are. We've heard from Cancer Research UK about income, work and education, and collecting data is critical to understanding disparities. Our trials panellists talked about the impact of ethnicity and geography, but also the role of representation in trials and contextualizing our science within demography. And we've heard extensively about racial and ethnic disparities across the cancer care continuum. Beyond that, we have expanded our knowledge past the traditional of what social and economic determinants means. Habib Naqvi at the NHS Race and Health Observatory and Keith Richards from Prostate Cancer UK talked about trust as a determiner of access to care. And our panel on mistrust and misinformation highlighted some very poignant points in areas of mistrust in the media and as part of traditionally held beliefs. Our panel on awareness to action talked about knowledge and how this empowers patients. And Faye Ruddock shared meaningful insight in the importance of culturally competent care as a key determinant of health. As we transition from awareness to action, we have heard some amazing examples of implementing interventions to reduce disparities. From our Vanessa Moss Prize winners, implementing culturally sensitive interventions and working to bridge the gap, and from our colleagues in the pharmaceutical industry on the importance of integrating equity into everything we do instead of treating it as an add-on. In our session on clinical trials, Tural Gathani talked about implementing policies that mandate equity, such as the Athena Swan Directive, which helps bridges the gap between funders and researchers. And Tariro Kaba from Gilead spoke about making valuable educational resources required learning to advance progress. We've also come back again and again to the idea of health system strengthening at the heart of improving cancer care, like the work done by Dario Trapani at ESMO, the work done by City Cancer Challenge, as well as Margaret Poe's emotive narrative on the role of primary care as the vanguard of the health system and the importance of investing in our front line. Kulveer Singh said to us earlier today, disparities are lived realities, and we have heard from the patients who have been generous enough to share their stories to help us center the patient at the heart of the work that we do. Today we have had speakers from Mexico, Ghana, Italy, Belgium, the UK, Nigeria, India, Indonesia, Saudi Arabia, and those representing diaspora communities from China, the Caribbean, South Korea, and more. London Global Cancer Week is special for lots of different reasons, but one of the most important is how it brings together people from across the globe who are committed to building a more equitable future for cancer care. Days like today reaffirm how much incredible work has been done and how much more we can go on to achieve together. I'd like to close with some thank yous on behalf of the London Global Cancer Week Steering Committee. We'd like to offer a heartfelt thanks to all of our speakers who have given their time, expertise and passion voluntarily, to the Vanessa Moss Prize judges who reviewed the abstract process, and to Aruni for his help and work in organising this, to Mercy Afua who helped put all the slides together, Being Lou who coordinates our financial progress and the rest of our management team, eCancer for their support of the Vanessa Moss Prize by publishing the top 10 abstracts and for being down in London to conduct interviews today, Oncadaily for their continued collaboration, support and amplification of the voices of London Global Cancer Week on social media, the sponsors of today for making this day possible, Novartis, AstraZeneca, Lilly, Gilead and Roche, Susie and Katie as our co-conveners of the week who create a bigger and better programme year on year. We're so grateful for everything that you do. And Bookie for her tireless work to organise the programme, saw all the logistics and still have the unbridled enthusiasm for all the work that she does. To Neil and Sarah for all of their help with the logistics today and in the lead up to the event. And a big thank you to every one of you who gave your time to attend today, in person and virtually, who contributed questions, enthusiasm and thoughtfulness. I don't know if while you've been sitting here, you've had a chance to look up the ceiling above the stage, but you'll see the epigraph, "To thine own self be true," which is a quote from Shakespeare's Hamlet. Bookie talked earlier today about leveraging your superpower, and I want to leave you with this thought. This community shows up with authenticity and genuine passion, and that is your superpower. You are unafraid of confronting hard truths, courageous about the challenges ahead, and committed to turning hope to action. London Global Cancer Week is what it is because of this community, so we thank you. So this brings the day to a close. We'd be very grateful if you could provide some feedback via the code that I think would be on screen. Yep, great. And we look forward to chatting with you all at the networking reception. Thank you very much.